1, 2, 3, 4. Hello and welcome back to day 2 of London Live Endoscopy. If you were one of the 1,600 who joined us yesterday, I hope you're back with us today. We've got a fantastic day ahead of us. The focus, the first half of the day is colonoscopy, all areas of diagnostic, therapeutic colonoscopy, really interesting data on performance and quality. And then the second half of the day, we're focusing on innovations. Where does AI sit in our practice, both now and into the future? Bariatric endoscopy. We've got a focus on therapeutic endoscopic ultrasound, and also a very clinically relevant section on the removal of foreign bodies. So just to remind you, there's a chat function. If you have questions that you want us to address, please send them through. There is an online feedback that we'd be very keen that delegates fill out to see what we're doing well and what we need to improve upon. But most importantly, have a great day, stay with us, enjoy, and I'm now going to hand over to my colleague Ed Seward to start the Colonoscopy Symposium.
So good morning and welcome to the first session of the day. We're going to be talking about diagnosis, how to diagnose polyps and dysplasia in the colon. We're going to do a brief review of where we stand as a nation in terms of endoscopy quality, and we're also going to be talking about the perils of missing polyps. We'll also have a session on alternative ways of looking at the colon and small bowel. So without further ado, I'm just going to introduce my stellar faculty. Across from me is Professor Matt Rutter from North Tees. I'm joined by Dr. Maria Parisi from Barcelona, and from UCLH, Dr. Joanna Parisi. Thank you. So we're going to go into the first case, which is looking at withdrawal in the colon. We're going to be using a Pentax scope, so we're going to be talking about the different eye scan modalities. We've got an endocuff mounted on the scope, so what does that lead to us in terms of benefit? And then we're going to be talking about the various different parts of the colon. So first case, 62-year-old male, it's bowel cancer screening patient, and he's got a past medical history of thromboembolic disease on River Oxaban. We're going to be using a Pentax I-20 scope and the Olympus endocuff vision.
So this lady's symptoms have improved since she had her CT and MRI, and she's had some liver function tests this morning, which showed a bilirubin's normal and only slightly elevated ALT. So we've started with an endoscopic ultrasound to confirm whether her small 5mm stone is still in the bile duct before we go on to do an ERCP. So we're now...
Okay, so apologies for that. That is the beauty of live TV, of course. So we're just going to line up the thing that you really want to see, which is colonoscopic withdrawal. So just to remind you, 62-year-old bowel cancer screening case. And what we're hoping to demonstrate is use of the endocuff and also the various modalities that eye scanning leads us in terms of polyp detection.
And whenever you're doing a withdrawal, I'd always suggest you use the correct modality. And in case of the Pentax scope, we've got iScan 1, which is the device that allows you to enhance surface tone. And basically the idea behind it is it highlights the differences that polyps represent. So you get these very nice, clear images, well demarcated. And I'll just go through the iScan modes just to give you some idea. So that's iScan 2. iScan 3 is what we use to interrogate the polyp and decide how to characterise it. And obviously we're looking at a adenoma there. And then we've got one there, and you've probably already seen this one as well here again, which again is clearly an adenoma with type 4 fits. So that's all quite straightforward. And obviously we've got the ileocecal valve coming in here, and always of note is you can just have to be a little bit careful when you're looking at the ileocecal valve not to misinterpret it as a adenoma, because the changes you get, the sort of the villus change that you get relating obviously to villi can be a trap to the unwary, and although it kind of sounds an obvious thing, sometimes it can be difficult to differentiate the two. So we'll just come off iScan 3 now and go back to iScan 1, our detecting mode. Now, in terms of withdrawal, the critical thing is to make sure that you are cleaning properly and that you're getting good mucosal views. So we've got another larger polyp here. So this is going to be a hot snare. Good, so I've got back to about hepatic flexure, so I'm going to go back in again. So I go all the way down to cecum, and then I have a second look. Can I get you back on your left now, please? So gentleman turns to his left. And I'm going to have a second look in the right colon. There is data for this now. Interestingly, there was I think a Chinese study which demonstrated the benefit of a second look. But this is something I've done for some time. And what you'll see is we're using the endocuff to kind of scrape the alveolar folds aside. And what that allows me to do is have a look in between them and also look at the backs of them, because it's quite easy to miss polyps on the back of folds. There was a vogue for retroflexing in the right colon. Some people still do that. Tiny adenoma I missed there on the first pass. 8 cm. Okay, so I'm coming back to where I was at the hepatic flexure. Just sucking through again, so the guys can retrieve the polyp. Don't worry if it doesn't come up, it's just a tiny thing. Okay, and then we're coming back to the hepatic flexure now. So, sir, can I get you onto your back again, please? Would you mind? Thank you. So, when I'm looking at the transverse colon, I look at that in supine, so right colon I look at twice, one in left lateral, one in supine, and then in transverse colon I'm supine all the way. And what you'll see, if you look at my left hand, I've got my thumb wedged between the big wheel and the little wheel of the pentax scope, and that gives me that fine movement. And that allows me to nick in between the folds, keep a quite a happy, well-distended colon, gives you better views. And then my right hand, which of course you can't see, I'm talking. Talking movements with your right hand is they're the larger movements, so that will move a colonoscope like this. Whereas the fine movements you get with your left thumb. And I'm just coming back, and if I feel like I can't see and there's just a little bit of hemoglobin around, as you can see, you're just washing that out, sucking it out. I always tell my trainees, your foot should be on the pedal, the water pedal continuously, just to make sure you're not missing anything. One big advantage of the scope I'm using today, the i20 scope, colonoscope, is it's got a very wide range of angle of view. It's 210 degrees, so the idea is that you have a better chance of sort of sitting around the corners and making sure that you're not missing anything. Could I have another Turner Buscopan, please? So bowel is just scrunching up a bit. You can probably see the folds crowding in there, and we really need to work as hard as we can to keep those open. in case you're wondering, this gentleman is anticoagulated for thromboembolic disease, not for AF. For people with AF, I still do use Buscopan, but not as my first choice. So I try and I don't give it routinely, whereas anyone, usually when I'm doing colonoscopy, everyone gets Buscopan. But sort of people with ischemic heart disease, AF, I tend to be a little bit more circumspect. Touch wood, I've never had a problem, with any sort of rate-related ischemia, but of course you never quite know. So we're beginning to approach the splenic flexure. I always say that splenic flexure, to me, is the most dangerous part of the colon. It's really easy to miss polyps here because you have that turn. So you need to make a point of looking at the floor, looking at the ceiling, and I go in and out on a splenic flexure. That's really important, I think. And you're using your endocuff to kind of stroke out the folds, make sure you're not missing anything. So look at the bottom, look at the top. That's good. If you're not seeing somewhere well enough, get your scope stuck in, really have a good look. Make sure you're not missing anything. The greatest predictor of the presence of a polyp, and there you go, we're rewarded. I think we can probably cold snare that off, Rennie. So another adenoma here. So this is splenic flexure. So that's very easily missed. That was tucked into a sort of nest of folds there, and it was only apparent when we gave it a shove. So that's a good learning point, really.
So coming back from the splenic flexure, I have quite a low threshold for moving the patient into right lateral position. Really depends on the quality of the views. So you can see we've got really nice views here, but you will see fluid that creeps in from the left. And if that begins to become bothersome, sort of like it is now, then I'll just move the patient. And we don't move the whole of the patient. If you just bring your left shoulder over towards me, sir, that's it. Just bring it over towards your left, and you can see what happens is the fluid drains away into the descending colon, and that just improves your views a little bit. So we stay in this sort of semi-right lateral position as we're coming back, looking at the left-hand side of the colon, and really this is where the endocuff comes into play. So you can see most of the prongs of the endocuff now holding the sort of descending and sigmoid sideline. Oh, we've got a polyp there. See that? Just another small adenoma there. So we'll use a cold snare on that. And as we continue to come back, really nice views of the sigmoid colon with the endocuff. And it's usually about distal sigmoid that I'll get the patient back onto the left-hand side again, just to have a look at the very end of the sigmoid and the rectum. So we're beginning to get a bit of fluid coming in again now. So we're just going to turn patient back onto left. So you just go back on there, sir, and then the views will remain pretty good. We're sucking out all the time. We're blowing carbon dioxide in just to get good views. So we're now just about to come into the rectum. Always have to be mindful of the fluid pool you always get in the rectum that can hide polyps, but usually you get a pretty good look at it on the way in. Actually, I should say I have retroflexed already. I always do my retroflexion at the beginning. That's more comfortable for patients. So I'm just going to deal with this fluid pool, have a final look. Just in the distal rectum now, and we've got one final polyp there that we've just seen. under white light, it looked hyperplastic, but we'll just get confirmation of that using iScan 3, and there's a cystic change that I would expect with a hyperplastic polyp, so that's fine. So we're going to come out now, and the examination's complete. Thank you.
Yeah. Great. Well, I can't tell you the sense of relief that we have to talk about a colonoscopy video and not an EUS video, so that's very reassuring. Matt, that was, I would think how one withdraws is quite a personal thing. So you tell me, what would you do differently, or do you have any comment on your sort of tips and tricks for withdrawal?
Yeah, I guess the first thing I'd say is that when people are learning colonoscopy or performing colonoscopy, they tend to focus on intubation. That's the bit that stresses endoscopists. But it's the extubation, it's the inspection where you really earn your money. This is the bit where you potentially are going to save a patient's life. So it is important to get it right. I think the first thing that we always teach our trainees is to slow down. And we know from evidence from many studies that we need to be going slower, at least 6 minutes. But from our bowel screening data, the optimal time is at least 10 minutes. So going slow is the first message. And then beyond that, it's making sure you've visualized the mucosa. And during the video, you demonstrated quite a few excellent techniques, so position shifts, re-intubation. So I don't routinely re-intubate the right colon, but what I will always do is if there's any slippage or if there's an area where I think I didn't quite see that, irrespective of where that is in the colon, I'll go back in and re-inspect that particular area. So extubation isn't just pulling the scope back, it's re-intubating and re-inspecting, and that's how best to use your 10 minutes of time.
Great. Yeah, absolutely. Maria, do you have anything to add to that?
Yeah, I think that there is a point that goes with what you were commenting, is to have a very straight scope. Because it's if you don't have, so that's where intubation is also important, because you need to have a good technique of intubation to reach the cecum with a straight scope, because that is where you can control on the withdrawal. So that's why everything is linked, no? So and then in my case, if I see it's possible, I do retroflexion in the right colon as well, especially depending on the scope. Some scopes are more flexible. So you need to know what scope you are working and the patient as well, but I like to do retroflexion whenever I can.
That's interesting. What's your sort of pickup, would you say, with lesions on the right then by retroflexing?
And there are several studies that show that,
Sure.
that you can increase it, but you can also increase it with the double inspection of the right colon. So probably one thing or the other are equivalent. And as Matt was saying, it's not all about the right colon, because very often in the sigmoid is where you can also overlook lesions, so you also need to go back to that part several times. So it's not all about the right colon, but it's true that in the right colon sometimes you jump, so you really need to make sure that you have done it properly. And for that you need to have a good control on the scope. So I suppose that this is something that we give for granted, but not everybody has that under control, no? To reach the cecum with a straight scope and be able then to control what you are doing while you are withdrawing.
Yeah. I mean, Matt, I mentioned on the VT, for me, the splenic flexure is the bit I worry about most. And I make a point of going in and out and checking the roof and checking the floor, if you like, of the splenic flexure. What are the danger areas for you in terms of the colon?
Well, I think you're right. Particularly if your technique doesn't involve asking the patient to move during the procedure, and if you're using propofol, of course, that's more difficult. If you leave the patient in the left lateral, then when you pull the scope back into the distal transverse and the splenic flexure, the lumen will be collapsed.
Yes.
You don't get good views. And it is important that you counteract that. And you can insufflate, but that can take time, and you can end up with an uncomfortable patient. The more elegant technique, which is the one that you were talking about on the video, is to rotate the patient. So I ask my patient to move supine or even a quarter turn to the right in that area, and suddenly from the collapsed lumen, everything pops open again. You haven't had to insufflate, you have a comfortable patient, and you've retained your views or re-established your views. So I'd agree, splenic flexure. And as Maria, as you were saying, the sigmoid is the second area because it is all concertinaed. By the time you're extubating, I think you have to go particularly slowly, and it's a dynamic technique. You have to flex the tip of the scope in between the folds to really maximize the view in that area.
Terrific. Hold all those thoughts because we're going to go to the next case now. So we're just going to bring up the slides. So we're now going to switch to inflammatory bowel disease. What we want to be able to talk about is the recognition of dysplastic lesions in inflammatory bowel disease, the importance of recognizing villiform change in the context of IBD, and the benefits of advanced imaging techniques such as MBI. So our second case is a 40-year-old. He's got extensive ulcerative colitis. He's on actually 12-weekly ustekinumab. He has had previous dysplasia, and as is so often in the case, there's this to and fro discussion about surgery, having a panproctocolectomy, and understandably people are resistant to that. He has had an ESD in the past for low-grade AIN, and so this is his colonoscopic surveillance procedure. We're going to be using the Olympus 1500 scope. So we'll go to VT.
So we're just in the cecum here, as you can see, and I'm just going to do my biopsies just to record the level of activity, but it's all very quiescent here on the right colon. We're doing the whole of the withdrawal under MBI because that gives us much better chances of picking up dysplasia, and you can see we've seen a polypoid structure here on the right hand side, and the telling thing about this polyp is that it's sort of long and wormy looking. And if you look carefully at the pits there, you'll see that the pits look very much like the pits in the surrounding mucosa. And this is a inflammatory pseudopolyp. Nothing there to be concerned about. And I'm very happy leaving that in situ with that very characteristic morphology there. Just coming back into the ascending now, and we're picking up another polypoid structure. This time it's more sessile, and this is where you begin to think, well, could this be an adenoma? If it was an adenoma, it looks sporadic to me. It just looks like it's sat on top of the mucosa. The pits would potentially do for 3S pits. Looking at it, it can be hard sometimes. So if I'm in any doubt, I'll take it off. A really small polyp like this, probably only a millimetre or two in size, I'm happy using cold biopsy forceps. So we just try and get onto it there, slightly fiddly position here, and we're just going to close, just close it. Just missed it, just going to have a second go, and there we've got it. So it's off, and you can be happy that that's been removed entirely. So we're just coming back here now, and you can see the mucosa is becoming a bit more atrophic under MBI. You can see this is where there's been active colitis previously, and we get that sort of patchy atrophic change. And just here now on the sort of towards the left, now I'm centering it and washing it off. And this is an area of sort of hypertrophic mucosa. These are commonly mistaken as dysplastic areas. Look how bland it is under MBI. If you have a look at the pit pattern, it doesn't look like anything nerve-wracking at all. It's got these sort of slightly, almost sort of crenellated, wavy pits. That's it under white light. Back to MBI. This is all very reassuring. Now, it is okay to biopsy these things if you want reassurance. Obviously, make sure they go in a separate pot, just so you know what you're looking at. But this is very reassuring and not a lesion I would want to be concerned about. So we're in distal sigmoid now, and we're just picking up a lesion on the left-hand side. And the first thing to say about it is if I just go to near focus, you'll be able to see we've got branching pits suggestive of adenomatous dysplastic change there. This is very distinct from the hypertrophic lesion I was looking at earlier. you can see this looks much more like conventional adenoma. Quite distinct margins. It's a sessile lesion, just going on to white light there just to show you the difference. Much better appreciated obviously in MBI, and it's not particularly dark under MBI, unlike most adenomas. So this is visible dysplasia, it's sessile, just to use a scenic language, and I'm just going to biopsy this lesion. This gentleman has widespread dysplasia on previous colonoscopy, and I just want to prove that it is dysplasia that's going on there. Now there, look, we're looking at the proximal border of the lesion. You can see it's quite indistinct. It's going into another area there. So I'm just going to do a biopsy, really just to prove what I think it is, and that will allow me obviously to grade the severity of the lesion. Again, we're looking at those tubular branched pits there, telling us this is all dysplasia. I'm just going to get my biopsy forceps out a second time. We're just going to push down into there, just take another bite. You can try and resect these things, of course, and this is perhaps something that we'll debate afterwards. Really, ESD is the best way of managing these lesions in a colytic length of colon, because the fibrosis will significantly impair any MR attempt. So that's visible dysplasia in the distal sigmoid. So you can see we're at the anal verge now, and as we're looking at very striking difference between the squamous mucosa and the rectal mucosa, and you can just see an abnormality there, which is most striking, but on the way in we saw other areas, so I'm just going to go around the circumference of the anal verge, and what we're looking for are areas of villus change, or the sort of branching pit-like pattern that we saw earlier. So look, there we go. So you see those branching pits that tell you that there could be an area of dysplasia, and again there we can see more abnormalities, but it's most striking here, and this is this is what we see when we talk about villiform change. So this is dysplastic mucosa, and you can see it looks for all the world like a very sort of villous polypoid area, and on this occasion right next to the anal verge, and we're going to need to biopsy this just to demonstrate dysplasia. It's fine to biopsy next to the anal verge. It can be sore, of course, so you just need to warn your patient that it's just going to be a little nip, so just bear with me, sir. Just going to open the forceps, and then just going to close, and just going to pull it back in a second, and just there we're going to pull back, and that's fine, well done. And I'm going to take a second sample now, so again just bear with me. So what we're going to do, we're going to open up the jaws of the biopsy forceps, and I'm going to just drop my tip, going to push into the mucosa where the villiform area is, and then we're going to just close the biopsy forceps there, and then we're just going to pull back. So that's villiform mucosa at the anal verge.
Okay, great. So we thrive on debate and controversy in London Live, and we've been having a really interesting panel discussion while that VT has been running. So Maria, I'm going to go to you first. Describe what the scenic guidelines tell us in terms of how to, when we're discussing dysplastic lesions within the colon, what sort of language should we be using? And then give me your opinion on how to manage this patient.
Yeah, so the point is that at the end we will use very similar, the same description, very similar to when we are looking at sporadic patients, but it's slightly different because here, as you know, some of the dysplasia will not have totally the same shape as we have in the sporadic situations, and sometimes lesions are more flat, more subtle. But at the end, we try to have a very similar way of describing them, and with the patterns, like with the Kudo patterns and the different patterns of dysplasia, and with the shape, the Perez classification. So it's quite similar, but a little bit different. But the idea is that many years ago, we used to say, we used to use like a different way of talking in IBD, but at the end, the lesions are very similar, so we need to do quite a similar way of describing them, let's say. And it's curious because we were talking that this patient has had several times dysplasia in several parts of the colon, so he is at high risk for having a cancer. But the lesions were quite well circumscribed, so some people will try to want to tag them endoscopically because they look like endoscopically resectable, no? So which is the point, the crucial point, if we can treat them by endoscopy or if we think that they are too much subtle and difficult to treat. So, and this is where it's quite controversial and it's nice to discuss about it. So I don't know what is your feeling about those things?
Yeah, I think you've described it very well. I mean, for me, this is a young patient, 40-year-old, who's had multiple dysplastic episodes. His colon is demonstrating itself to be highly unstable. The term we tend to use is field cancerization here. So yes, we can focus in on the lesions and we can probably manage each of those lesions individually, but his lifetime risk of developing cancer, post-colonoscopy cancer, an interval cancer, is very, very high. And I think you have to step back and think of the patient and the overall situation. And for me here, the right option is a pan-proctocolectomy because of that overarching risk. So yes, we can deal with the lesions, but we're slightly missing the point about what's going on in the whole of the colon here.
Joanna, he's your patient. Are you going to send him to Barcelona or are you going to send him to North Tees?
I would suggest a surgery as well.
Okay.
And I think we shouldn't forget that these patients are high risk because he's my patient. This is a patient that has had very active inflammation in his colon for many years. So it has been very difficult to actually get on top of his disease. After the third or the fourth treatment, actually, the disease responded. So he's a very high risk patient.
Okay, so 1-0 to North Tees. That's good to hear. Joanna, we're going to stay with you and we're going to launch your presentation. What are you going to be talking about, Joanna?
So I'm going to be talking about the role of colon capsule or panenteral capsule endoscopy in different care pathways. So I'm going to present 3 very different cases, which I think they're very interesting, very different. And people can vote about what they want to do. And then we can discuss while we're watching the videos. So straight away to case number 1, 22-year-old male. He was referred via his GP, by the lower GI to weak weight pathway. He has some recent change in his bowel habits, some loose bowel motions in the past few months. 1 episode of fresh red rectal bleeding, which has not happened again. GP tested him with a FIT that came back low positive at the level of 15. No other medical history, no family history of note, no medications, and never had any bowel investigations. So what would you do? So would you go for a 2-week wait colonoscopy? He came via the 2-week wait pathway. A routine colonoscopy, you consider this patient of low risk, nothing, discharge back to the GP. CT colonography, colon capsule. Ask the patient what they would prefer amongst all these options. Please vote. And while the audience is voting,
Okay.
What would you want to do? Would anyone send this patient for a 2-week wait colonoscopy?
So just to inform the panel, so the poll is running now in the background, so we should be getting those results hopefully in the next minute or so.
How old was he? How old was he?
22.
22. Oh, that was missing.
There's certainly a very good question to ask about whether you should be doing a FIT test in a 22-year-old, and that would certainly be my first criticism.
Yeah,
it's not an
fair
option,
enough.
sadly.
Yeah, the patient is already with us. And he has some symptoms, nothing, no frank diarrhea, no bloody diarrhea, nothing very impressive in terms of symptoms, but he is in our clinic. He would like to do some sort of investigations.
For our international audience, when you have a 2-week wait patient, what that means is the GP has a high suspicion of cancer and you are obliged to investigate them, or you have to speak to the general practitioner and explain why investigating them is a bad idea. Now, I've just had the results through in my ear, which is really hard to talk and listen at the same time.
Yeah.
So 42% of the audience have opted for a routine colonoscopy.
Yeah, okay. And that's the majority, I suspect. Yeah, okay, thank you. So these are some interesting facts. So the top is missing, but that's fine. So essentially, this is a study, the first one that showed that the prevalence of significant pathology in young patients that have a colonoscopy is very low. And we're not only talking about advanced adenomas or a bowel cancer. So this is a study with 450 patients where 85% of the colonoscopies were completely normal. And when we're talking specifically about advanced adenomas or significant neoplastic lesions in general, the prevalence is obviously even lower. So this is a recent study, 13,000 patients less than 45 years of age. The prevalence of significant neoplasia was 5%. And also we know that according to the FIT levels that you have, you may have a high risk of having advanced colorectal neoplasia or not. And in this study that they assessed about 34,000 of FIT results, they found that even up to the age of 70 years of old patients that had a FIT that was less than 100 and did not have anemia, the colorectal cancer risk was less than 3%. So we know that the patients that have a FIT, the false positive FIT rate is actually quite high, and 50% or even higher, with factors such as female gender or the known presence of hemorrhoids being significantly associated with a false positive FIT. And in terms of the colon capsule data, so these are data from meta-analysis. Essentially, there are big numbers that suggest similar levels of sensitivity and specificity, especially in larger polyps. And in terms of the NHS pilot program, they are still recruiting patients in the colon capsule study in the NHS. Interim data from almost 2,300 patients suggests that the mucosal lesion detection rate is similar between the colon capsule patients and patients that were matched controls and had a colonoscopy, higher than in the CTC group. Similar with polyps, similar results between capsule and colonoscopy, higher than in CTC. And as expected, when we're talking about larger size polyps, then the three studies are comparable. Previous studies have suggested that indeed the CTC is better in identifying bigger size polyps. 70% of patients were spared the colonoscopy in the pilot, and even those that did need to go for a colonoscopy, half of them were downgraded to a routine pathway because they didn't have significant neoplasia. And the last point was missing again, but that's fine, because that it showed that 60% of patients actually were able to be discharged without any further investigation. In terms of patient satisfaction, as expected, patients that have a colonoscopy, they're more likely to experience discomfort, pain, or anxiety. And these are, again, data from the pilot program. Even CTC is quite uncomfortable compared to the capsule. And this is a small study where patients that had both procedures, a capsule and a colonoscopy, they would prefer to have a capsule in the future, even the majority of them, even though they would know that if something was found, they would need to have a colonoscopy also. In our experience, also patients that have had the capsule at home, that's another extra benefit that may make this procedure more preferable for the patient's point of view. So our patient was offered to have either a colonoscopy or a colon capsule, explaining the pros and cons of each procedure. So he opted for the capsule procedure that was normal in the end. And while the video is playing, may I ask a dear panel, Matt, what do you think? Would there be any case that you would send anyone for a capsule? Would you think it's a useful test or not?
So I think the jury is still out. I mean, I think it's amazing technology. There's no doubt about it. And I think that there is potential for it to have large-scale clinical use. But I don't think we're there yet. And for me, there are a number of issues with it still. The first is that the patient still needs pretty aggressive prep, more aggressive than for a colonoscopy. Secondly, as you alluded to in your slides, a lot of people will need a subsequent investigation. So it's only 30% need a colonoscopy, but there's a proportion who also need a flexible sigmoidoscopy. So around half are going to need a second investigation. So that increases the cost and extends the timeline before they get definitive diagnosis or treatment. And then finally, the read time. it takes you a long time to read those the videos. I can do 2 colonoscopies in the time that it takes you to read 1 capsule. So maybe AI will get us out of that one.
Yes,
I don't know, but so potential, but I don't think we're there yet.
Yeah, fair enough. Maria?
So now in my hospital, we are now doing a study that is about to finish that started with COVID to using the capsule to prioritize the patients that were in the waiting list for colonoscopy. And so I see those patients in the outpatient very often, and when they had both experiences, so I can ask them. And it's true that having the 2 bowel preps is not very convenient for them, but it's true as well that you see that you can skip a lot of, that if you look at it from the other side, all those patients like this one that we were knowing that there will be nothing in the colonoscopy.
Yeah.
So of course, if you can really identify those patients, that could be a good option.
The important message I think is that it's not for everyone. It's essentially for someone that you think they're going to have a successful procedure that will be normal, and then they will skip the colonoscopy. So I think we should move to the next case, completely different, 19-year-old lady. She was originally referred to us when she was 16 because of diarrhea, delayed growth, anemia, and a very high fecal calprotectin. She had all the standard investigations, endoscopy, colonoscopy, and an MRI of the small bowel. Essentially, she was diagnosed with Crohn's disease, which was affecting her stomach, her duodenum, the ileum, and the colon. She was started straight away on exclusive enteral nutrition, anti-TNFs for her Crohn's. She responded partially, and there was some clinical improvement, but there were signs of ongoing active inflammation, so we had to change her biologic. She achieved clinical remission on the second biologic, on ustekinumab. Her CRP normalized, but she kept on having a very high fecal calprotectin. She had a bowel ultrasound for that, which showed an improvement in the small bowel and the colonic disease. Possibly some mild left-sided colitis was remaining. The patient was feeling extremely well, but the fecal calprotectin was still up to 6,000. So what would the audience do? Would they go for a colonoscopy? The patient is adamant that she will not have it under conscious sedation. She's 19, she would only accept GA. Would you go for a small bowel MRI? Would you do both? The patient has had panenteric disease, colonoscopy under GA and the small bowel MRI. Would you do nothing, continue same treatment, patient is well, the ultrasound didn't show impressive findings? Would you do a small bowel capsule endoscopy following a patency, or a panenteric capsule endoscopy following a patency? So you can vote.
So the poll is running. So I'm guessing, Maria, in Barcelona, you probably have better access to propofol.
We have 100% coverage.
Exactly. Yeah. So that's
excellent. It's okay. So we are covered. So in Barcelona, you would go for a colonoscopy.
I'm not so sure because why for? What do we want the colonoscopy for?
So this patient has a fecal calprotectin which is 6,000. What would you do?
But what will change with the colonoscopy? You know what I mean? Why do you need to?
So would you just change her treatment?
If the patient is okay and symptomatically and her blood tests are okay, why don't you wait a little bit? Why do you do the follow-up with fecal calprotectin?
Because we want to achieve control of the disease, not just clinical.
But to what end? How much time do you need?
So this was all in the presence of like 6 months and even longer than that. Okay. So she had ongoing raised calprotectins, and we suspect that there is some active disease, but we don't know the grade of the activity, yes, and whether we need to change the treatment or not. So I think, in my opinion, that bowel ultrasound was a bit equivocal.
Exactly, that's what I was thinking.
In terms of...
Because colonoscopy, I don't know, but I would think that probably it's not especially in the colon where the disease is.
The results are in.
That would be my...
Yes.
So the results are in. So 38%, Joanna, would go for a panenteric capsule.
Okay.
And 20% would go for a small bowel capsule.
Okay. All right.
So
this is one of the most important studies that has head-to-head compared the panenteric capsule with MRI, small bowel, and an ileocolonoscopy. This is in established Crohn's disease patients. And what it essentially showed is that compared to the two, the sensitivity in the whole of the GI tract was similar. When we're talking about the proximal small bowel, the sensitivity was higher in the capsule group, which is not a surprise. We know that capsule is superior compared to an MRI or a bowel ultrasound in the proximal small bowel. And when it comes to the TI, interestingly, the capsule was more specific compared to the standard group. And when patients were asked about their preference, 55% would prefer the capsule compared to having an ileocolonoscopy, which is the 36%, or even worse, having a combination of an MRI and a colonoscopy. Our data on 135 patients, and this is a mixture of established Crohn's or suspected Crohn's patients, showed that 23% needed to have a colonoscopy reflex in the end, but half of those 23% were actually new patients, so they were not established Crohn's disease, so they needed a biopsy, or some of them needed a polypectomy. But essentially, the planetary capsule led to a change in disease management in 75% of established Crohn's disease patients, and even half of the patients that were not they were not already diagnosed. And back to our patient, so she had a planetary capsule after patency, and you will see that she has active disease even early on, so we identified active inflammation in the proximal small bowel as well, and then moving further down, there is more active disease in the TI and patchy active disease in the colon too. So, Matt, what do you think? Any barriers you think, or anything or you think it's an interesting test to do? Or
I think it's very exciting, actually. It's not something that we can offer in our hospital at present, but a patient with inflammatory bowel disease has got lifelong disease. They're going to need to undergo a series of investigations during their life, and it is important that we minimize any discomfort or distress from those investigations. So this is a very simple, from a patient's perspective, a very simple technology that gives you panenteric assessment of their disease. So I really like the concept. I would agree with what Maria was saying before. In this patient, I think we probably had enough evidence, raised calprotectin, established diagnosis, just to change their management, change their medication. But that being said, I really like this concept for investigating IBD patients.
Yeah, I think there probably are advantages to localizing the disease. So this patient's obviously been known to have small bowel disease and upper GI disease, but obviously if the calprotectin was coming from a florid proctitis, for instance, then that would change the way you manage them.
And the other thing is that in the young patients, I think we try not to cycle through all the biologics very quickly if we can, because these are patients that come very early on. They have very aggressive disease.
Yeah.
So sometimes we may end up doing more often investigations because of this. Okay, I think we can move on to the next case. Completely different, 70 years old lady. She comes to A&E with palpitations, shortness of breath and chest pain. She's diagnosed with an NSTEMI and started on double anticoagulation, but a few days later, she experiences a GI bleed with melena and an HB drop to levels of 40 from 97. She needs an admission to intensive care. Her past medical history includes hypertension, COPD, and 6 years before this event, she had an OGD, a colonoscopy, and a small bowel capsule for a GI bleed, which had shown at the time a small bowel angiodysplasia. So what would you do? Would you just manage her supportively because she just had an NSTEMI? Would you do an OGD? And if that was normal, you would just support the patient, an OGD, and if that was normal, a colonoscopy, a CT angio, and if that was negative, support, a small bowel capsule endoscopy in view of the previous GI bleed from the small bowel angiodysplasia, or a panenteric capsule endoscopy. You can please vote.
So we would do everything.
Yes.
We would do an OGD and a
All of the
colonoscopy,
above.
and then the capsule endoscopy, no? I suppose because you would do the OGD and the colon would be
But
normal, and then you would need the capsule, eh?
It's hard, isn't it, when they've had a myocardial event?
Yes.
Yeah, so she just had it,
But for us not, again. As we do it with propofol, with the anesthesiologist, we don't have, that's not a problem anymore.
Would the anesthetists say anything? Would they be completely happy to?
They are completely happy. They said that the story of propofol and cardiovascular disease is just a tale.
Okay. So you wouldn't have, so you would do a top and tail OGD and colonoscopy
we would do
without.
as an implantation, top and tail, and probably then the capsule endoscopy, because I suppose that the OGD and the colonoscopy would be normal, and then.
Okay, that's interesting.
I mean, there is data for colonoscopy generating a stress on the heart, but it's interesting that was from conscious sedation and not propofol.
With propofol,
I wonder
that's
if
not a
you're...
problem anymore.
And I think there are a few studies that, most of them, as you say, they don't show any significant safety signals. But some of the patients have had more complications in the endoscopy group, but again, these are all very frail patients.
But even for example,
So results are in.
Yes.
Joanna, you're going to be really excited about this. It's a split between capsule investigation. So
Probably because a capsule session, I think.
do you think? So we've got 35% going for E, small bowel capsule endoscopy, and we've got 34% going for a panenteric capsule. You've obviously swung the crowd with the last case. So well done.
So that's actually very interesting because obviously this field is very new. There's not very much data around. There's a very small study that has been published by Musetto, who showed this strategy in 12 inpatients with a GI bleed who had a previous normal OGD. So instead of going directly for a colonoscopy after the OGD, going for a panenteric capsule instead, they had very good completion results, and the diagnostic yield was 83.3%. Our data, including 17 inpatients, they're a bit less impressive in terms of the completion rate. I'm actually a bit amazed on how they managed to prep those inpatients so well. So our patients have been difficult to prep. They're frail patients. They don't move around a lot. They have lots of comorbidities. But still, in 70% of the patients that had a panenteric capsule, a bleeding source was identified, and 82% were spared a colonoscopy in the end, with only 17% needed a flexi only. And I think the main challenge in this group, although it's quite fascinating to follow this pathway, it is the completion rate. So these are data from Professor McNamara in Ireland, where the completion rates between inpatients and outpatient controls that had a panenteric capsule are completely different. And unsurprisingly, the inpatients are older and they have far more factors for slow gut, more medications, diabetes, frail, immobile. But still, even in this study, the diagnostic yield was very high. 80% they found pathology. And this patient had a panenteric capsule. Stomach looked normal as far as you can see from the capsule, obviously. Proximal small bowel looked okay, and the colon too, but there was a non-bleeding ulcer in the mid ileum, which was not bleeding at the time, but could have been the source of previous bleed.
Terrific. How do you optimize the prep in patients? What are there tips and tricks to?
I don't think you get, it's already, as we talked about, it's already quite an intensive prep for a panenteric capsule. So I think the most important factor is to make sure that there's enough support. Because one of the problems we had on an inpatient ward, especially when we're talking about the boosters that the patient needs to take after they swallow the capsule, they will have alerts on the recorder. If there is a frail patient, they need to have a relative, someone who would be there to support them and to make sure they follow all the prep regime on time. So I think this is one of the challenges. It's having someone who is very on board to have this even on an inpatient setting.
Okay, interesting. So just as the VT is running now, I'm just going to introduce the next session, which is Matt's going to be discussing the lessons learned from the National Endoscopy database and what the current state of play is. And Joanna, thank you so much for a really interesting presentation. Thank you.
Thanks, Ed. So I'm going to be talking through the UK's National Endoscopy database, just giving you a whistle-stop tour through this. So if I can have, thank you, the slides on my screen. So NED was set up about 10 years ago by myself and a few colleagues, and it's in continuous evolution. The concept is that we automatically capture real-time endoscopy data from every hospital's electronic endoscopy reporting system. And at present, we have data inputted from over 95% of UK's endoscopy units. We're accruing 2 million procedures a year, and we have about 10 million procedures on the database. And there's a number of aims for doing this, and over the next few slides, I'm just going to illustrate some of the potential advantages. One thing that we weren't anticipating, of course, was the pandemic, and almost exactly 4 years ago, the UK went into lockdown, and it became immediately apparent that we had very little understanding of what was happening in endoscopy. We knew that units had been told to lock down, but we needed to have real-time information to see what was actually happening and to help units to recover. And it was immediately apparent that the National Endoscopy database gave us that information and facilitated that recovery. Prior to NED, we had no understanding of our endoscopy workforce, but now we know we have 7,500 endoscopists, a third of whom are consultant gastroenterologists, a third consultant surgeons, and a third are non-consultants, including 12% non-medical, almost all nurse, endoscopists. And that 12% delivers a quarter of all UK endoscopy activity. We know that the doctors struggle to reach their minimum annual number of procedures because of competing pressures within their weekly workload. And almost a half of all endoscopists fail to achieve minimum numbers of procedures a year. As well as improving on that, we also need more endoscopists. So through NED, we can monitor training activity. At present, 6% of our procedures are training procedures, and we have a target to increase that to 10%. We can also look at the patients that we scope. So this slide shows colonoscopy, and you can see that the major group of people in their 6th decade, and we can see why they've come for colonoscopy. And importantly, we can also see the outcomes. So this slide shows outcomes in terms of colorectal cancer yield, and we can identify high-risk patients and, perhaps equally importantly, low-risk patients for colorectal cancer. And when we analyse this, it's key that when we're predicting colorectal cancer risk, blood is the key, rectal bleeding, iron deficiency anemia, or FIT positive status. And without any of those, the risk of cancer is very low. But over half of our diagnostic or symptomatic colonoscopies are currently being performed on groups who have a very low cancer risk, less than 1%. So this allows us to identify opportunities to improve our clinical pathways so that we do identify the right people for the right test. We also use NED to monitor the quality of the endoscopy that we deliver. Prior to NED, 10 years ago, we did a national audit looking at 20,000 cases. It was a manual process. Lots of people spent a lot of time analysing that. But now we can do this automatically through NED. We looked at 600,000 procedures, and we can see an ongoing improvement in our cecal intubation rate, which is now 93.5% on average, a substantial increase in polyp detection rate, currently 37%, a halving in the rates of discomfort for our patients, and that's despite the fact that 30% of our patients now opt to have no intravenous sedation at all. I mentioned about the minimum number of procedures, and one question is, well, why have a minimum number of procedures? Well, this slide answers that, and we can see that there's a very strong correlation between the number of procedures that an endoscopist does a year and other important quality parameters: cecal intubation rate, polyp detection, comfort scores. As a side effect, if you like, of another study that we were doing, we noticed something a little bit odd. We noticed that colonoscopies being performed at a weekend had a lower polyp detection rate. Now, initially we thought, well, this will be due to case selection, maybe younger people coming at a weekend because they're working during the week and having less potential for polyps. So we did a more detailed analysis, adjusting for patient age, gender, and indication. And remarkably, that lower polyp detection rate at the weekend remains. So this is a cause for concern. We might have an opportunity later on in discussion to talk about potential reasons for that, but we're currently working on redressing this. We also use NED for quality improvement projects. So this NED Apricot project is about attempting to improve polyp detection amongst our endoscopists. And essentially, we created this entirely automated cycle. NED automatically captures the data. We analyze it automatically, producing procedure-adjusted polyp detection rates. And then we automatically produce the report that you can see on this slide, and that's emailed to every endoscopist every month. And in our randomized controlled trial, the group that were in the intervention arm improved their mean number of polyps detected. I mentioned before about trying to better select the patient who come for colonoscopy, and in our trust during the pandemic we introduced FIT testing for our non-screening for the symptomatic patients as well. And here on this slide you can see the before and after effect. So after introducing FIT, we have been detecting 43% more cancers per colonoscopy, more cancers a week, and we can use the National Endoscopy database to monitor the effect of any subsequent change that we introduce. So it's a whistle-stop tour, but hopefully I've demonstrated the value of the National Endoscopy database. It gives us greater insight into UK endoscopy. And this allows us to develop and support our workforce. It allows us to identify cohorts of patients and improve the efficiency and effectiveness of our service. And all of this is designed to improve the health outcomes of our population. Thank you. Now, I believe we're about to move to a case, a video demonstrating post-colonoscopy cancer.
So as you can see, we've just arrived at the cecum here, very clearly demonstrating the appendiceal orifice, and we've got a small polyp there just off to the right, sub-centimetre polyp. Always important to identify the landmarks just so you can confirm you've done a complete colonoscopy, obviously. I'm on iScan 1 and just flipping to iScan 3 there just to better elucidate the adenoma, and you can very clearly see the sort of probably 3L pits there on iScan 3. Just going to pop into the terminal ileum now. I always think the villi are seen probably best on either iScan 3 or MBI or BLI, depending on what system you use. So again, we're photo documenting just to get a good image there. We're satisfied then that we've done a complete colonoscopy, and I'm just going to come out of the ICV, and unfortunately this is the high-grade lesion we saw on the way in. Obvious 2C change on the polyp with some type 5 pits you can probably see there. I'm just going to go to iScan 3 again just to better elucidate that. And again, very high grade change, looks really unpleasant, and that's obviously grown up since the last colonoscopy. We're just going to clear it, tattoo the lesion, and then do some biopsy.
Great. So welcome back. So Matt, that was a really interesting set of data there that you're presenting, and amazing to be able to have that sort of insight on a national level now, which is staggering. What's going on the weekend? Do people get their coffee? Do they get their croissant and then they just kick back and relax? What's going on?
Yes, it's interesting, and to be honest, we thought that when we adjusted for procedures that the difference would disappear, but it doesn't. And there's a number of plausible explanations. A lot of the work that happens at the weekend is what we call waiting list initiatives or insourcing lists, trying to catch up with the backlog from the pandemic. The mindset, I think, behind those lists can be a little bit different for the whole team. So often, you have your list, you have your patients, and then when you're done, you can go home. So I think that psychologically there might be something going on there, that people just are less considered, aren't slowing down, they're maybe speeding up because they can see they can get home sooner. And for insourcing lists, for the international audience, this means an external team coming into your hospital to scope your patients. There's also potential, because they're coming into an unfamiliar environment, they might not be as used to the kit and the setup, so it may well be that they're underperforming because of that lack of familiarity with the setup. So clearly we need to do some more work, But knowing about it, I guess, is the first step in trying to unpick what's going on and allowing us to redress that.
Yes. I mean, Maria, the UK has a grand tradition of washing our dirty linen in public with respect to colonoscopy, and Matt's just one of a long line of people who've managed to demonstrate our weaknesses. Do you recognise the same issues in Spain, do you think?
So we are always looking at you in UK, because you have this long tradition and you have done this very nice job, and I think that that's what we would like to have. But the truth is that we don't have any system right now nationally, not even in the hospitals, that allows you to have this follow-up on the data. Only we have that for the screening program, but not for the general colonoscopies. So this is, I mean, it's crazy, because we have been wanting to have that for more than 10 years, and what happens is at the end we don't have it. So probably all the long tradition that you have to go through it, and then we still need to work a lot on that. I think that things have changed. Now people would be more willing or more ready to receive that kind of feedback. But we really don't have the experience as you have. So I can't say for true how people will take that with them.
You need thicker skins.
Exactly.
It's hard, but the VT showed the implications of potentially suboptimal colonoscopy, and there are obviously structural causes. So tell us, Matt, about post-colonoscopy cancer. You know, where are the lessons how do we learn the lessons of post-colonoscopy cancer to try and avoid it?
Yeah, it's a really good illustration of what goes wrong if you don't get the quality right. And I think there's a lot to be learnt from reviewing every case that pops up. So in our hospital, we have a system that identifies patients who have a post-colonoscopy colorectal cancer. And then we have a team of people who review the cases, just trying to see whether there is anything to learn from that case. Sometimes there isn't, but often there is. And the learning points can be very wide. Sometimes it's about the technique. It's about the endoscopy that was performed. But sometimes it's not. Quite often it's about the booking side of things. The clinician didn't recall the patient at the correct interval, or something happened, the patient didn't get the letter, so they didn't attend. There's so many things that can go wrong. So you do learn a lot from reviewing each case. And what we tried to do through the World Endoscopy Organization was to standardize the approach, to give people a toolkit for how you can go about that root cause analysis.
And you've given us some slides, so I think we'll just pop those up. So just talk us through what you're demonstrating here. Yeah,
so it's a little bit complex, but the documents out there that people can obtain online. But essentially, there's two ways that you can categorize a PCCRC, post-colonoscopy colorectal cancer. So the first is splitting it into an interval cancer. That's one that occurs in between planned tests, so planned colonoscopies, for example. So that's an interval type. And then you have your non-interval types. So this is a cancer that is identified when the patient comes for their next surveillance examination, for example. That's type A. Or if there's a delay in that next surveillance, then we call that a type B. Or if the patient doesn't have a planned next procedure, so their original procedure was to investigate symptoms, for example, then that's called a type C. So by subcategorizing like this, it helps you to get a handle on, are the majority of ours type C? Do we not have the right surveillance pathway? Or so on. So that's the first way that you can break it down into interval and non-interval. And then on the next slide, this is more colonoscopy focused. So this looks at the most plausible explanation for a missed cancer. So essentially, the first thing you do is to determine whether the cancer was detected 4 years post the previous examination or within the last 4 years. And then if it's within the last 4 years, you look at whether there's on the slide it says adenoma. We made a mistake there. Clearly we have serrated polyps as well. We should be thinking of serrated in the same way. Whether there's a an advanced lesion within the segment that the subsequent cancer was found, and whether that lesion was resected or not, and whether the overall quality of the examination was sufficient. Was the cecum reached? Was the bowel prep sufficient? So you end up with these 4 boxes at the bottom. Likely incomplete resection, detected lesion that was known about but wasn't resected, or missed lesion, either because the examination was inadequate or it was adequate and it was still missed. And 85% of lesions are because cancers are thought to arise because the lesion was missed. So that's the take-home message. Therapy is important, but actually it's all of this inspection, it's the detection, it's what we've been talking about this morning that helps to prevent the majority of our PCCRCs.
And how comfortable, because we've seen, particularly in scenarios, say in inflammatory bowel disease, where it seems that dysplasia can arise more quickly, there's a sort of frisson of anxiety about the word missed, and whether that's putting it onto the colonoscopist that it was there, you just didn't see it. I mean, is there any sort of defense in terms of, well, it's also the biology of the tumor, which might be more aggressive in particular circumstances?
Yeah, it's a very valid point, and I think it's important to stress that when you're doing the root cause analysis, you're not going in trying to apportion blame. This is trying to support the whole system and the whole service, and just to learn. And quite often, as I mentioned, it might be a booking issue or a patient issue. The patient DNA is their appointment. So it's not to apportion blame to the colonoscopist. And you're right, there are special cohorts of patients where we know that the cancer pathway is so much more rapid. Inflammatory bowel disease and Lynch syndrome probably being the 2 main ones. And in that context, it may well be the biology that stacks the odds against the endoscopist and so on. And that's fine. So people shouldn't think every PCCRC is due to a mistake. That's not always the case. But there's still learning opportunities, because if we're getting lots within a Lynch patient cohort, then we need to be doing something about that, changing how we survey patients, changing the interval, or using a different mechanism.
Terrific. I could talk about this all morning, but sadly the session is going to come to a close now, and we're going to move on to move from diagnosis to therapy. I'm just going to go through our panel members just to ask for 1 sentence, please. What's your take-home message for the viewers? So, Joanna, you're immediately to my left. What would you like to say?
I would say risk stratify the patients, think of the individual patient and what is the best test for them.
That's good advice. Maria?
So for the people that we are not in UK, I think that we need to have like a net system. We wish to have the way you are working, and we need to have you as an example and go in that way, because that's very important. And that we still always have field for improvement, and that's one of the good things about our job.
I suspect Matt is open to moving to Barcelona for a year.
Absolutely, absolutely.
Matt, final sentence.
You earn your money on the extubation. It's the inspection that's the key. Slow down, make sure your technique is dynamic, re-intubating if there's any slippage, and hopefully reducing the risk of PCCRCs.
Terrific. Okay, well, that's a fantastic note to end on. Thank you. So we're going to now go on to our 4th case here, which is how to tackle the smaller polyps. So what we're going to be looking for is the ability to assess polyp position and scope stability, and the relevance this has with small polyps. We're going to look at the benefits of lifting small polyps and the correct snare placement and manipulation of the snare on the polyp to achieve polypectomy. So this is a 66-year-old, again, it's bowel cancer screening, so FIT positive, background history of hypertension, high cholesterol, and a previous hip replacement. We're going to be using a Pentax I20 scope with a Pentax needle, the Boston Captivator cold snare, an Olympus SnareMaster hot snare, the Erbivio, and a Creo rotatable scope clip. Thank you.
So needle out and inject. Keep injecting, don't stop. Okay, needle back. And I always tend to inject the small polyps because I feel I have a better grip with the snare afterwards, and I feel more confident that I don't leave any polyps behind, any polyp tissue behind following the polypectomy. So open, and I open the snare and always place the proximal bit of the snare on top of the polyp, and then I'm putting pressure towards 7 o'clock and do my own cut. Suctioning, always successful if you put the suction channel that is at 5 o'clock on top of the polyp, and I flush the scar just to inspect the site. Okay, and needle out, and I am in a bit of an unstable position, so I'm gonna try to inject proximal to the stalk of this small polyp to help shaping the stalk to have a better access. And you can see I had a bit of a struggle to reach this area because the patient has a loop bowel. I'll inject a bit more proximally, needle out. Inject, keep injecting, and I go with the tip up just to shape the stalk. Okay, I'm advancing the snare, and it is useful to have the area that you want to target at 5 o'clock. That is where the accessory is appearing in the screen. And now I work quite closely. I think I have the polyp, and then I use endocut, a blend, and cut. Okay. Always inspect the post-polypectomy site immediately. Don't worry about the polyp you removed. That can be taken care after. I can see there is a little bit of ooze of blood, so I'm gonna place a small clip because, as I said, the intubation was slightly challenging and you don't want to have to come back because of an uncontrolled bleed, delayed bleeding afterwards. So again, the same principle, the scar at 5 o'clock. This is a rotatable clip from Creo Medical, and I usually ask the assistant to rotate sort of a 2 to 7 for me. That's it. And now tip down to put pressure, make sure I get the area that I want, then close and deploy.
Right, welcome back. We've mixed the panel up, and I really should be saying hola, because I'm joined by three, not one, but not two, but three Spanish colleagues. I've got Rosa Vega, UCLH's own. We've got Adolfo Parablanco from Nottingham, and Maria has kindly agreed to stay with us. So, Rosa.
Right, so very exciting new section of this colon symposium, and I'm very honored that I am here with these colleagues that I share love to our mother country, as well as love to colon blobs that we constantly remove. So in this section, we are going to see and progressively move towards complexity in terms of lesions that we may encounter. And as you have seen in the first video that we just demonstrated, it's basically small polyps. And I always feel and tell the trainees that come to my list that they shouldn't feel less important because we let them tackle small polyps and only progress to larger polyps when they feel a bit more confident, because I learned a very big deal on tip control, on interrogating pit patterns and all that on small polyps that allowed me then to progress to much more difficult situations. And there is a little bit of controversy of what should we do with the small polyps. Should we lift to be able to get them a bit better with our snare? Should we just chop them with a cold snare without really bothering too much about lift? Do we need to be concerned about bleeding? And I am a true lifter. So I lift everything because it gives me a bit more confidence on the delineation of the margins of the polyps, and I feel it gives me a better grip on the cold snare to be able to do an en bloc resection. But some other people in my department are more non-lifters. I'm not looking everyone else. So I don't know, for instance, Adolfo, tell me, obviously you do a lot of fancy stuff, but you are also doing, a lot of small stuff. And I think it's always important to keep the attention to detail on the small polyps. So how do you approach them? Tell us any tips or tricks. So if there are any trainees that are on this phase of their training that are tuning in, that they can grasp.
I don't want to talk too long like these elder guys, but I was remembering recently I was talking to a colleague about how we used to treat small polyps in the past, 25 years ago, when I was training in Japan, that we used energy. We used the hot biopsy forceps, that now it's practically forbidden. Last time I used a few years ago, I had a complication, in fact. And then we moved to cold biopsy forceps, that we know that we leave a part of the polyp behind. And then we embraced cold snaring. I have to say that initially, I'm quite open to new technology or new techniques, but I was not very convinced because I like to burn so that you could destroy whatever was around. And it was a colleague from Oviedo, Dr. Gonzalo Diaz, a very good endoscopist. He was really very keen in the cold snaring. So initially I didn't like it, but then I loved it, as most of the polyps nowadays are removed with a cold snare technique. And that's what we use for most non-pedunculated polyps, less than 10 millimeter at least. We can talk later about bigger polyps. And something that I noticed, especially if I work with a nurse that I haven't never worked with, is that they believe that I'm removing too much normal mucosa around the polyp. And there's a reason behind is that we know that if we just try to get the polyp itself, the resection is more frequently incomplete. So I try to get enough normal mucosa around that we know it's safe to resect. Of course, you have to take some normal mucosa, but if you have taken too much, then have to open your snare again and grab a bit less. But I agree with you that small polyps are so important. I would say you have to respect every polyp, every lesion, the large lesions and the small lesions, because they all belong to a patient, and you can always make a mistake in diagnosis and in treatment. Small polyps can have a cancer, even if they are less than 10 millimeter in size, even 5. So you have to look very carefully at the diagnosis, and then you have to be sure that you remove them with the best method for each polyp. And tip control is very important, and sometimes these polyps, I think, are more difficult to remove than bigger polyps, because you have to try to do it with your best technique. Stay close to the polyp, see the polyp well, place it at 6 o'clock in your monitor if you can, and grab normal mucosa around, and try to see how the snare is closing around the normal mucosa and how everything is happening, having good control of your tip. So I think they're very, very important polyps to get a good training. If you are very good at small polyps removal, you will be good at the bigger polyps.
So Maria, give us a bit of tips that you tell your trainees when they are at the very starting of their training point on polypectomies, and they face a small polyp. What do you think is important that you can pass on to them?
So the first thing I want to say, I am a cold snare lover, so I'm totally, and I don't lift either. I mean, just for very specific situations. And I wanted also to add a little bit onto that, because we have also the green endoscopy and the sustainability. So it is true that if we can avoid to use another thing, we have to think about it. I'm sorry, Rosé, but I wanted to say that. So as the other people you were saying, small polyps at the end sometimes are more difficult to remove than the large ones, because they go away and it's not so easy sometimes to have them in the correct position. So it's a good place where to improve your technique. I totally agree with you, and I think that this is important. And the thing with cold snaring is that it's different from hot snaring in the fact that you will try to have a distended colon because you need to have some tension on the wall because you are cutting through. So, and you need to be really parallel with the snare. So it's very important to use the tip of the scope with the big wheel to push it down. And don't worry about taking a lot of normal mucosa. It's much better to take a lot of normal mucosa than anything. So it's very important to have this flat snare on the polyp with a large rim of normal mucosa, and then close it and cut through and without any fear, because you are not using diathermy. So rarely you will go deeper than submucosa. But it has been described to have a perforation, even with this technique in small polyps. So the tip that I will add to what you have said is I always use the water pump. I always have my left foot in the water pump. And just after that, you use the jet there, and you will have like the submucosa takes the water or the saline, and then it's fantastic because then it everts the mucosa, and you can make sure that you didn't leave any adenoma or ulcerated lesion behind, and that there is no perf.
Excellent.
So that's
excellent
the
tip.
extra tip.
So we are going to move one step further with a bit of larger polyps. So before I'll present, so by the end of this section, hopefully you would appreciate the benefits of underwater versus insufflation in the sigmoid colon, where most of these large pedunculated difficult polyps appear. You will understand the importance of the stability of your scope during the polypectomy, and also understand considerations of post-polypectomy clipping once you assess the defect. So this is a 60-year-old female that again came through the bowel cancer screening program, had past medical history of bronchiectasis or orthostatic hypotension, bilateral. It was a bit of a tricky insertion because of the bilateral salpingo-oophorectomy in 2013. And what we are using for this case, you will see it's the snare master from Olympus. We are using the Pentax EC38i20, the RB Value 3 for the cryotherapy, and then rotatable scopes from Cryomedical. Most of the large pedunculated polyps always appear in a segment of the sigmoid colon in patients with diverticular disease, such as this one. So I find it quite advantageous to use water rather than air to have the space to remove the polyp. So there is a large pedicle, and with the water, hopefully, we'll be able to go ahead. So please pass me the needle, yes. And needle out. Inject, and I inject and shape the pedicle. Stop. Trying not to over-inject so that then I don't have room for maneuver. Okay, I am using the new I20C Pentax colonoscopes, which there is a very nice improvement in image quality. They have adjustable stiffness as well, so the ergonomics are very good for the colonoscopist. So I'm advancing beyond the polyp, open the snare and pull it open back into the channel, and I find this way I don't lose my position. So I'll find the head of the polyp with the tip of the snare showing, so I know where it is, and very carefully I pull out the snare, trying not to get the tip inside that diverticulum that we saw ahead. And now with the pedicle at 6 o'clock, I will bring the snare back close to me without closing to ensure we are in the pedicle and not catching the head. Okay, a bit more water to regain space and better view. I feel relatively happy, although I can't see the proximal bit And obviously being in the sigmoid colon, I am a little bit unstable. I may open and close again to make sure I'm not catching any bowel, but it's always difficult to be 100% sure because I am working in a bit of a tight space with some diverticulitis after me. Okay, cut. Good, so it's been cut, and I can see some blanching nets to the stalk, so probably the snare caught a bit of normal mucosa behind me. It is always very important to inspect the scar and the surroundings, so if you can prevent delayed complications, it's better. So because it's in the segment of diverticular disease, I will put some clips in that area just to seal the area in case there is a small diverticuli there that with the thermal effect may bring delayed complications. So clip please. And again, I'll try not to over-insufflate so I don't lose the position. Use water just to keep my position. Okay, the clip is a rotatable one. And again, I work quite closely, so I have a better control of exactly what I want to clip. The stalk is getting on my way, but first I want to clip this area. Because it's proximal, otherwise if I clip the pedicle, close and deploy. If I clip the pedicle first, the clip will get on the way to have a better view to clip this normal area. So that's why it's always good to have a plan. So that's the polypectomy site. So now, because it was a large stalk, and it's again a difficult segment to intubate, so you don't want to have a delayed bleeding that you have to revisit. Better to be safe and sorry, I will deploy a clip here. So passing the clip through. Okay, open. And I just rotate the clip 10 to 4. Again, using water, refraining on over-insufflating. I go with the tip down, make sure I grasp the scope, I grasp the scar of the polypectomy and deploy. And that's it. Right, so that's a quite interesting case, and we've been having quite a lot of offline discussion of how to manage this lesion. Obviously, all the large pedunculated polyps, or not all, but the majority, we always find them in that patient that has a challenging sigmoid, maybe because of previous hysterectomy, that has diverticular disease, that you see the polyp on the way in, and you are starting to think, oh dear, on the way back I'll have some difficulties, and how can I overcome the challenge? And obviously, as you have seen on this clip, I find that rather than using carbon dioxide insufflation, using the water to distend the lumen makes it better for the patient, because remember, these patients are on conscious sedation, so you want them comfortable and stable while you are doing the polypectomy. And also it gives you a better stability as well of the scope because of less angulation in the colon. But the space is narrow. Sometimes even in the best efforts, as you have seen, you may catch a little bit of normal mucosa. And I am always very mindful that I don't care about the polyp that has fallen off. I go to the resection base and inspect very well, because if any complications have happened that you realize on the spot, you can sort them out and patients do well. Whereas if you rush, get very excited about the polyp and don't inspect the site, then patients may come back with complications. So that's why it's really, really important. So Adolfo, give me a bit of tips or things that you were thinking while watching at this video that probably would be useful to the audience.
First thing is not particular about this polyp. As I told you, we could see this near complication today because you recorded the case. You don't know when complications are going to happen. If you don't record your cases, you won't be able to review the complications. So I think that's the first learning point, that we should try and record in the video our cases. Then sigmoid colon, frequently it's narrow with diverticular disease, and even if the head of the pedunculated polyps are not that large, it can be difficult to see the whole head and then circle the head with a snare. I think underwater is great to make the head float, to see the surface better, like giving some extra magnification. Alternatives are multiple. One of them that was described but not really analyzed very much in large papers is the volume reduction polypectomy, injecting 1/10,000 adrenaline, which I think we have all done, and sometimes it works very well, but there are some concerns about that. You can inject on the way in and the way back, see if the polyp is smaller. Second one, observing well, about grabbing the whole polyp. If you're underwater and you have to be close to your target as whenever you do a polypectomy, and see that you are closing the snare just with enough distance from the head to the stalk, leaving some normal mucosa in between. Because if the polyp is invasive and you have a pedunculated polyp, you want enough margin of normal mucosa, normal stalk from the invasion front to the vertical margin. So if you can, cut as much as you can, at least halfway through the stalk, so that you have enough specimen. Then, in order to prevent complications, I always try to put an endoloop, polyloop, because I'm very confident that if the polyloop is a detachable snare, that is not so popular, as we were discussing now. But if you manage to place an endoloop, you know that there's no bleeding is going to happen. But we are not so trained in applying the polyloop, the endoscopists and the teams, because they are not used frequently, maybe just when you have a particularly difficult polyp. But if you do it frequently, your team will be trained. So try to place a polyloop. If I can place the polyloop because it is quite floppy and the head is too large and the bowel lumen is narrow, one option is to do a polypectomy, just cutting the stalk. This is a bit more advanced, but we can cut with scissor-type knives, and it's been described, and it's a safe technique. Then, shall I go with the clips, or we talk about that later? No. Okay. And then, about that case, you showed that it was a near complication. There was a bit of burning of the mucosa, but you could identify it, and it was quite superficial. But for instance, I remember a case I had where there was a small proximal polyp slightly proximal to the pedunculated polyp. So I said, small polyp is innocent. Let's say, but we'll remove it later. Then I grabbed the large polyp, but then unfortunately the tip of the snare grasped the small polyp. And when I closed the snare, it looked as if it was okay, but then there was some burning of the place where the small polyp was, because I removed both of them in one go. So now what I do, if I have some smaller polyp proximal to a larger pedunculated polyp, I remove the smaller one first. Okay, so I sent it to a paper, but they didn't like it enough, or I didn't show it the right way.
Very good summary of tips, Adolfo, that I'm sure plenty of people are sort of taking notes in there. Let's move to another field of complexity of lesions, and we are going to present two cases back to back about adenomas or lesions in the appendix that we very often see. And hopefully by the end of this section, we will recognize the difficulties of appendiceal polypectomies. understand the importance of finding plane for lifting, that very often is quite difficult, the position tip of the snare above the polyp, and also avoid the snare slipping. And it's a 78 male patient that came because of iron deficiency anemia that was an anticoagulation because of a pulmonary embolism. Had a flexosigmoidoscopy that revealed a large descending colon, and then had a therapeutic colonoscopy to have this polyp removed, and on the completion colonoscopy, then the appendiceal polyp was found. We are going to be using the Olympus EZ 1500EL and the 10 millimeters cold snare captivator. And then the second lesion is a large appendiceal lateral spread lesion, and hopefully we will understand the use of BLI from Fuji scopes to characterize polyps. Also appreciate the benefits of the laser measuring tool that the Fuji system has. Also appreciate how important is the dynamic lift, and understand the benefits of cold snaring and soft tip coagulation. And that was a 61-year-old male that was newly diagnosed of a pheochromocytoma, had a PET scan that incidentally found an uptake in the appendiceal orifice, and then the diagnostic colonoscopy revealed the 25 millimeters LSTG. So as I said, we are going to be using the Fujifilm EC760S, the Olympus snare 20 millimeters hot snare master, the Olympus 10 millimeters snare master, and the coagulation and cauterization will be with the RB, and also some cold snaring with a captivator from Boston, and then clips as well from Boston.
So you can see quite nicely the adenoma in the appendix, and on MBI it looks reassuring in terms of pit pattern. So first of all, we're going to try a lift. Now, it's notoriously difficult to lift at the appendiceal orifice. It's really hard to find the plane, so we're just injecting in there, pushing in a bit further, and we're lucky there. We've got a really good plane there, so we can see the appendix is everting itself really due to the lift, and it's pushing the adenoma out like a cauliflower towards us. So that was very fortunate. So we're going to use a cold snare on the appendix. I always get a bit nervous about heat, just because of the risk of perforation. So we're going to hook it round, and as you can see, I'm pushing the snare in, and that allows me to get underneath the adenoma and just take a bite out. We're doing the whole thing underwater. As you can see, that just allows me to clear the defects, so I can see what's going on very readily. Got to watch out for the snare slipping like it just did there, because then you get inadequate cut, and you just scrape the top of the lesion. So we're going to be a bit more careful on the next cut, really pushing in. And again, you can see the undersurface of the adenoma. We're underneath that with a snare. Now really it's just a question of tidying up. As you can see, the lift has settled down now due to removing the adenoma, and I'm just taking the edges here, which I think are probably, it's probably just torsion of the polyp on the appendix. But it's always a bit hard to tell, and obviously better to play safe than sorry. And with a cold snare, you know what you're doing is going to be safe. So we can manipulate the appendix with the snare there. So we're just having a look inside, and that just gives me a little bit more information just to see what's going on, just in case there's any residual adenoma. And I'm switching to MBI there, and it's just on the left-hand side. I'm a little bit concerned, not really looking like adenoma if I'm honest, but whilst I'm here, I want to be as thorough as I can be. So we just snip that off and wash it away. And I think now what we're left with is a fairly satisfactory defect there. Not really sure how much is left. We might just tidy up that bottom right-hand side. There's possibly some 3S change there. So again, just place the tip of the snare above and just allow the snare to drop down, and then you push in, you ruck the tissue up so that you get good clearance. So I'm happy with that now. That looks okay. So that's a cleared appendiceal adenoma with good views there. That's reassuring. Thank you. So this is a lesion in the cecum, and we're looking at it with a Fuji scale eye scope, and this is a novel scope where we can bounce a laser to the left of the lesion, and then it puts up a scale, and this gives us an accurate assessment of the size of the lesion, which in this case is about 25 millimeters. You can also assess the area as well with this circular tool. So we're just switching to BLI to allow us to characterize the polyp, and you can see in Fuji language it's neoplastic, so it's a adenoma. Beautiful images there. We're going to start by lifting the lesion, and I'm using a standard mix here, and you can see I'm really struggling to lift up here, and this is quite common acting around the appendix. It's very hard to find your planes. This sort of lesion I've assessed as being safe. There are no concerning issues here that might suggest cancer, so I am happy, if necessary, injecting through the lesion to try and get my lift. So we're just trying to lift up there, and we're using what we call dynamic lift. I'm trying to pull the lesion up into the lumen of the bowel, and that gives me a better chance of being able to optimize the lift so that I can get onto the lesion. So that's the lift there, and it looks as good as it's going to get. It's sagging around the appendiceal orifice there. That's almost inevitable. I'm going to use a 20 millimeter is that, as you can see, just barbed there to allow me to try and engage with the tissue. So unusually, once this first piece is off there, now that's good. I'm actually going to try and go for the second lobe of the lesion now on the right. I'd normally go for consecutive cuts if I could, but this is just quite an unusually shaped lesion. The anxiety is if you take separate cuts, you can leave an isthmus of tissue. So just applying pressure there, that's off. We just push it away with the snare just to have a look at the defect there. I'm going to now tidy up with a 10mm snare. The 20mm snare is just too big for the remnant, so we're just going to apply, like we did, as much pressure downwards just to push into the lesion, and we tighten and it comes off there. So we just poke it out the way again, and we just try and do as much tightening up as we can with our 10mm hot snare. And once we finish with the hot snare, we're then going to switch to a cold snare. So just taking off a bit there, cut, that's good. Again, we'll just wash that away. So the rationale for using the cold snare is it allows us to bite into tissue much more effectively. And so you can see me just deploying it there. Again, I'm applying pressure and tighten, and we just wash it away, and that gives you much better grip against very sessile parts of the lesion. Now, it's not always perfect, so I'm again pushing as much as I can, and my snare is just skidding off this central part. That's where the fibrosis is, that's where the appendix is, and so in many respects I'm not surprised this is hard. So we are allowed to give up and switch to cold biopsy forceps. Now, this is often very unsatisfying technique for a interventional endoscopist because inevitably you're going to leave tissue behind. but we can't always shift everything. That's the difficulty with dealing with a complex lesion like this. You're always going to struggle around the appendiceal orifice. So we do what we can. So what I teach is that we clear as much macroscopic disease as possible with the cold biopsy forceps, so that you're left looking at as clean a field as possible. And then we switch to soft coag. So this is being done with a snare tip of the 10mm hot snare, and you can see what I'm doing is I'm not just buzzing the circumferential areas of the defect. I'm actually starting where I know there's a very high risk of recurrence. So I'm starting on that isthmus of tissue there next to the appendiceal orifice that I couldn't shift with my cold snare. Once I've targeted that, then you'll see me just going around the circumference here, and you can see the technique. You're just trying to do adjacent burns, and you're just looking for the tissue to fizz and bubble, which tells you that you're applying the heat damage to kill off any residual adenoma cells. So we just take it around the circumference so it's nice and neat, and you can continue to buzz any areas of which you think might still be high risk in terms of harbouring adenoma. So I'm particularly concentrating. And then what we need to do is just wash that up so we get a clear idea of what's going on, and just make sure. I must say that looks pretty good actually, that's not bad. So it looks a bit of a mess, but I am sort of reasonably happy with that, and that was a very challenging therapeutic procedure.
Excellent demonstration of how to tackle a very challenging polyp in a very challenging position. Tell me, we are going to change a bit of gears, not so much talk about the technique that you have demonstrated very well through the video, but tell me, how did this patient arrive to your list, and what was the whole journey of decision making to do what you did, basically? So do you have multidisciplinary discussions? Sure. Tell me a bit about that. How does it work?
Thank you. Yeah, Rosa. So when an individual has a cecal polyp, we want to know, does it involve the appendiceal orifice, or does it involve the ICV? Because then the endoscopic approach is very different. We're very fortunate at UCLH. We have a very strong polyp MDT with support from the pathologists, the radiologists, and the surgeons. And it's really important to get that multidisciplinary input. In this particular case, when we have a reasonably large adenoma sat right on top of the appendiceal orifice, I think it's always going to be a challenge for us as endoscopists to try and satisfactorily remove that lesion, because although in the first case we got really nice views into the appendiceal orifice, in this particular case that was always going to be challenging. And so even before we'd gone in, the MDT had made a decision that the surgeons were going to do an appendiceal wedge resection. So that's a standard appendicectomy, but then they just take a wedge of surrounding cecum, and that pretty much guarantees the patient that so long as you've removed the polyp in the rest of the cecum, they're going to be rendered completely safe and polyp-free. And that avoids all the morbidity and risk of a right hemicolectomy or a cecectomy, for instance. So really important that you go in with a very clear understanding of what are my endoscopic goals here. Am I going for 100% clearance, or am I going to clear as much as I can, and then I'm going to rely on the surgeons just to look after the appendiceal orifice for me.
Fantastic, and obviously that highlights the importance of multidisciplinary team with
Absolutely.
Different specialties to give the opinion and ultimately give the best to the patient. Now we are going to move, you already mentioned, TI and what do we do with polyps in the terminal ileum. So hopefully we will be able to recognize adenomas in the terminal ileum by the end of this section, which is always difficult because of the villiform appearance of the terminal ileum. Understand the difficulties of delineating the polyp and also the importance of clipping the defect on the small bowel, because the small bowel is quite thin. So we will see the case is a 74-year-old male with terminal ileum Crohn's disease on no treatment, so another layer of complexity, because probably there's some fibrosis in there, and also it's a patient quite frail. So we are going to use an Olympus EZ 1500, an Olympus 10 millimeters snare master, Boston 10 millimeters captivator cold snare, and cryomedical clips.
So very unusual situation here. We've got a adenoma in the terminal ileum in the context of Crohn's disease. And as you can see, this looks like a fairly conventional adenoma, sort of granular LST. So what we're going to do is we're going to try and lift it. Finding a plane in a small bowel, I always find a bit more difficult than in the large bowel, and that's probably just practice. And what we're trying to do is this dynamic lift. I'm pulling it into the lumen of the terminal ileum as we lift to try and raise the lesion as much as possible. So it's coming up very nicely. I could have marked the lesion beforehand, but this is reasonably well circumscribed. But this is always the anxiety in the small bowel, is that it's hard. It can be hard to spot the edges sometimes. So I'm going to take a 10 mil hot snare here. And usual rules apply. I'm going to start at the very edge of the lesion. I'm going to really carefully place the snare just on the edge of the lesion there, so I'm not dealing with the risk of recurrence at the edge. And we're just going to apply heat. So I'm using right colon settings in the terminal ileum just to take that nodule off, and we just push it away there. And then we go round the lesion as we would do normally in the colon, always taking care to do consecutive chunks of the polyp so that we reduce the risk of leading strips of tissue that then might run the risk of growing back in the future. So we're making reasonable progress here. Again, I'm happy I can see the edges of the polyp. So we're just going to push down nice. We always keep the polyp nice and close to the scope, and that really stiffens the snare and allows the cut to be successful. Otherwise, what you'll find is the snare just skims off the polyp. Time to tackle that left-hand side of the polyp now. So again, I'm pushing in, I'm sucking as I close the snare, and I'm advancing the snare as well with my right hand just to ensure that we get a good cut as possible. So that's looking reassuring. There is a little bit of superficial tissue there, so I'm going to go now with a cold snare. I'm using a cold snare because this is stiffer, and you can see it is hard. It is slipping off a bit, but I'm able to just deal with the remaining sort of macroscopic evidence of tissue there. Always a bit of venous ooze with a cold snare, nothing to be concerned about there. Obviously, this is a piecemeal resection, so it's at a high risk of recurrence. So I'm now coming back with my snare tip. So this is my 10 mil snare, and we're just going to burn the edges, not just of the defect, but also inside the defect, where you can very clearly see the cut margins. And you do as much as you can, as much as you dare, really, just to make sure everything's okay. And we're just going to then clean things up a bit and make sure I'm happy that that's all complete. Now, sort of unique to terminal ileal lesions, I biopsy around the defect, and I have been caught out in the past where adenoma extends into the villi. I can't see it, and so therefore doing biopsies just to make sure there's no persistent low-grade dysplasia is a way of reassuring me that I've got the whole lesion out. Once I'm done, I will clip the lesion up, really just because I'm worried about bleeding polypectomies in the small bowel. And that's all complete.
Fantastic. A very, very unusual polyp in a very unusual location. And we were discussing quite a lot here offline as well. And there are points that I know, Ed, you are presenting in a minute, a bit of a lecture on electrocautery. So I'm not going to touch upon soft coagulation that we've seen quite a lot over the last few videos. I'll keep it for your talk, so please, guys, keep here with us. But I would like to, for instance, ask Maria. One of the things that we were discussing is obviously small bowel is thin, so the risk of perforation is much higher, especially if you are using heat to cut the polyp. But on another hand, you don't want to have recurrence in such a difficult location to tackle. Have you consider to do maybe piecemeal cold snaring in this situation? What would be your thoughts of process while you are seeing this polyp?
So clearly here is a situation here of the duodenum where I would lift. Here I go totally with you. I think that lifting here is especially helpful for two reasons. One, for avoiding the possible complication of a perforation, but as well, it helps you to delineate a bit more the polyp because it's so difficult sometimes to distinguish the villus pattern of the adenoma from the villus per se of the small bowel. So this helps you very often. So lifting, I think, is very important. And then this is a very interesting question because especially in the duodenum, because of the risk of bleeding that is so high, and the bleedings in the duodenum are very different from in the colon. They can be really dangerous, let's say. So because of that risk of bleeding, I tend to go for cold snaring, but it is true that you have the downside of more recurrence. So I really don't know which is the best option. So mostly of the times when it's a lesion like the one that you were showing that is a little bit larger and a little bit more bulky, I would go for hot snare. Whereas if it's more a flat, like 20 millimeters, 15 millimeters, probably I would go for cold snaring.
Yeah, fantastic. And I think a key point message is that it's very important to understand your diathermy machine and the diathermy physics, so that if you decide to go for hot snaring, you know that you are applying the heat as safe as possible. So hopefully you, Ed, will highlight a bit the importance of that in a minute.
Can I interrupt just with
1 minute?
Okay.
30 seconds.
30 seconds. So if we have cold snaring, we're discussing for high-risk situations and monopolar cutting. But we are not considering bipolar snaring because we don't have bipolar snares in Western countries. In Japan, they have bipolar snares, which with certain studies have shown that the depth of the injury is less in the submucosa. So
Yes.
that's something that we should have available as well.
Exactly. Yes, yes, very good point, Adolfo. Now, Maria, we are very grateful that you are sharing a couple of very interesting videos with us of completely different techniques of how to remove large polyps. So the very first video is a video about a beautiful demonstration of full thickness resection. So I'm going to let you introduce the case, and we will watch you on the spot.
So thank you, José. So this will be a case on full thickness resection, and so we will establish what are the pros and cons and the main steps necessary to use it. So can we have this? So it's a 85 years old female with Alzheimer's disease in a starting point. She still can live by her own with her daughter, but she's having this Alzheimer's disease, and because of a persistent iron deficiency anemia, there was a colonoscopy that was requested. So here is the video. So we will see that lesion now with the video.
So here, we have this lesion that is probably a 15 millimeters lesion that clearly has a depression, and when we look at the lesion from a closer view in the ascending colon, now with narrow band and without narrow band, we can see that there are some distorted vessels in the middle of the lesion without a mucosal pattern, which is very suggestive of a JNET3 lesion, which will be an invasive cancer. So that's why we decided to do this treatment, an EFTR. And what we will do, the first thing, and very important, is to mark the lesion. You have to mark the lesion because once you are with the FTRD disposed, it's very difficult. The field of view is very reduced, so you need to have a clear view of what the lesion is. So these marks will be done with this probe that goes in the set. And it is important to do the marks a little bit far away from the lesion. Here you will see that the marks are a little bit too close. And so an important thing is to have the marks a little bit more far away. So then we go out with the scope, and what we will do is to prepare the FTRD disposable. For that, the first thing we will do is to have this wheel. Then we will use the thread retriever that we will put through the hand wheel, and like this. Once we have that, we will be able to pull the thread retriever. As you can see here, and wind it up in the hand wheel, and this will be connected, of course, to the cap with the clip that is mounted on the cap. It is very important to make sure that you align correctly the cap, making sure that it is aligned with the auxiliary channel of the scope, so you have it vertical. Then you will pull the cap into the tip of the endoscope, taking care of not making the clip to be released. And you will see that there are stoppers that will mark you until what size you have to pull this cap. You have to make sure that those stoppers are in contact with the scope, and that the thread retriever is vertical. Then you will have to put the sleeve, and the first step of the sleeve has to be done just in the tip, but in the scope, not in the cap. This is the first one, and it's important to put the corner like this to make sure that then it will be easier to retrieve it. You will put all the sleeve in the scope, depending on where the lesion is located. In this case, it is located in the ascending colon, so at least you will need to have 80 centimeters of scope with the sleeve. So you will pull all this sleeve, and you will put the tapes to make sure that everything is well aligned. You put the tapes every 20 centimeters, and then maybe you can put another one between 0 and 10. Then you have to go with this cap through all the colon. This is one of the difficult parts because, as you can see here, the view is very much diminished with this cap, which is 14 millimeters long. So then it will be also more difficult to go through the different parts. Once you are here you have the grasp that will go through the auxiliary channel. This grasp has to be open, so you are a little bit more far away than you are used to work when you are working in therapeutics because of the cap and because you need to have the space to open the grasp. And it is important that you don't target the middle of the lesion, because very often these lesions are very easy to have them broken. So it's better to take a little bit of a lateral part that you think that will be more easy to tight. And here comes a very important part. You don't have to grasp the grasper to tighten it, because very often if you do that, it will tear apart the tissue. And what you have to make is to make the wall and the lesion come inside the cap. And for that, it is very important to be patient and to do movements, torquing movements, and help the wall to come bit by bit with this elasticity and plasticity to come inside. Suction can be used, as you have been seeing, to help you to have this inside the cap, but you can never release the clip with suction, because then it could happen that you could involve a small bowel that is around the colon. So you just can use the suction to help you to make the wall to come inside the cap. And you have to do that patiently, as you can see here, doing these torquing movements, grasping a little bit also the tissue when you see that it is possible to make it come, and being careful not to tear apart this tissue that is not totally healthy. And when you see that this is coming up to the endoscope like here, then is the moment you can start releasing the clip. You will see that there is this white ribbon outside. That is the one that will show you when you are releasing the clip. You will make it turning out the hand wheel, as you will see now that the white, this white ribbon is going to go down, and you have to make sure that you are pulling the grasper, because the tissue will go down once the clip goes up, as you can see here. And then once you have done that, someone else is closing the snare and cutting with the yellow pedal. And this moment you have to be really coordinate between the nurse and the assistant to make sure that you have a full thickness resection, as you can see here, where you can see the fat and the muscularis that are totally here in the specimen. Then you go out, and then that's it. Histology, I don't know if they are...
Excellent demonstration of the case, Maria. And what I would like you to explain to us is, after having seen the video, is how difficult it is to train on full thickness resection, if it took you a very long time to learn. And also, if you could talk to us a bit about the importance of having a team doing it, because clearly you are not deploying it by yourself, and how important is the skill communication with the nurse in order to do it safely.
So I wanted to say that this lesion finally was a T1 with good prognosis criteria and with clean margins, so the patient was cured with this procedure. So the learning curve of EFTR is very short. It's easy. It's one of the easy procedures. There are 2 points that are critical that are more difficult. One is to advance with the colonoscope with the cap, because it's a long cap, 3 centimeters long, and the field of view is reduced and it's very rigid. So reaching the lesion can be challenging, and most of the times you spend the most of your time for that. So if you start, it's better to start with lesions that are in the left part of the colon, and to make sure that it's not in a sigmoid or angulated sigmoid, because this is one of the pain points to reach the lesion. And once you have reached the lesion, the other difficult point would be to include the lesion inside the cap, because you can't tear. You can do like tear. You have to make sure that it gets into it. So you'd have to do a little bit of torquing movements, be patient. But I think that this, you can have it quite quick. Maybe with 10 procedures, you really have it totally on your head. So and then the deployment and all the other part, it's really easy. It's like a banding. But it's true that you need to coordinate, because there is one person that will be with the grasping forceps, and the other one will be closing the snare and cutting. And you need to do that very quick and coordinate, because the moment that the clip goes down, it will push the tissue out. So you need to cut just in the moment to make sure that you cut the most of it. So this coordination, you need to talk a little bit just before starting the procedure, and in each step to make sure that everybody's coordinating.
Fantastic. Well, let's move on to another technique that you are sharing with us, that is underwater EMR, that it's becoming more and more popular among us. So Maria, just present us the case.
So yeah, so here you will learn about underwater EMR, and if we can see the case, please, the slide with the case. So this is a 52 female smoker with no family history of tumors that underwent a colonoscopy after a FIT positive in the screening program. So we have this lesion in the rectum that now we will see in the video.
Here we have this beautiful non-granular homogeneous LST that is located in the posterior wall of the rectum at 10 centimeters from anal verge. And we can see in LCI and now in BLI that the lesion has a villus pattern, but homogeneous without any part that is suggestive of invasive cancer. So although the lesion looks like benign, there is a small risk of having a cover cancer because we are in the rectum. So we will probably prefer to remove this lesion en bloc if possible. So what we'll do here is to fill in the rectum with saline We prefer to use saline to water because the saline, in case of complication, it's more physiological, and also because it helps more to have the conductivity of the diathermy. So it will take a small minutes to fill in the wall, because what happens with this water filling is that the mucosa will float into the liquid in difference when you distillate CO2, and this floating effect will make the lesion shrink. And as you can see now, the lesion doesn't look as big as it used to look when we were with CO2. So with this very simple procedure, as you can see here, we will be able to remove this lesion en bloc, and we will avoid, for example, to perform an ESD that is much more expensive. So here, what we are doing is that we are using the snare that we use in our department, which is a captivator snare, 15 millimeters is the one that we want. So of course, the lesion is larger than 15 millimeters. So let's see if we are able to have all the lesion included in this snare. Now we place the lesion at 6 o'clock position, as always, to make sure that we have a good control on the snare. And here, as you can see, the snare is smaller than the lesion, of course, but with a little bit of patience, we will be able to place the snare in a way that we will be able to include all the lesion, because the effect of the saline will help the lesion to float, and as you can see here, then bit by bit we will be able to include all of it in that 15 millimeters snare. Of course, it's very important to have the snare parallel to the mucosa, because it's the way that we make sure that we will have a good plane. We also have to make sure that we have a rim of normal mucosa included in the snare, and what we will do is to put the wheel, the big wheel, down to make the tip of the scope go down, to make sure that the snare is really parallel to the mucosa, and then we will close this snare. Then we will apply diathermy through the endocut, and you will see that it takes a little bit longer than usually to cut through, because the water, the liquid, doesn't let the diathermy to go through much through the tissue as when you are under CO2. Then we will cut through, as you will see here now, without any injection, and then when it cuts through, we can see here very nicely that we had all the lesion removed.
Very good demonstration of an underwater EMR, Maria. Congratulations about the video. And actually, one thing I've noticed that this a non-edited 3 minutes, 13 seconds video. So actually, when the underwater EMR goes well, it is very, very quick and very safe. So when would you choose to do an underwater EMR in comparison to the more conventional large field EMR? Yeah. What's the rationale? Why do you choose the underwater EMR?
One of the situations is like that one, when a lesion is a little bit larger than 20 and you want to have an en bloc resection. So this technique will allow you to do more en bloc, a little bit, expand the at least to 30. I am not so comfortable when it goes over 30. Some people do it, but I have to say that I am not so comfortable. That would be one indication. The other one, in the cecum and in the right colon, sometimes it really makes your life easier, because sometimes there are some lesions that when you inject them, they become, the tension that goes into the submucosa makes the lesion more difficult to be grabbed. So it goes in the other way that you would like, and especially in the cecum, where sometimes there is fibrosis in the submucosa, so the lifting doesn't go very well. So here it's another good indication for that kind of technique. And then sometimes in lesions that have a scar underneath that you know, for example, this week I did one lesion that someone else said there is no lifting opportunity because it's a recurrence, and I tried to lift it and it didn't work, so I went directly with underwater because there was no point in trying to lift it, but it was big enough not to do it without any secure path. No? So I think that these are, for me, my 3 preferred indications.
Yes, and obviously when we started to get trained on removing big lesions with a conventional large field EMR, we knew that we needed to put a very big cushion of lifting in order to push the polyp away from the muscle, so then it was safer to put the snare around. How confident do you feel without lifting when you are closing the snare that it's safe?
Yeah, this very good point, Rosie, and I suppose you have the same problem as I have, that have been doing conventional EMR in a very sequential pathway for a long time, so I really know in every step what I'm doing. And what happens here, especially for me, is that I don't have the blue mat after the cutting. So sometimes it's a little bit, for me, difficult to assess what is going on there, and I feel a little bit puzzled about it. But the truth is that the evidence show that it's quite secure. I mean, that we really can go through it. The problem we were commenting with Adolfo with underwater EMR sometimes is that you can have bleeding because the diathermy effect is different when you push into the endocut. The effect of the cutting effect goes faster than the other one. So, and as you are in the submucosa, you can go through a vessel with the cutting effect and you can have a bleeding. And this is cumbersome because you are in the middle of the water. So blood in the middle of the water is like you don't see anything, and then you really feel not so secure. That's why, at least for me, that I am a little bit conservative, let's say, of my being. I don't go for very large lesions with underwater because I don't like not to have this control.
Yeah, okay. Adolfo, tell us.
I would say that I've learned a lot from experts doing underwater EMR. And what I found is that in their groups, once they adopt underwater, they don't want to change to on air or with injection. So I think that people doing underwater, they do for almost every polyp that is up to 3 centimeters or so. I think it's very good for the indications that Maria said. I don't enjoy it particularly for polyps like very large LSTs with big nodules where the cut is not very clean. I think when you inject such polyps, you can see much better how you cut in a good sequence and make sure that you don't leave bridges of polyp in between. Whereas when you don't inject and you do underwater, I feel it's not so good. And also I'm quite careful about bleeding, as Maria described. And it's very important to communicate with the nurse how quickly they should close the snare. I think you have to take a bit longer to cut and to close the snare. If you close it very snug in the beginning, then you can have bleeding. And of course, you have to know that you have to use the yellow pedal, not the blue pedal.
Okay. So fantastic review of very complex polyps. We had an increscendo of difficulties and different techniques, which has been fantastic. And as I promised now, or Ed has promised me, we are going to have a fantastic overview of electrocautery that I think is extremely important if we are thinking of persevering on the management of colonic polyps and have an understanding so we can do it safely. So over to you, Ed.
Thank you very much, Rosa. So yes, we're going to be talking about, well, the talk is billed as electrocautery, but just to be clear, electrocautery is actually the wrong term. So it's actually electrosurgery when we're talking about use of snares and knives in the colon. So electrosurgery, high frequency electrical currents, attacking sort of biological tissue where the thermal effect is medically useful. Electrocautery is actually the term used to where you heat up a resistant metal electrode, and typically this is the heater probe that we're all familiar with. So we should be talking about electrosurgery. There's some really basic physics that you need to be aware of. In essence, you're putting a current into the patient, which is driven by the voltage. The resistance to the flow of current is what generates heat, and this is what generates the desirable therapeutic effect that we're looking for. And this diagram, and I need to shout out to Dr. Raju, he does really good YouTube talks on this, so I've lifted a lot of his images because they're so fantastic. And this demonstrates the flow of current from the generator through the snare, through the patient, and then back to the return electrode. If you've ever wondered why the return electrode doesn't heat up, it's all about surface area and current density. So obviously your snare is very small, so you get very high current density, so you get temperature going up. On the return electrode, it's very big, very large surface area, low current density, therefore no rise in temperature. Now, we touched on this briefly. Adolfo mentioned the concept of a bipolar snare, and you might be wondering what the advantage of that is. So a monopolar snare, so that's what we're used to using, in the UK and Europe, and you need a return electrode for these. So it's a flow of current from the polyp snare to the return electrode and then back to the generator again. In a bipolar situation, such as a coag grasper, you only have current flowing between one arm of the coag grasper and the other. This requires a lower voltage because you're only going through a small amount of tissue. That makes it a lot safer. And most importantly, you don't get interference with other electrical devices such as implantable defibrillators. So bipolar is safer, potentially you're using lower voltage. So this is what we're used to looking at, obviously, with the Irby. You'll notice it always says endocut Q. Just to give you a bit of background for that, the Q, you'll have noticed that a snare is shaped like the capital letter Q, so that's where the Q comes from. You also get endocut I, and you use those for knives or needle knife sphincterotomy, for instance, in ERCP. And really the 1 minute version of this talk is just use endocut Q. The guys at Irby have thought all these things through. They're very happy. You just press the yellow pedal and you go. But to go a little bit more in depth, it's important to be aware of the effect that the energy has on tissue. So when you're doing coagulation, what coagulation does is it actually causes cellular dehydration and protein denaturation, and that's what causes your coagulation. When you're cutting, the temperatures are going up to and above 100 degrees centigrade. The cells will boil, and that causes them to vaporize, and that's what causes cut. So there's a difference in the temperatures and, of course, then the voltages between the two modes. So although we talk about cutting when we're cutting, it's actually, you get a blend of currents. There are different stages within the cycle. So you get an initial surge when you're doing your initial incision. That causes a spark that allows you to cut into the tissue. You then have a brief cutting phase, which is very high voltage, and then the voltage falls, the temperature falls, and then you get that cellular dehydration. You get the coagulation phase before you ping into another cutting phase. And that's really important to know, because if you tap the yellow pedal, you're just going to constantly reset the machine. So when you put your foot on the pedal, your foot needs to stay on the pedal, and then that will allow it to go through the cycle of cutting and coagulation appropriately. Okay, so let's say you do want to know a little bit more about what the different numbers mean. Now, I've already said to you, just stick with endocut Q. It's fine. You don't necessarily need to know this stuff, but I think it is useful just to be aware of why they're there. So you'll see effect, you'll see cut duration, and you'll see cut interval. So let's talk about those one by one. So the effect refers to the coagulation effect. There's 4 settings. Setting 1, there is no coagulation, so you're getting pure cuts. Setting 4, you're getting maximum coagulation effect. It will often be set to setting 3. Cut duration does what it says on the tin. If you're on setting 1, you have a very brief cutting duration, so you're going to get a relatively slower cut, whereas on setting 4, you can see the cut duration is prolonged, so you're going to get a faster cut. And obviously there's dangers to that. If you're cutting through too quickly, nobody wants to slice through a large stalk polyp too quickly. And then finally, cut interval. So again, this is pretty obvious. This is the amount of time between one cutting episode and the next. So for a lower number, you can have very relatively brief coagulation phases as compared to the higher numbers. Right, just to talk a little bit now about the difference in coags. So I'm now switching to the blue side of the screen. You've got three options. You've got soft coag, forced coag, and swift coagulation. Swift coagulation, I want you to ignore. Your ERBI generator is not just designed for endoscopy. We don't use swift coagulation in endoscopy. Mostly when you're taking a polyp off, it will be under forced coagulation. And you can see from the diagrams to the left that that's relatively high voltage. You're putting a lot of energy in. Soft coag, and this is what you saw from some of the videos being applied, it's lower voltage. You're getting a slower cooking of the tissue. That's going to make it much safer to use. And you're usually using this for hemostasis or for trying to reduce your risk of a recurrent adenoma. We're just going to run a video now, and we've seen this already, but just this is me demonstrating the technique of using soft coag. Large sessile polyp has been taken off en bloc, a little bit uncertain about the edges, so all I'm doing is I'm going from position to position on the circumference of the defect, and what I will have asked my nurses to do is to switch from forced coag to soft coag. If I was using forced coag, there's a much greater risk of causing charring, the snare can stick, and obviously my anxiety is I'm going to be transmitting more energy into a defect, and that's potentially risky if you're on the right side of the colon. Just briefly to say, of course, it's not just about the generator. There are also other variables, such as your user technique and the size of the polyp that you're removing. Just a couple of points on this. In a large stalked polyp, you're going to potentially have large blood vessels going up the center of the stalk. It used to be a fashion that we used to give pre-coag, so we would switch the blue pedal, we'd burn a bit, and then we go on to the yellow pedal to endocut Q to cut through. Now, if you think about it, that makes no sense. If you're coagging just the periphery of the stalk, you're not going to tackle those big vessels. So makes much more sense just to use endocut Q throughout the polyp resection. The other anxiety is getting a counter burn on the opposite wall of the polyp. Now again, this is where we go back to current density. If only a tiny bit of the polyp is touching the opposite wall, then you run the risk of delivering energy to there in a high current density, and then you can get a burn which could result in a perforation. If a large amount of the polyp is touching the opposite wall, you get a broad area of contact, you get low current density, you get no damage. So if you're in a situation where you can't manipulate the polyp into the lumen, you're actually much better off ensuring that there's a broad area of contact of the polyp head on the opposite wall rather than just a little bit. So to summarize, endocut Q, very important, people remember, it's a blend of cut and coag. User technique is crucial for safe polypectomy, and my general advice is don't mess with the settings. This has all been thought through. Endocut Q is very safe, but I think it is important to know what the other numbers mean, just so you understand them. On the rare times you might need to adjust them. There is a teaching website run by ERBI, and they just asked me to show you this, so follow the link. And then what I'm going to do now is finish here, and Rosa is going to now talk about all things ESD. Thank you very much.
Right, thank you, Ed. A very comprehensive overview. So hopefully it's been useful to go through all that. And now we are moving to a bit more complex means of removing polyps, and I'm joined here by Professor Pradeep Bhandari. Thank you, Pradeep, to be here with us. And Ralph Bishops, that has been with us since yesterday, and we are always very happy to have you around. And Adolfo decided to stay as well, so it's very, very good. So In this section, we are going to talk a bit about colonic ESD, because nowadays it seems that if you don't reach the point of doing colonic ESDs and you consider yourself an interventional colonoscopist, you are sort of failing. And actually,
I don't think I agree with that, but yeah.
But everybody's, when you talk to the juniors that they are just starting and you ask them, what's your aim? I want to do colonic ESD. And I would like to have a bit of a discussion through a case, through some challenges that probably we have been facing through our journey on learning and performing safely colonic ESD, so we can have a nice discussion what is all that about. And the very first thing I would like to do is just very briefly, 5 minutes talk about why we should consider colonic ESD and when. So let me just see if I can pass the slide. So basically, why do we need to do colonic ESD? There are some lesions that we know that when we have the histology coming back, they show some surprises, because we have submucosal cancers, and if we remove them with our conventional snare techniques, that's not a curative treatment, especially these lesions where we have non-granular laterally spread tumors, or sometimes granular laterally spread tumors that are mixed type, very nodular, or lesions that we see with an irregular pit pattern. As you can see here, an example that I have circled, a very small polyp. It looked not very aggressive, but then the biopsies demonstrated there was a submucosal cancer on it. So we know that ESD is becoming more present in the arena of the different modalities that we can use to remove polyps, and the European Society of Gastrointestinal Endoscopy produced a guideline a couple of years ago that had been reviewed where ESD is appearing. And when would we consider to perform a colonic ESD? Well, on all these lesions that have suspicion of intramucosal cancer, and in the rectum if they are very large, mainly because of the risk of recurrence. And it is very important that we learn how to interpret and how to characterize these lesions in order to reach this type of risks. Therefore, we need to use our Paris classifications as usual, and use pit pattern classifications that give us a prediction of the possibility of submucosal cancer. Laterally spread tumors. Obviously, we've been presenting cases over the few hours this morning where we've been mentioning granular type, non-granular, granular type mixed. Why are we so particular about that? Well, we know that in granular homogeneous type, that would be the picture at the very top, the risk of cancer is roughly about 1%. However, if we have a mixed type, granular laterally spread lesion that we can see in the picture in the middle, that basically you have a component of homogeneous granular type and then there is a nodule at the top, then the risk of cancer increases to roughly 5%. So we should take that into consideration when we are treating it. And the non-granular, that would be the picture at the very end, then the cancer risk increases to up to 15%. So that's why in the new guidelines of treatment, these are lesions that could perhaps be considered for an ESD. The JNET classification has helped quite a lot in order to distinguish which lesions we could tackle endoscopically, even if we think there is a high possibility of high-grade intramucosal dysplasia or shallow mucosal invasion, and which ones we should leave for surgical treatment. And this distinction happens between the JNET type 2B and JNET 3. So basically, learning about this classification will help anybody to try to get into the algorithm of what would be the best way of tackling these lesions. And very often I get asked this question by trainees or maybe consultants about what is an ESD. And I just borrowed this vignette from this publication of my esteemed colleagues, Brian Saunders and Zach Ziamoulos, that I think represents very well the difference between an EMR and an ESD, or how an ESD should be done. When we place a snare across a polyp from the surface of the polyp, most of the times the resection is quite superficial into the submucosa, and we want to do that in order not to cause the complication of perforation. So very often we are quite shallow. Whereas when you perform an ESD, you should aim to peel off as much submucosa as possible, so be quite right above the muscle layer. So if there is a chance of submucosal invasion and is superficial, you are giving the chance to the patient to have a curative treatment. And you are going to see a video that it was a 2.5 hours ESD that I've done the very difficult task to try to condense it to over 15 minutes. And sometimes if you are not familiarized with ESDs, it's a bit difficult to follow the sort of the script of the movie. So these are very simple vignettes that I'm going to give you now to highlight the different points of the video that we have. So first of all, what we are going to do is, in this particular case, I'm going to use tunneling technique because I'm using the Speedboat Ultra Slim, and tunneling technique works very well when you use this device. So we will mark the lesion, first of all. Then we are going to do an incision on the proximal gate, so open a proximal gate on the oral side of the lesion. The next step is going to be opening a distal gate on the anal side of the lesion. And then once that's happening, I'm going to be traveling beneath the polyp, creating a tunnel until I meet the proximal gate I have opened initially. Once that's done, we will tackle one of the side circumferential areas, then we will move to the other side, and hopefully then we will have the lesion completely removed. So without further ado, please, could we just go to the video?
This is a lesion that is a non-granular laterally spread lesion in the mid-transverse colon, and a pat on the back on the endoscopist who detected it, because it's a difficult lesion. So today we are going to use as a device to perform this ESD, the Speedboat Ultra Slim. Creo Medical has provided with this new piece of technology that allows to perform endoscopic submucosal dissections, especially in the colon, pretty safely. So you have the Chroma platform here that will deliver bipolar radiofrequency for cutting and ablation, and then it also has the feature of delivering microwave for coagulation. So you can see how small it is. You need a partner in crime in order to do the dissection. So we work very closely with the nurses to try to deliver the dissection as safe as possible. You will see now coming out on the screen, so you can appreciate the dimensions a little bit better. The Ultra Slim goes down up to a 2.8 channel, so it can be used comfortably with slim scopes for upper GI work, and also fiber optic lesions in the colon if you need to go in. It has these 2 points of torquing device, and it comes with this shape that is this device with a golden blade on top. And if you do left up for me, Sheila, you can see the one-to-one rotation. The white rim bottom, just beneath the golden blade, is the area that is active for the cutting and coagulation. So it has, as I said, one-to-one rotation. At the beginning, a bit of training is required in terms of communication with the nurses assisting you, but very quickly you get used to it, and then we don't need to talk that much. So you can bring it in and out and make it as long or short as possible, depends on the area that you are scoping. And then the other feature that is different from the previous versions, like the Slim or the Speed boat initially launched in 2019, is that if you turn upside down all the way, you will see here the silver area that protects the energy to traveling through, so allows the speedboat to work very, very closely to the muscle layer, as you will see with the lesion that we are going to resect. And the needle has been eliminated, and instead, through a foot pump or manual injection by the nurse, you have jet to inject quite efficiently when you are in the submucosa. So we will proceed now with the marking.
I always mark it, and we are using the microwave function on the speedboat ultra slim, because the lesion is quite flat, is coming over two different axes of a fall, and by marking it guides me when I have the conical cap on it to have a better delineation. We are opening slightly the distal gate, so we'll be able to meet it through the tunnel. Right up a bit. Okay, device out. I'm injecting, and this is the proximal gate, and I have the muscle at 3 o'clock, the polyp at 9, and the blue segment is the submucosa. Right up, please. Okay, we have here a nice view of the tunnel, and we can appreciate the fibrosis that very commonly, let me just inject to get a bit of better space in the submucosa. Very commonly, as I was saying, the non-granular LSTs there is quite limited space to work, so we have to be very precise. Okay, device out, please, and left up a bit, yeah. Because of the protective hull that the device has, that allows me to rest. Let me coagulate. I'll inject first. Allows me, as I was saying, to rest the device on top of the muscle. That is this whitish segment that I have at 5 o'clock. So you see the muscle at 5 o'clock, the blue segment that is the submucosa. I'll coagulate this blood vessel with a microwave, and as you can see, There is immediate bubbling as a result of the microwave, but no charring at all, which allows a very good visualization, which is a fantastic advantage. Again, you can see we get the blanching of the blood vessels, but no charring, so we can have a very good view of the submucosa in such a fibrotic lesion. I'm just using the tip. And by using the tip, it makes it quite safe. I'm injecting again and slowly making my way through the tunnel. Right up. Good. You can see the vascularization of the polyp on top of the cap. That's why dissecting close to the muscle layer also avoids significant bleeding. Right. Very slowly, as the transverse colon is quite thin. And I'm trying to work quite close in the film. Okay, let's reassess where we think we are. We can see the change on the color of the polyp as we are dissecting the blood vessels as we progress. So we'll keep going a bit more on the tunnel, very slowly, injecting first, making my way through the tunnel towards the proximal gate that I opened initially. Just expanding the tunnel a little bit more on the right up, yes. And I keep coagulating the blood vessels as I encounter them before cutting. We're probably getting close to the proximal gate. Right, I'm coagulating with a microwave function, a large blood vessel bundle. So I'm gonna apply several cycles. I'll coagulate from the other side. And I probably want to coagulate a bit more as I can see the blood vessel is still active. So it's 5 second cycles. I'll cut a bit and coagulate inside the blood vessel to be a bit more effective. It's quite easy, you just change pedals from blue to yellow and yellow to blue. I'm just rotating to get better tension, coagulate a bit more. The muscle is at 3 o'clock, the polyp is at 9, and I have the submucosa vertically from 12 to 6. I'm cutting the blood vessel. Hopefully I have coagulated. Yes, good enough. So no bleeding and a good dissection. It's a demonstration of coagulation, pre-coagulation and cutting. Right, I'm applying some traction as the polyp is very flat and the gravity is not in my favor, so I put a dental rubber band attach it with a clip to the flap of the polyp that I created, and now I'm just deploying open and close, deploy. So I'm attaching the second clip onto the contralateral wall, and you can see the effect of tenting and with the help of the traction now I can have a better access to the side at the left hand side. That is an area that was difficult access before because the polyp is just mounting towards the vertical aspect of the fall. And with this traction I can have a better access to the area that is quite fibrotic again, and because of the change on the axis of the polyp it doesn't help. This area is quite vascular, so I'm going to try not to hit the polyp while cutting, and when I have a better access I will coagulate because I don't want to lose my submucosal space. Now probably is a good chance. So I'm giving one cycle of coagulation with microwave and continue cutting. And the traction helps a lot because it just moves the polyp away as I dissect and gives me a better space. Coagulate here, this blood vessel, and right up please. Right, so we have dissected quite a lot of the left side of the polyp, and now I'm tackling the right side and slowly progressing towards the proximal gate. And in order to get coagulating this blood vessel a better tension, I have again rotated the dynamic, and I have again the muscle at 3 o'clock, polyp at 9, and the submucosa vertically facing me, and that allows me to create tension. As I am using bipolar energy, I have to be in contact. Right, nearly finishing this area. It's just the last bit. The tension is not great now. Try to see how much I progress. need to change direction. Okay. That's better. And last cut. Okay.
Right, so here a very compressed ESD case that hopefully lots of learning points from it. But first of all, any overall comments about the case, Pradeep, that you would like to share?
I think first thing to say is that was a very good indication for ESD. I think these are flat, very difficult lesions and the risk of cancer is high in them. So I think it's a good case selection. And I really liked your plan about having a clear thought process at the beginning of what you're going to achieve. So making that cut on the proximal side, on the distal side, tunneling and opening it slowly, using traction when it is necessary. So to me, this is an ideal teaching case. So it demonstrates all the principles of ESD very well for pocket creation. So no, it's very well done.
And talking of which, obviously everybody that has trained in ESD, we all know how much gray hair we have developed on the process, because it's one of the most difficult things I have learned in the profession over the last 20 years, and with a lot of dedication and also physical sort of a strength that you need to be there and keep the concentration. Pradeep, you obviously have a lot of experience on ESD. You are a leading expert on the field. Could you just summarize a little bit your sort of a training journey through ESD?
Sure.
We've got 1.5 minutes, but how was it for any people in the audience that maybe are thinking, is this something that I should be offering to my patients?
Yeah. Well, certainly ESD has a big role, and I would say my training journey started when I had a lot of hair in my head. So back in 2004, I had all the hair, and you can see what happens when you do ESD. I didn't even gray, I just lost my hair. So I went to Japan in 2004 for about 5.5, 6 months. Unlike other people, I couldn't speak Japanese, so I couldn't get licensed to touch. So I was watching and observing for about 5 months. So I learned everything by watching a bit of animal work. And then I came back and started doing, at that time, knives were not available in UK at all. ESD didn't exist. So I negotiated with Olympus, and we used to get a few knives at a time, and we started with the help of Japanese support from there in terms of lesion selection. So to be honest, it was very unusual for me. I started with using combination of knives, IT and a needle type knife combining. The strengths of two knives work differently, but when used together, there is a complementary strength. And then using the snare. So my journey was to start with hybrid ESD, because to be very, very safe, when ESD doesn't exist in your country and you make a perforation, it becomes a big clinical governance issue. So you have to be very, very careful in your early days, avoiding that. So it was all about hybrid ESD till I started getting experts to come and supervise me. Every now and then, twice a year, we would have experts come from Japan for a week or so and watch me, help me. And that's how slowly. So my journey is very slow. My learning curve is very long. But it has helped me develop my own way of doing ESD, which is a little bit different from others. For me, the aim is en bloc excision. Doesn't matter if it comes with a combination of knife and snare. I have no pride to lose in that. That's how I work, is safe resection, timely resection, and en bloc excision. Doesn't matter what devices I have to use for that. And touch wood, so far, things have worked really well, and we've been very safe with no major issues in our service.
Okay. But clearly, it highlights how complicated it can be,
yes.
The access to training with ESD. Also, another aspect of the ESD is obviously during your learning curve, you need a lot of support. You are slow, And it's very often very difficult to convince your peers and convince the managerial staff in your hospital that this is something that can add value to your patients' outcomes and that you need support to learn through it. So Adolfo, I'm sure you also had your training in Japan, and we are not going to talk about that because probably Pradeep summarized it quite well. And when I talk to colleagues that have gone to Japan, it mimics a bit that. But could you tell us a bit when you decided to set up an ESD service in your hospital, the challenges that maybe you had faced, and any tips or tricks for anyone that maybe are thinking of setting up that?
So I have worked in 4 different hospitals doing ESD, where I had to develop it, in Tenerife, in Oviedo in Spain, in Santiago in Chile, where it was just starting, and in Nottingham. So it's always a challenge because first for ESD, you need your own training. Otherwise, you shouldn't start ESD. And I just have to add about the training that I think that the industry are extremely big support, because frequently the training comes in the hand of the industry, where they develop some training and with their own knives, which is very, very good. So I think you need the training, you need to decide how you're going to do it in terms of the setting, if it's in theaters or if it's in the endoscopy room. Ideally, you should have a proper sedation, a general anesthetic, and that's one of the limitations. You have to decide how it's going to be done. Be sure that you're in the right setting. Of course, you have to be in a unit where you can deal with immediate and delayed complications, so make sure that the surgical team is available and with expertise required. And you need to have a team, a dedicated team, also trained. Of course, the nursing team is very important. So you have to spend enough time and effort in training them. And you need some other colleagues, ideally, doing ESD, not yourself. Because the problem with ESD is that it seems to be sometimes like for non-humans, for supermen or superwomen. But it should be a service that could be sustainable. So it cannot rely on just the shoulders of one person. So you need a proper team with other colleagues. Probably you will train them, and then establish a team that can make it sustainable. And then you need to be good friends with the surgeons always, because we need each other. And in case of any complications, not just when the complication has happened, but ideally you should be in the right setting so that if you are doubting what to do, if continuing or not the ESD, when you face some difficulties, they could come into the theater and discuss the case. That's what we frequently do when these things happen. And then, of course, ESD, we saw the underwater EMR by Maria, or your ESD was late, but the underwater EMR took a few minutes. Same case by ESD would be more than an hour probably. So we have to see what's our capacity and our needs, because if we are able to do a few resections only, and we have many patients needing the resection, we may need to decide which of the cases will benefit from ESD. And there are some cost and economic studies from Australia and other areas where they told us that maybe you should only choose the more complex cases with higher risk of cancer, whereas in Japan, most of the lesions, large lesions, are done by ESD. So we have to understand our setting. In the beginning, we will have limited capacity, so we'll have to do the more complex cases, which means that probably they will be more difficult. So we have to be careful not to cause any complications. And then the problem is about the cost economics of this. And we need much more support because ESD is not properly reimbursed in public health systems. It is very costly. Apart from the training, the devices we use, the time spent in theater, the time the procedure takes, but it has to be seen more broadly, considering the reduced need for surveillance, the organ-sparing treatment. So there's much more work that we need to do. So I think we have to work with our endoscopy team, with our nursing team, of course, with our medical engineering team, so that they facilitate us to have a kit, come and test it or introduce it in our unit. And we have to work with our management team and our medical director so that they all decide what can be done and give the proper support. And then you have to inform the centers around you that you are doing the procedure, and so that they know that you can be a referral center and you can get the cases. So that would be some of the tips I would like to give.
Excellent. I found out, obviously, with all the bowel cancer screening programs spreading across Europe and in the UK, we had the bowel cancer screening program for quite some time now, 2006, and we dropped the age of starting at 55, and probably will drop it further. Very often we see lesions that they have suspicion of superficial invasive cancer in young patients in locations that perhaps surgery is it's going to cure of the cancer, but obviously will leave the patients with some consequences in terms of quality of life because of the lack of sparing the colon. So we are finding more and more lesions that would fall into the category of ESD as a possibility of the gold standard. But listening to you, Pradeep, or listening to you, Adolfo, it's still something quite complicated to master and maybe be offered to the population and not just to the patients that live next to a hospital of a very determined doctor that decided to go through all this training. So Raf, that's a question for you, and because obviously you have an overall view of what's happening in Europe in terms of interventional endoscopy and all that. What do you think are the main barriers in terms of training in ESD? For instance, in my case, I have never stepped a foot in Japan, even I wanted to, because personal circumstances, you have a family, you have young children, you can't really drop. It's not that you can, it's that you don't want this extra leg that we have in the double chromosome X, carry very strong genes that you need to be close to your little loved ones. So you can't drop everything and go 6 months to Japan. Not everybody has this opportunity. And then if you don't do that, it feels like maybe I won't be able to achieve a safe mode. So what do you think maybe needs to happen? What are the challenges? And in Europe, what do we need to do to put a plan together to make the training more available and make public health more understanding of what an ESD is, and then it can become more broadly available for the right lesions and the right indications? Tell me your thoughts.
Okay, thank you, Rosetta. So first of all, with shorter chromosomes, you have the same problem, basically. So just to clarify that. Well, I must admit that, for a long time, I've been like a bystander looking at these guys, say, what the hell are they doing, right? So why do we need ESD in the colon? And I think the good thing here, and why the constellation could not have been better than where we are now, to introduce this and to have a widespread of this technique for the right indications, as Adolfo pointed out. I think we're there right now, because thanks to the pioneering work of these guys, we know the safety of the procedure, we know the better indications, and that's where we are. So coming back to the barriers, I think the first barrier that you brought up, going to Japan, I think that has been taken down, just because of the very fact that we now have experts in Europe, like Pradeep, like Adolfo, like yourself, that can perfectly train people in becoming acquainted with the diagnostic features of the polyps, but also the techniques. So I don't think it's really necessary. It's good if you can. You certainly will beneficial. But it's not like when Pradeep started more than 20 years ago, where nobody was doing it here in Europe and you had to go there. So I think that barrier is gone. I cannot personally think of any country in Europe, including UK, where there aren't any experts in ESD who perform at a very high level with good indications and also with good skills. So I think that's a major advantage for people in Europe now that want to acquire the technique. I think the second barrier, I think is even most important, is actually what you raised in the beginning of this session. People saying, I need to do this in order to be good endoscopists. I think that's the complete wrong mindset. So the second barrier to overcome is to have the correct mindset for the people who are doing it. So if you're going to do this to prove that you're worthy as an endoscopist, that's absolutely not a good indication. So you need to take care of your patient, and probably if you say, I want to learn this, you need to have the dedication that Adolfo was alluding to. I think this, in fact, may be the biggest barrier for the widespread use of this technique, because for each of us who trained in these techniques and said, okay, now I know what I need to do, now I know which lesions need to be taken out with ESD, but now I need to learn it. It takes a long-term dedication. It's not something like RFA that you can learn in 2 days or 1 day. This is something that takes 2, 3, 4 years with supervised training, a lot of cases doing together, and that's also important for the safety. And I think that's indeed the largest barrier. So you need to find people that are willing, like people like Pradeep, you and Adolfo, that are willing to chaperone people for a long time period, but it also takes the dedication from them to come to your unit. And that's what we are doing now, for instance, in our unit, where we have like every 3 years, somebody new coming, and we have at this stage, we have 4 people who are doing ESD, and they can, slowly be introduced in the technique in parallel with also animal training. So you can take that down, but it takes a lot of dedication. And that comes then again down to the management as well. So you need support for that time. But that also comes with you as an expert unit. I think that you already have that in place. So the barrier of having, for the training at least, to have the correct staff, I don't think that's so big. So it's more the dedication of the person. And then obviously the third barrier, I think, is the number of people who are going to do this. And I think this is my personal opinion, so this is not an opinion from ESG or for me in the Belgian Society, but I think that in general, the mindset of most gastroenterologists, I think 80%, they're not ready to do this. So I think we need to look at the surgeons for this. So maybe at some point in the future, we need to have like what they have actually in Denmark in place, to really have a dedicated subspecialty medicine for interventional endoscopy, where this is really a common track and training. So, but that means also you need to get the basics right of endoscopy. So you need also to be able to do a basic high quality colonoscopy and gastroscopy. But I think we need to enlarge the pool of people that will be able to do that, so that you don't end up in your unit being the only one who is doing this, being able to do that. So I think these are the 3 barriers. So, but the last 2, I think, are the most difficult to overcome in order to get a widespread use. But I think it's happening. Like you say, young people are really motivated to do this. And I think not everybody wants to do this because otherwise they think they're failing. That's a good thing. And if they have the dedication and they want to dedicate time and they are patient enough to learn it, I think they will be able to achieve the skills. Well, there's some primary skills that you need. So some people will never be up for the job, I think. But those who put their minds to it and have technical skills, they will achieve it if they are patient enough.
Thank you very much. Guys, it's been a real pleasure to have this discussion with you with different aspects, and I'm sure we have brought a lot of light of what's coming next in the next 10 to 15 years with the submucosal space in the colon. So now we are going to move to another section. So it's a non-stop here in the Colon Symposium. And we would like to, Adolfo, you very kindly brought a few cases for us to discuss challenges post-resection, post-complications. So we are going to see, I think, a post-polypectomy bleed and how do we tackle it. We are going to talk about recurrence. So some different bits and bobs that we can see in the colon. So the very first case, would you like to introduce it?
Yes, I think there was a voice recorded there. I don't know if you're planning to...
The video, if you recorded the voice, the audio will go on. So just...
Yes, this is the ascending... Yes, this is a... I think it's the immediate. There are 2 immediate post-polypectomy bleeding.
Yeah.
So I think this is the one where there was a arterial bleed, not very high volume one, but maybe could we run the video and I tell?
Yeah.
This is
a 3 to 4 centimeter sessile polyp diagnosed in the ascending colon. Biopsy showed a tubulobilous adenoma with high-grade dysplasia and low-grade dysplasia. It was not clear if the polyp was sessile or subtrunculated, so after injecting with yellow fusing and adrenaline. Water was infused and the cap was pressed against the base of the polyp. Therefore, we could see that it is a subperangulated polyp, and it was cut underwater with pulse cut slow current. Unfortunately, there was immediate bleeding. Maybe the snare was too tightly closed, or it was closed too quickly. Anyway, different strategies were required to be able to identify the bleeding site clearly. That took 14 minutes. We changed the position of the patient and we used a purostat. Now the bleeding vessels can be seen. We have to grab them with a coag grasper, and what we have to do is to flush water. There's still bleeding. It means that we haven't grabbed the vessel in the right place. So we grab the vessel again and then we flush very small amount of water, and now the bleeding from that side stopped, and then we can press the blue pedal and soft coagulation to make the bleeding stopped. And then we flush again very briefly. We can identify the bleeding. We grab the vessel with the coag grasper. There's no further bleeding, and we can press the blue pedal again. That's the way how bleeds are treated with coagulation forceps. Now there's no further bleeding, and then the post-EMR scar has been sutured with 11 millimeter resolution clips.
Good. So quite a challenging bleed here. You spent 14 minutes and decided to go with a coag grasper. Any learning points?
Yes, so I was helping a colleague do the case, and as I say, it took 14 minutes from the moment when there was only a readout, only blood, to the moment where we could see something of the origin of the bleed. So it included changing the first is to be ready to deal with the complications before they happen. So we have to be sure that we have the right team, the right training, we are the right people to remove the polyp, and we have all the tools needed. If things go wrong, we have to be sure that we'll be able to deliver the treatment. So think of changing position, the water pump, know how to use the coagulation forceps. In this case, we use the gel to treat the bleeding, the purostat, which did help reduce the volume of the bleed. And you have to be calm. You have to work with CO2, of course, so that the patient doesn't get pain, because sometimes patients are tolerating the procedure quite well, but then when you have a bleed, you have to insufflate a lot, they get pain, and then you may have to stop. So you have to be sure that tolerance is good enough before removing the polyp as well. Okay. Some of the tips.
And I think you brought us another case. So yes, if you want to present the slides for us.
So this is another case where I did, this case and another one did change my practice somehow. Let's see what you think. Wow. So this is, and both of them happen in Nottingham. 71-year-old male with comorbidities, not on antiplatelet drugs, but did have a stroke and emphysema, had a change in bowel habit, had a raised fit, which is a good method to select the patients needing a colonoscopy, as we heard earlier from Professor Rotter. And there was a not very large sessile polyp in the ascending colon close to the ICV. So we used a high definition standard colonoscope, Olympus, HQ290DL, so it can be used with the scope guide. A plastic cap that we discussed the use of the caps. I do use the caps for EMRs. We injected yellow fusing, grab the polyp underwater, which I think helps see both sides of the polyps are being grabbed with the snare and snug, and trying to get an en bloc resection. A Boston captivator snare, 25 millimeter in size, and then we used, we'll see, clips and purostat and something else for the bleeding.
It's everything.
Okay. So
this is a case that somehow changed my practice, the treatment of post-polypectomy bleeding. This was a 2 centimeter polyp in the ascending colon. Sessile was injected and left underwater and cut. Unfortunately, there was immediate bleeding. The post-EMR scar was longitudinal, quite narrow, and there was a very evident arterial bleed from a very small vessel, probably 1 millimeter in size. So I did attempt to touch the vessel with the tip of the snare, but maneuverability of the scope was not happening in the proximal colon of course, if the scope is not stable or completely straight. For that reason, and as it looked quite simple to close the post-EMR defect with clips, that's what I decided to do. So I tried to be precise with the first clip. The blood is covering the polypectomy site. I could have changed in retrospect the position of the patient to have a more clear view. However, I was very confident that I would be able to close this defect. Doesn't seem to be very technically challenging. So you can see that there's like maybe a pocket has formed. See that there's a fold of the both ends of the polypectomy defect, and there's still oozing between the clips. The more clips I place, the more difficult to find some spare space to apply further clips. So my learning point here would be that if there's a very evident bleeding site that can be targeted easily with a more precise and accurate method such as a coagulation forceps, that's what I would attend if I had this case again. So I applied 14 clips and there was still oozing. The problem was that at the end there was a clot where I applied a Purestat. I believe that reasonably it stopped the bleed. However, of course, this patient couldn't be discharged like that, and I had to apply a pure hemospray on the bleeding site. I explained on my report that in case of early rebleed, within 48 hours, vascular treatment would be required by a radiologist. Luckily, there was no further bleeding and the patient was discharged 2 days later, but the hemoglobin level dropped from 150 to 92. Therefore, the bleed was significant. A colonoscopy a few months later found a post-EMR scar with no signs of recurrence, but unfortunately, the polypectomy specimen was never retrieved.
Right, Adolfo, thank you very much for sharing this video. I'm sure that I could see Matt that just joined us for this discussion, and also Pradeep was doing meaning we have all been there, right? That you see a very clear arterial bleed. You see, okay, a quick clip here. I'm gonna do that in 5 minutes, and just more clips appear and more clips, and then you put all the hemostatic agents that you have in your armamentarium, and everything becomes a little bit of a mess. So, Pradeep. Obviously, it's very easy with the retrospect.
Yeah,
but
that's exactly what I was going to say. Is in retrospect, you can be very wise, and you can see. And I've known Adolfo for a very long time, so I'm sure he wouldn't mind me criticizing him. I'm not criticizing Adolfo. I'm criticizing the technique. Yeah. We all know the best thing for bleeding is diathermy. But the diathermy carries the risk of perforation, so we go for other options. I think the option of clip was not a bad option here. I think because the polypectomy base was very small, and that's what made Adolfo think that I can close this very quickly with 2 or 3 clips, and he went for that, and not unreasonable. The only mistake that happened is that the clipping was done from a bit of distance from the polypectomy site. If you'd push the scope and the clip right into the base of it and grasp the muscle with it, job done. But when there's blood everywhere and your scope is a bit unstable, position is not sure, this is when this happens.
That was the problem, because I did try to touch with the tip of the snare, but I couldn't be precise. I think that it was not very stable, the scope, and that's another learning point.
Yeah, it is about access to the bleeding point. If it is not perfect, then it is a problem. But I think in retrospect, if you ask Adolfo, I'm sure he would say, I should have persisted and gone for a core grasper, caught the vessel, cook it,
and job done.
That's what I do now.
So basically what changed your practice was that when you see such a target blood vessel, rather than going with clips, you just coagulate with a...
Yeah, because in the past it's been successful in most of the cases, but you can always learn, of course.
Yeah, yeah.
Okay?
Absolutely.
Okay. Any things you want to add, Matt?
Yeah, well, I think we've covered most of the main points, but just to go back to what you said about the first video, that if you are going to be doing this type of therapy, it's important that the endoscopist knows how to deal with the potential complications that they'll come across, and that they're prepared, that the room's prepared, the staff understand where the equipment that you might need is, so it's all available. And I think that's key. And a lot of this is about the non-technical skills as well. You mentioned keeping calm. And it's fascinating if you walk into a room where a complication's occurred. And an experienced or a good endoscopist, there'll still be an air of calm there. They're in control. You know, something's happened, but they can manage this. You go into another room and there's shouting and everyone's talking across each other. And they're the rooms that we're concerned about. So the non-technical skills are important as well. The technical side of things, I think we've covered very nicely.
Yes, absolutely. And I am a true advocate of promoting non-technical skills. And also, I would say it is very important, for instance, the briefs before starting your lists, and especially when you work in big units with a lot of nurses with different mix of skills with them, to be absolutely sure that you know also the level of skills of the nurses assisting you, so you can titrate a bit how much input you need to give and so forth. And actually, if you dedicate 5 minutes before every list to run through the skills of people supporting you with the cases, making sure that all the devices that you can use are they all ready for you, and you preempt any possible emergencies, that things are set, I think that you are on a win there.
Sorry, that's the time to learn that you don't have the coag graspers in the unit. You don't want to be told that when you've had the complication.
Exactly.
Yeah. No, I was going to say one other important aspect amongst all this is that you need to train your team that especially when a bleed or a perforation happens, one nurse should be dedicated talking just to the patient. It's very, very important, because otherwise patients see, because conscious sedation, patients are awake. With colonoscopy, they're watching the screen. They see blood everywhere and people running around. Yeah. That panic goes to the patient. And I've had situations where patient blood pressures drop not because of the blood, the bleeding, but because the patient has had a vagal response looking at so much blood on the screen.
Yeah.
So we have a policy that one of the nurses will stand right against the patient, so patient can't see the screen, and continuously talk as to what's going on and what's happening, and calm. Otherwise, that's another very difficult, because we in England do everything under conscious sedation, not like Europe where propofol and GA, you don't need to worry about the patient.
Exactly, so it is extremely important, because patients very often are watching, and obviously we are working with a magnifying 30 times glass, where a bit of blood looks very alarming, and a lot of blood looks even more alarming. And if you start shouting and demonstrating anxiety, things can go really wrong.
Just one thing that it links to the next case is that in this case, the specimen was not retrieved. So when dealing about post-colonoscopy cancer and all this specimen wasn't retrieved.
Yeah.
Some of the post-colonoscopy cancers that we have known were because of a complication of bleed with an incomplete resection and inadequate follow-up and all this. So that's an important point.
Yeah. Good.
Well, we are going to move into polyp recurrence. That obviously is another situation that we have. We have talked a lot throughout the symposium about how to ensure that we remove polyps and block, that we get normal mucosa around, that we do soft tip coagulation on the edges when we do large field EMRs. All that is to avoid this scenario, but they still happen. So basically, by the end of the symposium, I'm sorry, I think we are showing another clip. Sorry, it's, before we go to the polyp recurrence, this is another.
Yeah, this is this is.
This is another.
This is a case of LST non-granular in the lower sigmoid colon. On the previous colonoscopy, Access to the lesion was not great, and the lesion was not described in great detail. The patient came for reassessment and the EMR. We could see that the lesion was quite large, almost 4 centimeters in size probably, but it was quite longitudinal. It was like a sausage shape. Therefore, I thought that underwater resection could be attempted. I did inject the lesion. It was previously assessed with a near focus and there were no signs of a malignancy. The lesion was resected and blocked. However, there was immediate bleeding, which seemed to be arterial and probably coming from 2 different vessels. Because I didn't want to lose the specimen, I decided to apply a Purastat and then immediately sucking the specimen within the cup, retrieving the specimen. As this was a lower sigmoid, it was very easy to remove it. And we can see how we apply the Purastat. In fact, 5 milliliters were applied. We can see a vessel on the backhand side of the specimen. And then the scope was reinserted quickly. And the post-EMR defect was assessed. This was just less than 2 minutes after having applied the Purastat. And it was very interesting to see that the bleeding had stopped. At that point, I could have targeted the vessels, but as there was no further bleeding, I decided to just suture the post-EMR defect with 6 resolution clips, 11 millimeter in size. Started with the oral side and consecutively applied the others to completely close the defect. And of course, a tattoo was applied as the polyp was large. Single side of tattoo with the traditional technique of saline tattoo, saline. This is the unstretched specimen, and you can see that the stretched specimen measured 4 centimeters in size, and it showed a normal mucosa all around. Histology revealed a tubular adenoma with low-grade dysplasia. So I wouldn't say, of course, that we have to treat arterial bleeds with a Purastat, but I think this does show that we have to have different strategies in our mind and apply wherever it can be helpful depending on its situation. And in this case, a Purastat certainly did stop the bleed.
Well, an unusual indication, because we always understand that Purastat perhaps doesn't work on arterial bleeds because of the pressure of the blood flow, but you demonstrated very well, sort of in a desperation, let's use a bit of Purastat, and actually it controlled the bleed and allowed you the time to close the defect. So Pradeep, first of all, 1 minute of what you think about the Adolfo approach, and also I would like you to tell me, when do you decide to close defects?
Sure. I think one interesting thing about underwater resection is I feel this is a very big area of growth. A lot of resection will happen underwater in the future. But we are at a stage where we, as well as industry, both do not understand how to optimize diathermy underwater. Mm-hmm. And I think this is something that has to be done for us to grow faster in this field. And maybe sometimes these kind of disasters can be avoided if we understand the diathermy very well underwater. You did very well. The use of Purastat, I have used, a lot of other experts I've spoken to who have used in big arterial bleeds, purely to slow it down to allow a more definitive therapy to happen. We never trust Purastat to just be the solution for that kind of bleed. That will be a disaster, and that's what you did. You went back and you closed the entire defect, and that secures it. So I think it's very well managed, the whole thing. When do you close? Well, I think closure in trials looks fantastic idea. Closure in reality is not that easy. It's quite challenging, and access is not right. Patient is uncomfortable, taken a long time to do the resection. Patients, you're running late, patient's uncomfortable, and you're trying to get everything together can be very challenging. And our Spanish colleagues have shown that probably in about 40% or 50% of the patients only we can achieve complete closure. So we need to be conscious of that fact. But one thing which we do target is that a lot of our patients come from wide referral patch and can be on anticoagulants or double platelet agents. These are the patients we always attempt a closure, irrespective of the location of the lesion or size of the lesion. If they are going to go on anticoagulants or double platelet agents, we always do the closure. Other than that, we do know that all right-sided lesions more than 2 centimeters are at high risk of bleeding, and clip closure will reduce. So if you can safely perform, it's a good idea, but I wouldn't advise spending 15 clips and then doing an incomplete job. So please make an assessment right at the beginning. This is something that you can really achieve or you cannot achieve. Don't spend 15 clips and still not be able to close. So this requires a bit of experience and thought and decision making of which one you would do or which one. Adolfo showed you options like Purostat and various other things which could be used in replacement.
And Matt, Freddie raised the issue of anticoagulation and double platelet agents. When you are doing a large field EMR on a patient, for instance, on the new anticoagulation agents, when do you tell them to resume?
Yeah, it's a great question, isn't it? Clearly, from an endoscopist point of view, we would say, well, stay off them for 2 weeks, 3 weeks, because we know there's the recurrent bleeding at about 7 to 10 days. But then the patient has a large stroke, so we have to be mindful of that balance of risks. And ultimately, there's no risk-free option. And I would say that it's easier to treat post-procedural bleeding than it is to rescue someone who's had a thromboembolic event. So I think we have to be a little bit brave here. And although there's no hard and fast rule, it depends exactly what I've done and whether I've managed to obtain closure, et cetera, But in general, I will try to restart the antithrombotics after 24 hours or 48 hours. It's rare that I will go longer than that, but it has to be individualized, doesn't it?
Yeah. Okay. Excellent. So, obviously, we are live, and I introduced the recurrence, and actually, it was good we went back because it's been a very, very great case of post-polypectomy bleeding. So, moving on to where I left it, we will talk about polyp recurrence, and by the end of this case, we should be able to recognize recurrence, to understand maybe the benefit of underwater EMR on managing the recurrence, and then how do we use the soft coagulation to reduce the risk.
So I'm in the ascending colon, and we're just coming back to the previous resection site, and you can see quite a big scar here. It's really pulled in the haustral folds, and at first sight, actually it looks pretty good. I can't see any evidence of recurrence, certainly on the distal border of the scar, but just there on the proximal border, we're picking something up, perhaps not perfect. So I'm just going to move the patient into the supine position just to get a better look at that. And yep, there we go. You can see 2 plaques of recurrent tissue. I'm just going to stick on MBI so you can get a clearer look at those, and we'll wash. And when we get nice and close, yep, 2 areas of adenoma there. They're often in a inconvenient place when there is recurrence for obvious reasons. It's always a bit of the polyp that you struggle to clear where it comes back. So what I'm going to do, I'm going to attempt an underwater EMR. So I'm flooding the colon with water, and the idea is that that will make up the recurrent polyp. It will allow it to float up. I'm going to use a cold snare because that's my best snare for very flat lesions. And what you're going to see me doing, I'm just going to push down onto the polyp as hard as I can. I'm going to try and catch it in, and although we've had some success there, we've not cleared the whole of the recurrence, and that's very typical with a fibrotic reaction you get with recurrent polyps. It makes it very hard for the snares to grip and remove the polyps. So we're going to have another go here. So again, fill the water up again, and I'll get my cold snare out. I'm nice and close to the polyp. I'm going to push down as hard as I can, really oppose the tissue there and close up. And we've got some tissue, but again, I think there's still a bit of residual there. So this is third time lucky, and it's skidding off, but you can see at least we've cleared superficially. Now I'm obviously worried that there might be tissue which is still deep, so I'm going to use snare tip soft coag. So this is using a 10mm hot snare. I just put the tip of the snare out, as you can see, and I'm using blue pedal, and we are going to burn the area. And in this case, rather than a neat circumferential burn, I'm just going to burn really the whole of the area, and that will hopefully help stop the venous ooze as well and allow me to catch any residual microscopic evidence of persistent polyp. So we just do as much as we can here, and when I'm happy that the whole of the bed of the polyp defect has been treated, then we can leave it alone and then arrange to come back in 6 months just to check my handiwork and make sure that the whole of the polyp is clear. So that's a polyp recurrence managed with underwater EMR and cold snare and snare tip soft coag. Thank you very much.
Right, so a good case to set the scene about polyp recurrence. That is what we are facing quite a lot in our practice. First of all, Pradeep, just give us a bit of a summary of the case.
Well, it was very good to recognize recurrence because sometimes it can be challenging. There was a good bowel prep, and you show that how NBI really helps highlight the exact recurrence. So it was a very good idea to use. Fine. Once you find the recurrence, then options for dealing with the recurrence are very variable, and different people use different ways of doing it. I think cold snare resection is a good idea. Personally, for me, for recurrence, I wouldn't use it because they are fibrotic, they're difficult, they're vascular, and it's never satisfying. And you saw at the end of that case as well that Ed ended up using hot snare coagulation because he wasn't convinced in his mind that he has managed to eradicate everything. So I would generally either go for some radical option like a endorotor for cold resection or for hot resection. Doing ESD for this kind of little resection I don't think is required, but underwater hot resection you could do here, or standard EMR, inject, or even the hot avulsion. So my personal preference is hot in this unless I use a different device like a endorotor. But different people use different, as long with the beauty is the endoscopist there knew the drawback of the technique he's used, and he added another technique to compensate for that. So that thought process is very important. And that's what was reflected here, that doesn't matter what technique you use, you're aware of the downside and plus side, and you compensated for it. So overall, I think it's a great way of doing it.
Good. Matt, two things. So the very first thing is, obviously, we want to avoid the scenario of the recurrence. In your practice, when you are doing a large field EMR, so most of the recurrence happens on lesions that we haven't been able to remove and block. Mm-hmm. What do you do that when you go and interrogate this lesion again, you don't find recurrence? Which steps do you take to ensure that when you have completed the large field EMR, you are 100% sure that the risk of recurrence is going to be bare minimum?
It's a good question, and I think the key thing is to, you said interrogate. That's the right word. So once you think you've completely resected the lesion, you need to spend substantial time then interrogating the lateral margin. So I walk my way around the lateral margin, making absolutely sure that it's all clear. And I use near focus so we get the best view possible. And although I don't personally, I don't coag the edge routinely. If there's any area of concern, I'll use a snare and remove that area and possibly coag over that area too. So I tend to use a more targeted approach. So I think the key thing is to be very, very careful that you haven't left any peripheral aspect. And then, of course, after that, you look at the base of the lesion, make sure there's no islands within that, and treat those aggressively, because it's those central islands that are the most challenging bit to resect in 3 to 6 months' time. Recurrence at the periphery of a lesion is fairly easy to deal with. It's the ones that are in the middle that are more challenging.
And when do you bring your patients back? Because sometimes you feel, I don't want to wait too long in case it becomes very bulky. Shall I do it in 4 to 6 weeks, but maybe I'm not going to see enough because the bed is not healed enough? So what's your practice? And for instance, in the UK, we have a very good sort of guidelines that tell us pretty much on a formulae, but what do you do in your case?
Yeah, my practice has changed over the years, really. And in general, I think leaving a little bit longer is often better because you're allowing recurrence to reveal itself. I think if you go in too early, the recurrence might be fairly small and you might potentially miss it. So I think there's an argument for leaving it a little bit longer. And it also, it removes any sort of post-resection inflammation challenge as well. So in general, I leave it 6 months. If there's high-grade dysplasia, if there's any concern in the original specimen, then I will bring that forward because obviously I don't want to leave that a potential malignant tissue too long. So I'll go earlier, case by case, but in general it will be 6 months.
Okay. And Adolfo, obviously we have snares, we have soft coagulation. You have quite a lot of experience on endorotor in these type of situations when the recurrence is very small. Just tell us a bit about your experience of other means of dealing with recurrence.
Yeah. So I always say that until I started using this technique, I didn't like this type of polyps. There are certain polyps you like to treat. I didn't enjoy them because usually I was not very successful. The policy used for this polyp now that are discussed in our polyp MDT, by the way, is and not just after polypectomy, also after transcendental surgery, some of them which have very large scars. So if there's nodular components, then we remove them with a snare. Of course, first, a proper assessment, make sure that we are not treating a cancer. If there's no suspicious features, nodular components by EMR. And when you reach the flat portion of the polyp that you cannot remove anymore because the snare slips, then we apply endorotor, which is a technique, it's a cold resection technique where we use a probe with rotating microblades with suction that you can change the orientation of the device, and then you suck you shave off the polyp on the scar. So we're presenting in the international meetings this year, but we've done 42 patients who have had at least one follow-up. And of course, Pradeep is also very actually published, I think, the first series about endorotor. We use a multi-modality, as I say. With nodular, we start with EMR and then endorotor. If there are no nodular components, only endorotor. And within 3 sessions, 94% of the polyp disappeared with histological confirmation of that. Most of them had benign histology, of course, and almost half of them were in the rectum, and many of them after transcendental surgery. And it's a very safe procedure. One patient had a delayed bleeding requiring transfusion, and 2 patients required coagrasper for bleeding in the rectum, that you have to be a bit more careful because there's hemorrhoids, of course, and no perforations. So I think but something we tell the patient that you have to bring them every 3 to 6 months to check the scar. It's very important to check the scar with your best technique. We use indigo carmine as well, because sometimes if there's some certain narrowing in the lumen, you might miss a part of the flat residual polyp near the scar. But as I say, I think it's a good technology. We have to bring the patients every 3 months and make sure there's nothing left. If there's something left, you have to treat again, as you would do with radiofrequency in Barrett's, for instance. Okay. It's not one-off procedure.
Thank you for sharing that with us. So we are about to conclude our colon symposium. I think we've gone through a bit of a journey, starting from very small polyps to things a bit more challenging, and also challenges post-resection and when patients come back to us. From this section of obviously the bleeds, the closing defects, Pradeep, one sentence of a good take-home message that people could get from you.
I would say if you are learning any new technique or you want to introduce any new service, do it reverse way around. Learn how to manage the complication of the technique first, and then learn the technique, and then you can't go wrong.
And Matt, one take-home message from you.
Yeah, I think that's a great one. You've stolen mine, but to think of another one, I guess it's planning and preparation. It's making sure before you start the procedure that that the team is aware what you're intending to do, you have the equipment, you have sufficient time to do it, and then if a complication does occur, keeping calm and again working as a team.
Excellent. And lastly, Adolfo.
Just the same. It's a training in the technique of polypectomy, but in the treatment of complications first, and it's a teamwork and non-technical skills. Be sure that you'll be able to deliver the treatment and that your team is trained.
Fantastic messages. Thank you very much to sharing this time with me. And now we are going to break for a break of half an hour, back at 1:30 for more exciting stuff in the afternoon. So please rejoin.
2. I came today via Good afternoon. Welcome back to London Live in the final session of the two-day course. It's very sad that we hit the final session now already. What we want to do this afternoon is talk about really innovations and futures of endoscopy, and really have, I think, quite an exciting afternoon with some really up-to-date topics. And no better place to start than an area that is covered in the media quite a lot, and that is, of course, the obesity epidemic that we're seeing. And I'm joined by real experts in the field. So I have to my left here my colleague at UCH, Cormac McGee. I've got Reem Shariah from New York, who's laughing at the thoughts that George Webster is being classed as an expert in the field of obesity. That's, I think, maybe his own personal life rather than... Oh my God. But there we go.
Start with a bit of shaming.
I'm very sorry. So, without further ado, I think there's a lot of coverage being talked about in terms of the medicines that are available in obesity, and we're seeing more and more being approved. And I think a nice place to start really is with a nice sort of refresher on where we are with the medicines available for the treatment of obesity. So I'm going to hand over to my colleague Cormac to just talk us through that.
Perfect, thank you. So if we can just go to the slides. So thank you very much for having me, Dave and George, on the course. Really pleased to be here, and of course to be joined by Reem here as well. So very just brief overview of medicines, because they're in the newspapers all the time. So firstly, as we know, obesity is important. I think this slide just nicely just summarises here the impact of obesity and rising BMI on life expectancy. And obviously we all know about all the other complications and comorbidities as well. So in the past, medical therapies in obesity were not great. Things that were tried included amphetamines, as you can see here from the famous film Requiem for a Dream, and then laxatives, thyroid gland extract, orlistat, which remains licensed within the UK, which is a drug that impairs fat absorption, but usually very poorly tolerated by patients, and about 50% have to stop it. And then naltrexone bupropion was used, but again, due to side effects, has been stopped. So historically, medical therapies were really quite poor for obesity, but obviously this has changed in recent years. So the drug that's probably the most famous is semaglutide, which is a once-weekly injection used in diabetes, called Ozempic, and called Wegovy for weight management, but the same drug. And the reason why this has become really important is that suddenly we had introduction of a once-weekly injection, which can lead to quite profound weight loss. And this is just some data from one of the trials on it. Liraglutide I mentioned as well, because this is a once-daily injection, which is also licensed for weight management, but with slightly less profound effects. And the reason why these drugs are important is because they're trying to target the hormones which control appetite and control food choice and satiety, and also metabolism. And these have been really effective. The other drug which is licensed within the UK currently is tirzepatide, which was very recently licensed, although it hasn't gone through sort of all the stages of NICE. And this is a combined drug, so targeting two hormones, GLP-1 and GIP, and it has, again, as you can see here, really quite profound weight loss within the trials, and with a dose-dependent response and much higher than placebo. The last thing I'm just going to say very briefly before we discuss is that there are lots of therapies being planned at the moment. So this is just a slide just to demonstrate some various different targets in terms of hormones, which are being looked at by drug companies in various stages of trials. And again, looking at sort of combination drugs on the right, which are targeting multiple receptors and multiple hormones to try and improve weight and improve obesity. And I think the last slide here was just mentioning from Voltaire about eating and drinking. And, the important thing is that, we have to make sure that we're treating the patient as well. Thanks.
Brilliant. Well, look, thank you for a lovely overview there, Cormac. And I think, George, in your practice, there's been a lot of change, over the years. And are you seeing in your sort of day-to-day life, there are more people just coming to you sort of saying, I want to go straight to these, these medications, or is it something that's still not really taught?
Yeah, I think it's a good point. I think, there is much more public awareness about the longer-term impacts of obesity, and we all recognise that standard measures, diet control and exercise, we all know that that is what can lead to weight reduction, but it's a huge challenge, and the reasons why it's a huge challenge are beyond the remit of this discussion. I mean, I think that one of the issues for patients, whether it's related to weight reduction or other areas of medicine, but also very much impacts the discussions we've been having over the last 2 days about endoscopy, is the invasiveness of procedures, the risks of procedures, and that balance that, we had an excellent discussion yesterday about the management of chronic pancreatitis. We know that surgery has a benefit. In chronic pancreatitis, many of our patients would like to know if there is an alternative to open surgery for the management of their painful chronic pancreatitis, and whether that's endoscopic or other approaches. And I think actually the same issues and the same discussions are brought up by patients with regards to obesity management, and so they want to know what treatments are available, what is the relative merit of those treatments, what are the relative risks of those treatments, and something that I'll be very interested to hear about during this discussion is sustainability, and because I think that's what many non-specialists in this area, such as myself, we see the graphs showing significant reduction during through the duration of studies, whether they be endoscopic, surgical, or pharmacological studies. But do we have enough information to share with patients about what the likelihood is 2, 5, 10 years down the line? Because that also, I think, probably impacts patients' considerations. If they go through major surgery, which is going to produce significant weight reduction, but actually 5 years down the line, they're going to be back at where they were, then that will, I'm sure, influence decision making about what options people choose.
Well, let's sort of pick apart that a bit if we can with our two sort of experts. So, what's your let's start with the first thing George raised, the safety really of these medications. Do we know enough about the long-term effects of these medications at the moment? What is the sort of safety profile of where we are?
So I think you brought up really, really good points. For the safety, the safety of these medications, they're generally very safe. In fact, there's sort of the trial that just came out showing reduction in cardiovascular mortality and morbidity with Wegovy. So we've had even patients who are on Ozempic. I'm like, I want to switch to Wegovy because it's better. I'm like, it's the same drug. But no, it's not like it's direct-to-consumer medicine in the States. But there was an article that came out in JAMA, I believe, sort of late last year, looking at the GI side effects of these medications, and they compared it to, I think, naltrexone, bupropion, just to sort of as a control. And we do know that it causes delay in gastric emptying and some nausea and sort of gastroparesis-like effects, and that's how it affects the weight loss. So there is that. But there is an effect of pancreatitis that's sort of been, I think, underreported, and we're probably seeing it a little bit more. Even if you just randomly select a group of people and just check their amylase and lipase, you'll probably find it elevated in some patients. And the thought is, what do we need to do about that? And the long-term effects of that, we still don't know. And there have been some cases of gastric obstruction, whether or not they're true or unrelated, it's sort of too early to say. With tirzepatide, I think the side effect profile for GI side effects is a little bit lower. So it's a bit more favorable, or has a bit of a more favorable profile.
Fantastic. And then the second part of it, Cormac, if that's okay, that George asked there was then, do we have then the data to say, well, actually, great, I'm going to lose weight in the first year, fantastic. Is this going to is this going to take me further, beyond the 1 year, 2 year, 5 year, 10 year, George?
So there is some data. A lot of these drugs, as we were discussing, have been used in diabetes before. So you're looking at a slightly different patient group and longer term follow-ups. There does seem to be quite a lot of weight regain when people stop the medication. And that's obviously, particularly if you're looking, for example, within the health service, you're thinking about, the cost of people being on these drugs for a length of time. And certainly there does seem to be weight regain after stopping the medications. Now, in the trials on semaglutide, which I was involved in, they did have unfortunate timing for the period when the medication was stopped, because it was just as COVID came out. So all these patients had been given lots of lifestyle advice. Many of them had joined gyms. And as I say, this is purely anecdotal from the patients that we saw, was feeling, I've lost weight, I feel a lot more confident going to the gym. And then just about that time, COVID came, the lockdown, and all the gyms stopped. So I don't know how much of a confounding it is. I mean, if we think about it, it's likely that if you stop these medications, you're going to regain some weight. But then, I think the thing that we will see as the use increases is, can it be a situation where maybe you go onto a medication for a year, come off for a year, go back on? And I don't think anyone's looked at that fully to see, how that is. But can you then keep the BMI down at a reasonable level?
Go on, sorry.
Yeah, no. I was going to say there is definitely data that when you stop the medications, you're going to regain back the weight. Whether or not you regain it fully depends on how much lifestyle and other therapies that you do alongside of it. But the key thing is that we need to sort of see obesity as a chronic problem similar to cardiovascular disease, and you have your medications like for high blood pressure and hyperlipidemia, so you give those. And then people that may need stenting, for instance, or a CABG, and so you have those sort of facets of treatment, and that's how we probably should start thinking about it. So you have the medications, you have endoscopy, and then you also have surgery.
Can I ask you, you're going to tell us all about the endoscopic approaches, but has anybody looked at the sort of direct cost comparison? I mean, I accept that, there may be extra interventions related to, cardiovascular intervention, but long-term Ozempic compared with endoscopic sleeve gastrectomy, for example, compared with Roux-en-Y gastrectomies. Has anybody looked at that data? And is that something in the US that impacts in terms of reimbursement and insurance? Is that part of the story or not?
Funny you should mention that. No, no, we just looked at this quite recently. So we compared surgical sleeve gastrectomy to an endoscopic sleeve to semaglutide. And sort of what we've shown is that surgical sleeves are cost effective. And that's something that we probably need to sort of hammer down the point to patients and even payers, because it's cost effective in the sense that you get your surgery, there's that upfront cost of surgery, but then down the line there's less comorbidities and less everything else that can happen with that. ESG is cost effective for that class 1 obesity patients because they're less obese and then they have less comorbidities associated with that. We just still don't have a lot of data for comorbidity, which you can add on to any modeling that uses cost effectiveness. The problem with semaglutide, at least in the US, is it's very costly. So it costs around $1,200, so roughly £1,000 a month. And for it to be cost effective, it needs to cost £700 a year. And so for that to happen, and it will once you get all the generic medications, and we do have those, like the compounding pharmacies that do that. But what we're seeing is that there's so many people that are more acceptable, or they find it more acceptable to take medications rather than go for surgery. So more people want to do that. So the impact of obesity with these medications is going to be huge.
Yeah, really interesting. And I guess maybe as a way to perhaps lead into the room's talk, Cormac, it feels to me, when we hear about these medications, well, they seem fantastic. They seem like they're going to work. We've heard they're safe. We've heard they give you long-term effects. And a few years ago, we did London Live. We had, bariatric endoscopy. That is the way forward. That we're going to solve obesity, and don't worry about it. And now it feels like, well, actually, maybe bariatric endoscopy isn't needed so much anymore. Maybe actually we're just going to all take the medicines. Is that a right opinion? Tell me, where are we with that?
I think it would be useful to know that completely. I mean, I think there's a couple of things that personally I always think about this. I think, as Reem just spoke about there, the idea of sort of different classes of obesity and different types of management, beautifully analogy to cardiology, there is one thing. But I think on top of that, I think that although certainly there are lots of patients who would prefer to have a medicine than to have surgery or have an endoscopy, there are also a large group of patients who really hate taking medications. And I remember when we did some of the work on duodenal resurfacing, which obviously was diabetes rather than specifically obesity, there were patients who were desperate to come onto the trial, some of whom were diet controlled, some of whom took 1 tablet of metformin a day, and they were absolutely desperate because they really didn't want to take that medication. They wanted to have a procedure and have it done. So I think a lot of it will come down a bit to patient choice, but I think there's definitely, in my opinion, still a role for that, because I think there will still be patients who want that, and reasons and indications where you'll want to do that, or contraindications to medications.
Fantastic. Well, there you go. So, Reem, you've potentially still got a job, and your talk is still relevant. So fantastic. So let's go on to Reem and her talk, if that's okay, on bariatric endoscopy. So take us away, Reem.
All right, so what's new with bariatric endoscopy in 2024? So when we look at obesity in the UK, about 27% of adults in the UK are classified as having obesity. We want to say that they have obesity rather than they're obese, because you're using first patient name. And so this is sort of 800 million are patients with obesity, and you have a high number of children also with obesity. So it's rising both in adults and in young people as well. So why is it important for us as gastroenterologists to treat obesity? And if you think about it, a lot of times it was like maybe send it to endocrinologists or bariatric surgeons, but GIs are starting to see it because it really affects all facets of GI. So it affects reflux, Barrett's esophagus, as we heard earlier on, colon cancer, pancreatitis, fatty liver, really anything in GI, obesity can be a driving factor. And sort of as you had asked George earlier, we're seeing patients more and more with a higher BMI. And so it's important to sort of ask them, hey, have you thought about weight loss, or what can you do that, and sort of be comfortable in prescribing these medications. So in the US, you have 7 or 8 approved FDA medications. I know it's a little bit less here, but really the driving meds that are now being driven are all the GLP-1 medications. And obviously you have the different types of surgery, and the more sort of small bowel you bypass, the better the surgeries are, but obviously the higher the risk. And there is data that shows that really patients that are eligible for surgery, only about 1% to 2% undergo surgery each year. And this study I like, it's from the Swedish database, and it's basically, it was published in the New England Journal, and then later on in JAMA, and I think the Lancet, with even long-term follow-up. But what it does show you is that after 1 year, all patients who have undergone, does this have a pointer? All patients who have undergone any type of surgery lose weight. So at 1 year, they reach their nadir weight loss. But then over time, they regain some of that weight. And at 15 years, they gain back a good percentage point, but they're still lower from where they started off. And that's important because when you look at endoscopic treatments, you're going to see that same curve there. So here it just shows that the percentage is less, but also it shows a risk reduction in mortality. And we're yet to show that in endoscopic treatments, but we're seeing it in the sort of early medication trials. This is a randomized controlled trial that was also published sort of 3 times in the New England Journal, again, comparing medical treatment to surgical treatment for patients with diabetes. And the key point in this is that it shows risk reduction or resolution of diabetes defined as an A1C of less than 6% in a small percentage of patients with medical therapy, but about a third of those with surgery. So the advantages of bariatric therapies is that they're less invasive, less costly. It's an outpatient procedure, repeatable and reversible. With everything that we're discussing here today, I think it's important to maybe give patients that we see a survey and see what they want. I was just looking this early on. There's no paper that's been published to date on what patients would want, given all three options. And I think that would be a good point to look into. So you have the medications that affect, the treatments that affect the stomach and the treatments that affect the small bowel. And the ones that affect the stomach are more gastric remodeling, it's the suturing, balloons, and those cause gastric delay, and those have more of a weight loss effect. And the ones that affect the small bowel, like you mentioned, the fractal or duodenal resurfacing, that has more of an anti-diabetic NASH effect. So there are lots of balloons out there. There are double balloons, single balloons, swallowable balloons, balloons filled with air, saline, or a mixture of both. In the UK, really Obera is the only one that's available, and another balloon, which I'll talk about in a second. And this balloon is also placed and removed endoscopically, and it stays in for, in the UK and in Europe, you're allowed to keep it in for a year. But then you have to remove it endoscopically, and it causes about a 10% total body weight loss. There is an adjustable balloon out there that's not yet available in Europe, and the theory behind that is that you can deflate or inflate the balloon depending on how much weight loss you have. The theory behind that, though, is that how cost-effective would that be? Because you're doing an endoscopy for insertion, endoscopy for removal, and some adjustment. But the data shows that you can have good weight loss with that. This is another balloon that has taken off during COVID. So it's a swallowable balloon that you can place in your office. And essentially, you place it like you're placing an NG tube. You attach it to a bag of saline with proprietary fluid. And what happens is that the valve that you can see here has sutures that dissolve after 4 months. And so then the balloon, the valve opens, the balloon self-deflates and passes through the GI system. And this is a meta-analysis of over 160 studies showing that the weight loss is similar to other fluid-filled balloons. In the US, we completed one FDA trial. They didn't like it, so now they're completing another one. So the data is still open, so it's not yet available. And this is a small study that looked at balloons and the impact on NASH and fatty liver, because the theory behind this is that weight loss causes some improvement in comorbidities, but what's the point as when we start seeing it? And it's really that 10%. So this was a paired liver biopsy done at the time of balloon placement and balloon removal. And what you can see at the time of balloon removal, they did another biopsy that showed that fibrosis regressed and the NAS score also regressed, showing improvement in fatty liver. And on the heels of that, the AGA, which is our American Gastro Society, approved balloons for the treatment of weight loss. And so I wanted to move from balloons to suturing, and this is the endoscopic sleeve gastroplasty using the Apollo overstitch device, which we'll show you in a second. And it was owned by Apollo, bought by Boston Scientific now. So basically, we do a number of sutures going from the anterior wall of the stomach to the posterior wall of the stomach in a couple of various different patterns, either a Z or a U pattern. And so this is a short video showing this, and please feel free to ask some questions so I don't feel like I'm the only one talking. But
why you're here.
But basically, what you see here is I wanted to show both sort of what the hands are doing and what we're seeing on the left side of the screen. So I usually do APC just to mark the anterior and posterior walls of the stomach. It's not really needed, but it's good to sort of see a good overview, because sometimes when you start suturing, you lose perspective of where everything is in the stomach.
That's nothing to do with the apposition of the tissues.
No.
Obviously, we saw some suturing yesterday with the
So, I have Rosa Vega here performing this colonoscopy. My name's Omar.
Oh, there we are.
Sorry about that.
Okay. Exciting bit of
that was just going back into colon again.
So it doesn't affect the apposition then, therefore?
No, but that's a good question, because we're now starting to look, and there's more data looking at what you can do to make sure the sutures are more durable. So there is some data looking at that, and we can talk about that. But essentially, this is a double-channel scope, but there is the SX device, which is over a single channel, and that's more available here in the UK. And what you do is you sort of obviously pass a 2.0 proline suture from one side to the other, and use a helix. And the helix is really important because that ensures that you're grabbing muscularis propria to ensure that you have good suture apposition and durability. And so this is showing the first set of sutures. What's coming out at the 4 o'clock or 7 o'clock part of the screen is the helix that grabs the tissue for you. And you repeat the sutures going all the way from the anterior, middle, posterior part of the stomach.
Reem, I can see another pair of hands in this video. So is that someone that is another physician helping you? Is it a nurse, or how involved is that other pair of hands apart from yours?
In this instance, I think it's one of the techs. So you can either have a tech, a nurse, or sometimes the fellow. And then basically what they do is they turn this device that looks like a corkscrew 3 times clockwise and then anti-clockwise, and that basically corkscrew into the mucosa, and you are the person that grabs the tissue. And it's important that you be the person to grab it because you can feel how much you're grabbing, and then also that you ensure that you're not grabbing anything beyond that. Because there have been cases of either perforations or gallbladder perforations, because you can corkscrew into the gallbladder as well. So it's the most important part of the procedure, but it's also the most dangerous. Right. And so you can see here how much you're grabbing. I tend to turn the CO2 off a little bit to grab more tissue.
Okay.
And there are various techniques to do it, but here you're sort of going all the way from anterior, middle, posterior, and then all the way back again. And you repeat this procedure, this sort of technique, going all the way from the incisura to the GE junction.
You're making this look exceptionally easy. I've done a bit of suturing. How many steps are there to applying a suture? If you're just doing one suture, how many different clicks and moves and things are they? What's the process, I suppose?
So we were talking about it yesterday, just in how you learn from a procedure. And I think what's taught me is watching myself on a video back again, because you sort of, the steps are a little bit onerous because you're like grabbing a suture from one side, grabbing it with your anchor exchange and sort of transferring it back again. And I think once you see what you're doing on a video, it sort of makes sense. So there are a lot of nuances to it. I did my first case when I was pregnant with my daughter, so a lot of my teaching ends up being on kids. So I usually say, press the blue button. It's like frozen, let it go. So that lets go of the sutures. The helix, I make people count, and I make them count slowly. I call it the Layla count. So you go 1, 2, 3, and back. And I think it helps, and it's a lot of repetition. So you're doing 70 or so sutures, 70 bites in each case. So you are learning as you go along.
And I think that it's an interesting point you make about learning endoscopic skills, particularly technically demanding interventional techniques like this. That actually the value of repetition, the value of reviewing and rewatching, and actually that's one of the features of actually these 2 days, is that actually the delegates can go back and look at the procedures again, look at the discussions we've had, and it's very interesting that a real expert like you, when you get very good, sometimes you can, for all of us, not trying to actually describe and verbalize how you do it is actually quite demanding. It's a bit like if you're asked to describe how to use a knife and fork, we can all do it, but actually describing it is incredibly difficult. So actually being able to review the procedures is actually a really important part of it, I think.
I think more and more I've started sort of taking a step back and sort of seeing if I could, and I think it's a sign of a good mentor, and I think I've had good mentors who've sort of said, move right, left, and I was like, oh, how did they know how to do that? As opposed to initially when I was probably first starting out, I would say I would take it to feel what I would do, and now I'm sort of more learning how to describe what to do a little bit better. And I think that's sort of a skill that you learn moving on.
As Dave introduced me, I am here as the useful idiot.
Just not that useful.
Well, one of the questions I've always been intrigued about is that doing a sleeve gastroplasty, are you sure that there is no risk of leakage of food contents, if you like, behind the suture line? You know, is it a secure suture line, you know, from top to bottom, and is there any risk associated with you know, gastric contents, if you like, getting caught and leaking around into the redundant part of the
I think that's a good question. We just haven't seen it, but patients are on a liquid diet for about 3 weeks afterwards, and so it's enough for the sutures to heal and heal around the area. I think if patients eat early, you can get like a small perforation that can happen or a leak, and you can get extreme pain. And so patients learn to, it's like a Pavlovian response. They not only learn to eat less, but if they eat more than they should, they'll have pain. And I had one patient who told me that she used to eat 3 meatballs and now she can only eat a meatball and a half. And so that's
progress.
It is progress.
The other thing about you know, putting my HPB hat on, we well know that rapid weight reduction is one of the risk factors for gallstone development, and of course gallstone passage and all the issues around biliary stone disease, and of course the patient who's had a sleeve gastrectomy, whether surgical or endoscopic, that has no real impact on our ability to do conventional ERCPs should that patient run into problems with biliary disease. But you know, the gastric bypass patient, yes, there are the options of edge procedures, etc. But you know, it does make a difference.
For sure. And we've seen patients sort of now up to 10 years out, and you'll see this bridging fibrosis that still keep the stomach smaller. It's not like as smooth as a surgical sleeve, but there is these things that look like Swiss cheese that sort of keep the stomach a lot smaller. So this is our data at 5 years, now published back in 2020, sort of showing that it's durable for up to 5 years. So showing that you have a 15.9% total body weight loss. And if you look at the curve, it's similar to what's the surgical curves that you've seen. And so we also wanted to look at comorbidity improvement. So this is 2-year data showing improvement in HSI index and as a surrogate for fatty liver, and the NAFLD fibrosis score at 2 years compared to sort of 0. And so you can see that a lot of people shift from F3, F4 to F0, F2, sort of showing that if you lose weight, you're also going to see improvement in comorbidities. And this is probably the largest data to date from Saudi Arabia, where they compared a sleeve gastroplasty to a sleeve surgery. And this is data done by a surgeon. And you can see that there is comorbidity improvement in both groups, so surgery and the endoscopic group. The adverse event rate is very low. And then the revision part is important. So you can convert to either surgery if you don't lose enough weight or you regain, or you can redo an endoscopic sleeve. And I think both those factors are really important, because if we're seeing sort of the chronic condition of obesity, and patients can cycle through one treatment or another. This was our multi-center trial. This was a randomized trial that was multi-center in the US with both surgeons, community, and academic practice. And the reason we wanted to do it that way is so that we can show that anyone can do a sleeve. And basically what it shows, it was randomized between lifestyle and ESG, and then at the 1-year mark, the ESG, the lifestyle group went into sort of converted back into an ESG if they wanted to. And you can see that the weight loss is pretty good at about 14% here. And even during COVID, people maintained that weight loss, because similar to what you saw here, we saw sort of a rise in obesity and all of that. And the adverse event rate is very low. So there was one gastric abscess. I've definitely seen it in my cohort of patients, one GI bleed that required an endoscopy for treatment, and one patient who lost a lot of weight. And here you can see improvement in comorbidities as well. And on the heels of that, the FDA authorized ESG for the treatment of obesity. They went sort of saying 30 to 50 BMI, and NICE just approved it for obesity. So that's now going to happen a lot in the US. In the UK, rather.
Yeah.
So we talked about the learning curve. So here we show that it took about 35 cases to get it done under 2 hours. And as I said, the first case, I was pregnant, it took about 5 hours.
Nice.
I stopped halfway for pizza. And we did it in the OR. And now...
Was that factored into the 5 hours?
It did. I counted. I was very meticulous about my timing. But it does get faster, and then the more you do it, it's not just you, like you said, there's a technician, the nurses, everyone's there handing you things, and that speeds up the procedure.
And Reem, approximately now, how long does it take you? Obviously, varies case to case, but approximately now.
Depends on with or without a fellow.
Okay.
I usually
or
say,
a pizza.
or a pizza, about 45 minutes.
Okay. Well, yeah.
But I usually say it depends on how big the stomachs are. So if the stomach is huge, it'll take a little bit longer. And I think that you shouldn't be stingy or rushing with the sutures. So some people wanted to just use 3 or 4 sutures. I think you should really take your time, make sure that you grab as much tissue as possible and not sort of cut corners. I think once you cut corners, it can look good now, but it probably won't be durable. So the next few slides are other suturing devices, which we don't need to spend as much time on because they're not approved in the UK. So this is USGI. It's a plication device that causes serosa to serosa apposition. The data is still very early. A lot of the data comes from Spain. There is data from the US showing improvement in portal pressure measurements that obviously we can do now endoscopically with a paired liver biopsy. So we're seeing a little bit more data on that. And this is the Endomina device that came from Jacques Devier's group. And it's, again, you can place this over any type of scope, a single channel scope that also causes serosa to serosa apposition. It's a little bit more rudimentary because you're using a rat tooth forceps and then grabbing the suture with a snare. But this is a randomized trial that, again, shows good weight loss. And then finally, this is an EndoZip device, which is a device from Israel that motorizes sutures. So I've tried it in Prague just to sort of proof of concept. And there's a study ongoing now in Spain and Italy. And basically, you just press a button and it just sutures the stomach. And you repeat that 3 or 4 times. The thing is that device that you see on the top right of the screen and that thing there is that you have to use 5 of those. So it's not as cost effective, and I think it's going to be really expensive, but it really is, you just press that button and it sutures. So so you're seeing sort of robotic.
We finished well in time for pizza.
Exactly. Obviously we're talking about cauliflower pizza here because so then moving like really quickly, there's the duodenal and jejunal barrier. These are more small bowel devices. This bypasses the small bowel like a long limb bypass. Again, you can see improvement in diabetes in there. This is Fractal, which you talked about. It's available here.
It's just in the process of that, but it's.
So the NICE are looking into it, but obviously you guys at UCH were part of some of the studies in Europe. And so the theory behind this, you're ablating duodenal mucosa to improve diabetes, essentially. There's a lot of nuances to that we don't really need to talk about, but it shows improvement in ALT, AST, HOMA-IR that's independent from their weight loss effect. And this was a randomized trial in Europe and Brazil, again showing similar data. And there are new data coming on bypasses. whether or not we can start using the Axios, which I think we're going to show a couple of cases for a gastric outlet obstruction, whether or not we can do this with for weight loss. And this is data from Mark Barthet, sort of a proof of concept with a notes concept, trying to grab a sleeve and then doing this notes approach. I think we can probably do it with the EUS guided approach, and so we'll see maybe a combination effect. And sort of to bring it full circle to what Cormac was talking about, I think the combination is probably the most important. To add medications, we see a lot of patients that come through from the endocrine side or even offer retightening. Do you see a lot of that?
I think just because there's not been so much being done in the UK thus far that we haven't seen so much of it, but I'm sure in time we will as well. Yeah.
And so we've shown that you can either add medications to balloons. So here you can see this is pharmacotherapy on patients who've not lost a lot of weight versus doing a redo ESG. And that data just got published late last year. This is with balloons, again showing that if you add medications to balloons, you can improve the weight loss. So the combination effect is really important. And obviously, you just talked about Ozempic. Everyone in New York is probably on it, whether they admit it or not. But the combination effect of having medications plus a procedure is you're going to get surgical weight loss. And sort of, I think people who poo-poo one side or the other need to understand that both are here to stay with this. And we sort of answered this question earlier on with the economics of obesity. And this, I just showed you that semaglutide needs to be less than $1,200 a year to be cost effective. This is data from James Kelly in the UK, also probably used for the NICE guidelines, showing that ESG is cost effective compared to lifestyle modifications alone. And that's pretty much it.
Fantastic. I mean, that is an incredible presentation, really fantastic. Cormac, you're obviously heavily involved in the sort of the bariatric service here at UCH. Talk me through how a patient who may come to, let's say, Georgian Clinic and say, I want to be considered for, bariatric intervention. Talk me through the process of where they go from, that clinic thing, a referral to you, and what happens, and who do they see? Where's the
no, of course, no. So we set up the process recently, and the first thing is that for all sort of interventional bariatric stuff within the UK, it still has to be a GP referral because of funding. So if they're seen, for example, by Georgian Clinic, it would probably have to go. The patient would have to go to his GP and get a referral directly to bariatric services is still the situation. But I think in time that will change. And as we were talking about sort of gastroenterology becoming more involved, the way we've set it up at the moment then is that then the patient will be assessed in the one-stop bariatric clinic, okay? So where they're seen by a dietitian, they're seen either by me or to talk to some of the other bariatric people there, and then discussed and then maybe seen by a psychologist as well, depending on needs. They're then reviewed, all the patients in the bariatric MDT, which is a large multidisciplinary team of the surgeons, the psychologists, dietitians, specialist nurses and myself, and discuss about the best intervention for a patient, because obviously we take into account what the patient would like, but in some patients they may be very fixed on having one thing done which may not be suitable for other reasons, and then after that then go forward to the procedure from there, provided that you're happy.
And is there ongoing? So let's say you've had the procedure. Is there ongoing intervention from, you mentioned psychologists and dietitians? Is that it?
So ongoing intervention from dietitians. The psychology is usually all done in advance because what you're trying to do is just identify people which unfortunately is very common, may have had some trauma that led to obesity and so on, and make sure that you've explored those sorts of things. Other things that are important to explore about things like alcohol excess. One thing we didn't mention is that actually there's been some interesting stuff looking at semaglutide, that it may be actually helpful for people who are alcoholics as well, whilst actually with bariatric surgery, some of the if you were an alcoholic before, it may actually get worse afterwards. So things like that need to be picked up in any eating disorders. There doesn't tend to be as much psychology after the procedure unless there was a particular need for it.
Okay, fantastic. And maybe you showed us just loads of different endoscopic options there in terms of the treatments. Does the patient say, look, I want a balloon, and you go, okay, a balloon it is then, or do you have a vibe of what you feel is best suited for them? And you know, is there sort of one your go-to, or do you literally mould the treatment for each patient?
So it's a little bit of both, and I learned this from one of the bariatric surgeons earlier on. They told me that patients with obesity are really good at Googling stuff, and I think it's because they want to lose weight, so they're going to look at whatever options they have, and then they'll go to forums. There's a Facebook forum, there's whatever, TikTok and everything like that, and they come to you with a procedure in mind. And we looked at that data, so we looked at Google Analytics to just see what patients want, like all over Europe and in the US, and especially looked at the impact of COVID. And you can see that just everyone was interested in like balloons or ESG, but then after COVID, the sort of Google search for ESG and balloon just went up. And the same thing, we looked at the impact of COVID on TikTok, and it's the same thing. So people were more looking at sort of anti-obesity treatments for that. So some people come to you saying, I want X, and you're like, well, your BMI is 60, that's not going to work. And so sometimes you sort of get them to see a surgeon, and if they don't want to, they'll come back to you. But I think it's just that hook of getting them into any form of treatment. They'll sort of say, okay, semaglutide wasn't that bad. I lost 20 pounds. I want to lose a little bit more. What else is available? And so then that becomes the next step.
We think you're great, but do your surgeons think you're great?
I'd love to say that.
Do they? But is there a tension between the surgeons who make a good living from doing surgical bypasses, or maybe doing surgical sleeve gastrectomy, and then you coming in and doing it all endoscopically?
So to my face, they're very nice. I have heard comments like on our 5-year data where they've said, well, it's mixed in with medications. It's not as pure as surgery. But we were very honest in this. We said this is the data, and we just wanted to show what the 5-year data is. And I've tried to be very meticulous to, when we've presented at conferences, to make sure that we have an IRB for everything. I put our data in the surgical database. It's the equivalent of you have a bariatric center for excellence. We have the same thing in the US, and they want to make sure that we're part of that. And I think just ensuring that anyone above a BMI of 40 goes to see a surgeon, and we make sure we document needs surgery, I think shows them that we're not trying to steal patients from them. And I think that sort of political game is important.
That's been a really amazing session. Thank you so much. I've learned loads. So thank you so much, Cormac and Reem, for that session. And of course, thank you hugely to George, as always.
My expert input.
So look, we're going to go on to a really exciting session now on AI in endoscopy. And to sort of introduce that section, I'm going to hand over to Omar Ahmed, our colleague at UCH, to just talk us through some of the latest innovations there.
Thank you, David. I'm absolutely delighted to open this session on AI in endoscopy. It's entitled, Is AI mainstream or downstream? Well, I think the fact, for the first time ever, we have a standalone session on AI in London Live tells you it's very much mainstream. Admittedly, there is a lot of hype. The question is, does the clinical evidence support the hype? Let's take a look. Here are my disclosures. So I think you'll agree with me, we've probably witnessed one of the most rapid translational journeys for any technology in the history of endoscopy when it comes to AI. Within the space of a few years, we have multiple regulatory approved devices now on the market for CAD-E, AI-assisted polyp detection. We also have a couple of devices on the market for detection of Barrett's neoplasia in Europe. And we also have multiple devices on the market for AI-assisted polyp characterization, CAD-X. But what does the evidence say? Well, when it comes to AI-assisted polyp detection, this is the most rigorously evaluated indication for any AI application in the entire field of medicine. This is a very nice and high-quality systematic review and meta-analysis from Cesare Hassan, who will be joining us on the panel later, which evaluated 21 randomized controlled trials of over 18,000 patients. And what we found here was a very clear message that AI-assisted colonoscopy led to an approximate increase in ADR of around about 10%. There are some potential downsides we should acknowledge. There was a significant increase in the resection of non-neoplastic polyps, but to some degree that might be mitigated by the implementation of CADX in the future, and there was a slight increase in mean inspection time. But I think we should be very honest and say, well, actually, all the randomized controlled trials are not showing the same thing. Here are two of the largest reported randomized controlled trials, both parallel multi-center RCTs within screening programs. This study on the left is from the Cadillac group in Spain. We have Maria Polisi joining us here from that study. We'll hear from her later, where actually the study did not demonstrate any significant increase in ADR or advanced colorectal neoplasia detection rate. But conversely, this study on the right-hand side from Joseph Sung's group in Hong Kong showed quite the opposite. Similar number of patients, significant increase in ADR, significant increase in even advanced ADR, and actually quite fascinating to see that AI was more beneficial to experts than non-experts. I think we should also be mindful of some of the more recent so-called pragmatic observational implementation trials. And of course, these do have some limitations when it comes to methodology when you compare them to the randomized controlled trials. But both of these studies demonstrated actually no significant increase in ADR or PDR when AI was implemented in the real world into their departments. Interestingly, even though the study on the left showed a significant decrease in ADR, there's a suggestion maybe that the presence of AI altered the behavior of some of the endoscopists in this study because their withdrawal time was shorter with ADR. So we really need to think about this interaction between the human endoscopist and the AI devices. What about AI-assisted polyp characterization? Well, no randomized controlled trial data yet, but two large prospective studies that I would like to highlight today. We have the ABC study from Cesare Hassan's group and the Endoscopy, which is an ultramagnification study with AI software called EndoBrain from Yuichi Mori's group. Neither study demonstrated a significant increase in sensitivity or specificity, but two important insights we should take from these studies. In the top study, this wasn't actually powered to look at non-experts, and when you look at this nice graph on the top right-hand side, what you see is a very clear learning curve with CADX. And actually, by the time these non-experts got to their last 50 diminutive rectosigmoid polyps, they were meeting the thresholds for implementation. And in the study at the bottom, we saw a significant increase in high confidence diagnosis with CADX. This could be really important for real-world implementation of an optical diagnosis strategy. Moving on to the upper GI tract, I think we have seen the upper GI tract lag behind the development in colonoscopy. We've seen some very nice high-quality work coming from the East, looking at gastric neoplasia and squamous neoplasia in the esophagus. But I think in the West, if we're honest, it's Barrett's neoplasia is where the real money is, because this is where we really desperately need some help. The initial preliminary studies were very promising, mainly on preclinical data, showing in this meta-analysis pooled sensitivities of around 90% and specificities of around 85%. Thankfully, we've moved forward. We don't have randomized controlled trial data yet, but we do have some very high-quality, multi-center prospective, multi-reader video studies. This study on the left is from Jack Bergman's group, and what you see very elegantly here is that when they provided general endoscopists or sort of non-expert endoscopists with AI assistance, the sensitivity actually increased significantly and was inferior to experts. And importantly, there was no drop in specificity. We also have a very nice study on the right from Pradeep Bhandari, who again joins us on the panel later today, where he was able to demonstrate with his group that AI was significantly superior to non-expert endoscopists, and also, reassuringly, there was no drop in specificity. So the data's there. The question is, why is everyone not using AI? Well, we published this exercise actually 3 years ago now, looking at barriers to adoption and implementation. And actually, many of these questions remain unaddressed, and I'd really like to talk to the panel about them today. So we know that there's an uncertain effect of AI-assisted polyp detection on actual colorectal cancer incidence and mortality. The microsimulation modeling studies suggest there is a benefit, but we probably need to see some real-world data. We have some uncertainties about the cost-effectiveness of AI-assisted polyp detection, and the issue is even more complex when we think about AI-assisted polyp characterization and the possible cost savings we could have with that. I think the elephant in the room is really about reimbursement and who pays for this. Recently, we didn't really have any reimbursement globally, but really some groundbreaking news just a couple of weeks ago. Many congratulations to our Japanese friends and colleagues, Yuichi Mori and Misawa, who have managed to obtain a world-first reimbursement for AI-assisted polyp detection in Japan. And we also have some important emerging ethical and legal issues, particularly with the use of CADX and the new quality assurance softwares. And just coming back to this crucial issue, probably the hottest topic right now in research is this concept of the human endoscopist-AI interaction. To some degree, you know, there's a dance you've got to do with the device, because the device will only be as good as the endoscopist sometimes, and the quality of the outputs you get will depend on the mucosal exposure technique and what you show the software. And what we have found, actually some evidence we published, is that when these softwares are designed to pick up on very subtle flat lesions, actually the endoscopists dismissed these as false positives when they were not. And we can see from this very nice eye tracking data on the right-hand side that actually, especially amongst trainees, the most common error was a cognitive type error. So they actually saw the lesions but didn't recognize that these were abnormal. So we've got a bit of work there to do with AI and training. And very nice work below from the GI Genius group, where they showed that the standalone performance of CADX was superior to that of humans alone. And when you put the human in the loop, actually the performance was inferior. Of course, we've got some really exciting new use cases on the horizon and applications coming your way. Some of them are actually already here. We've got in the top left AI-assisted quality assurance, where you get real-time feedback about the quality of your mucosal inspection and potential blind spots. We've got automated bowel prep scoring in the top right. We've got emerging applications for automated polyp sizing. And in the bottom right, it's really nice to see AI slowly come into the therapeutic arena. This is work from Helmut Messmann, preclinical work with a demonstration here showing a very nice overlay during third space endoscopy. But really, what's going to get adopted the quickest, I think you'll agree with me, it's probably automated reporting. My heart still sinks when I have to write a report and I've removed 30 or 40 diminutive adenomas. AI really needs to do this for us. We'll very rapidly embrace that. And you see some nice work here from Odin Vision in the video, actually, where you can get more accurate metrics as well. So the AI system here is very accurately giving you a clean withdrawal time estimate. And it's likely in the future we'll see completely novel computer vision AI-driven metrics. So I'm just going to finish off with this slide. I think it's really important because I think it's the question you're probably all asking, and I ask myself every day when I use AI in endoscopy. What is the clinical value of AI? What is this actually bringing to the table? What's the difference it's making? And I really have to congratulate the ESGE, and particularly I know Raf Bishops, who's with us on the panel today, and Cesare Hassan, because they put a lot of work into this position statement where we tried to define by consensus the performance measures that we should expect for different AI use cases. And hopefully today, in the cases, that's what we want to demonstrate, is what difference is AI making in day-to-day endoscopic practice. So with that in mind, we'll go straight over to our first case. This is a diagnostic colonoscopy. We've got a 70-year-old male who had a change in bowel habit with diarrhea. He's FIT test positive, and we will demonstrate here the equipment we're using, which would be a Fujifilm 700 series colonoscope with CAD-I, their artificial intelligence system, and also Colo Assist, their magnetic imager. So really the learning objectives for this case are to think about optimal withdrawal techniques to maximize polyp detection, but particularly with the use of AI, characterizing colonic lesions to inform therapeutic decision-making using image enhancement, and also being very familiar with the AI technology that's now becoming more commonplace. So we'll go straight through into the case now.
So I have Rosa Vega here performing this colonoscopy. My name's Omar Ahmad, one of the other consultant gastroenterologists. Today we're using the Fuji 700 series and also demonstrating the AI system, CAD-I, and also using Colo Assist to very nicely get around comfortably to the cecum with a straight scope. Yeah, so what we can see at the moment, we're in detection mode with the bounding box is being flagged up. And I think don't be perturbed by the short duration false positives. As you can see, those can be very quickly and easily dismissed, and actually sometimes help the quality of your mucosal exposure because it just attracts your eye to some subtle areas, perhaps a little bit of mucus that needs washing. You never know, for example, if there's a sessile serrated lesion underneath. So false positives actually, I believe, can be helpful. One of the slight criticisms of the AI systems that people make is, well, they're mainly detecting very small diminutive polyps, and is this really making a difference to interval cancers and ultimately to patient outcomes? But I think certainly one of the things to be mindful of is that I know the developers have been working very hard. They've been enriching their data sets with these very flat, subtle lesions. Certainly those lesions are the ones that we sometimes lose sleep over, because these are probably the lesions that are missed that lead to the interval cancers. And it's a combination of making sure you're doing a very good mucosal exposure on your withdrawal, so you get your best chance to pick up any subtle cues that might indicate an advanced flat lesion that could be there.
And Omar, obviously what I am trying to demonstrate is that I spend quite a lot of time using Infracols or Cineticon as a bubble breaker, suctioning the fluids, and making sure I get a good visualization of the mucosa, because this is how I've been trained. Do you think this is still important if you want to get the best of your CADI mode?
Yeah, absolutely. I mean, the current systems that are available, they are essentially detection systems. So they will only detect what you show it. So fundamentally, the endoscopist, there's a nice interaction between the machine and the human endoscopist, and we've got to work together. It's almost like doing a dance. And fundamentally, you've got to do your good quality mucosal exposure, your washing, to get the very best out of the system. And maybe that's partly why, sometimes we see some variable results from these systems in the trials, because at the moment, they're not going to correct your exposure technique. We may well see with some of the future systems that they give you some feedback and say, for example, there's a blind spot there you didn't see properly, there's a bit of mucus you need to wash. But at the current moment in time, nothing beats that harmony of good quality mucosal exposure, washing exactly as we're doing here, to give yourself the very best chance.
And I can see from time to time as I am withdrawing that I have a bit of flickery, like something has been detected, but it disappears very soon. So when it's just this flush, should be changing to a CADX to try to see if it characterizes the nature of a polyp, or we should feel reassured that if it's only a very brief sort of a snap of a green square, it's probably a false positive. What's your practice?
Yeah, I mean, I mean, you've got a very nice example there. We saw a brief flash. Now, you could easily have dismissed that. But I would urge you to go back and see what that brief flash was. Because it may well be that you picked up on a small part of a partially exposed subtle polyp. And actually, I think that's exactly what we're seeing right now.
Let me see.
So let's have a look under this mucus, and I suspect this is exactly what we were talking about, a very subtle flat lesion.
I don't know if you've noticed that I spend a bit of time rotating the colon in order. I know the suction channel is around 6 o'clock, and I rotate specifically because that avoids suction polyps. That when you are trying to figure out what you are seeing, you don't want the artifact of a suction polyp to interfere with your assessment. So that's why I take a while just to rotate. So yeah, it seems we are here in front of non-granular laterally spread lesion, a small one, isn't it?
Well, we could perhaps, should we use the CAD-X system to characterize this from CAD-I?
So I'm gonna, so that's how you would see it in LCI, but for the CAD-X, you need just to flick to BLI.
Yeah. What we see nicely here in a minute, we'll see the heat map coming up on the bottom right-hand corner, which demonstrates what the system is looking at.
Let me just clear it a little bit more and just see.
Yeah, there we go. So obviously,
so it's quite interesting because the lesion is a bit big. Yeah. So you need to make sure that you get a good signal. So you can see these 3 bars that are lighting. That it looks like the signal you get on a mobile phone, more or less, if we have to relate to something, and then see the good representation of the polyp. And then, obviously, if there is a little bit of artifact of water, but I think I agree with the neoplastic assessment. What do you think?
I agree. I think you made a really good point there as well, that, you know, a lot of people say the machine will do everything for you, but that's not true. Rosa just demonstrated the importance of what you would normally do and what we've all been trained to do, which is get a very good quality, stable image of the lesion, ideally the entire lesion, so that the system has the best chance to make a prediction. And I would totally agree, Rosa. I think maybe if we start with morphology, I agree with you. I would classify this as a laterally spreading lesion, non-granular subtype, probably flat elevated, although there is a bit of a central area there that perhaps looks like it's slightly losing its pit pattern there from 3L from the periphery. Yeah, and there.
Yes. So, but I don't see the pit patterns being extremely distorted.
No, I agree.
Would you classify that as maybe the sort of more risky JNet to A to B?
Yeah, I agree. Maybe right in the center there, you could potentially say there's a small focus of 2B. But in any event, I mean, a laterally spreading non-granular flat elevated lesion probably does have if you believe the Japanese Showa series, just under 3,000 cases, has about an 8 to 10% risk of submucosal invasion. So what do you think, Rosa, in terms of therapeutic strategy? How do you tackle this polyp?
So obviously, if we are thinking there is a small area here in the center, just where this bubble is that I'm going to flash now, of JNet 2B, there is a possibility the biopsies will come back as at least high-grade dysplasia, or what in the States it's known as intramucosal cancer. So it's very important that this lesion gets removed and blocked. And it's probably about 2.5 centimeters max, but flat, so difficult to maybe you can try to do an underwater EMR, but sometimes these very flat lesions don't necessarily come up nicely underwater. I'm going to show you. So you see there is this area in there that we are underwater. I'm just going to remove the VLI now and the cadex just for the purpose of that. And this flat lesion is not really coming up, so I'm not 100% certain that the lesion we are a little bit more concerned, we are going to be able to remove it and block. So obviously then if you have the facility in your department to do an ESD, it's a small ESD, it's not going to take a lot of time, and at least you ensure that the lesion is removed and blocked. Do you agree?
I agree. I think ESD would be the right strategy here.
Great. Okay. Well, we just saw a case there with a lot of clinical relevance, and I think I'm really delighted to be joined by a truly expert panel today to talk through these cases. You did hear about them in the presentation, but here they are in the flesh. We've got Maria Polisi joining us, Raf Bishops, Pradeep Bandari, and we're absolutely delighted also to have Cesare Hassan joining us, not from Milan, but all the way from Kansas. So hopefully we'll get Cesare up on the screen shortly. But just going back to that case, we did talk about demonstrating clinical value, and I think what you saw there was an example of the detection of a very subtle advanced lesion. We were just talking about the actual histopathology of that lesion. It was resected by ESD en bloc, and there was a focus of high grade in there. So a very high-risk lesion for that patient. Cesare, I hope you've managed to have a coffee there in Kansas, so thanks for joining us early in the morning. You know, you've probably published more evidence on this topic than anyone else, and my question to you is, you know, what do we need more for people to start using AI-assisted polyp detection software? Do we need more trials? Do we need more meta-analyses? What are the barriers?
So, Omer, I feel that you explained very well in your introduction that there is uncertainty on whether AI help only in detecting diminutive non-advanced adenoma, or also advanced lesion. And I feel that this uncertainty is still somewhat underestimating the value of AI. For instance, looking at this case, of course, I'm happy that the CAD eye detected this very flat advanced lesion, but maybe we should be honest, and there may be better way to identify this lesion. For instance, you realize that most of the time the lesion was detected only in a very small part, but probably like in Barrett, and there is Pradeep and Raf, we would like that flat lesion would be completely how you say, bordered by the AI, and then the endoscopists were correctly talking about whether this was a JNA to A to B, blah, blah, blah. And then maybe you would like an AI to tell you whether this lesion has a JNA to B in its most advanced part. So I guess that AI is already done extraordinary step ahead, but maybe for a complete success of AI, we still need to improve it, especially for the detection and also for the way on how advanced lesions are detected.
Thank you, Cesare. So I think you made a really important point there. And I think following on from that, the question I get asked a lot is, who is this software for? Is this for everybody? Is this for the non-experts? Is this for the experts? And Maria, I'd like to go over to you because I know you were involved in that Cadillac study. And, I have some colleagues in my department, they've got ADRs of 70%. They say, you put an AI-assisted detection software in my room and maybe I gain 1 or 2%. What difference does this make? So what's your take on that? Who do you think should be using this software?
So the experience we had with the Cadillac study and as well another study that we have run in Lynch syndrome patients, but both studies were multi-center and with people devoted to colonoscopy and to detection, but not like 3 experts. It was maybe 14 people in one trial and 30 people in the other one. So that means that could be the average good endoscopist, not like the endoscopist, but something that we all want to have in our units. That's what we are saying, that everybody should be there. And in those both trials, CADI didn't provide any real benefit, let's say. So then, well, some people say, well, that is for these people you have in your department that never reach the standard. But for me, it's difficult to understand this rationale behind that, because the people that don't reach the standard, probably they don't have a good withdrawal technique. So at the end, I am not so sure to what point AI will be able to solve all that is related with that. So I think that this is an open question. I really don't have the answer, and I think we need to understand a bit more also on the impact of that kind of software on your behavior as well. And I don't really know yet the answer. I don't know the other ones.
So yeah, I think building on that point, I think there's always this question, isn't there? What's the bigger relative contribution? Is it exposure errors? Is it perceptual errors? Maybe there's a slight difference between the upper GI tract and lower GI tract. So there is definitely this human AI interaction, but also there's a degree of maybe some difference between the software and what's been used to train them. I know you've been involved a lot in developing these types of software. What's your opinion on how important is the training data set and that in terms of real world application? And is this software going to get better?
That's a very good question. If you talk to people in the horse industry or dog industry, they'll always tell you, look at the breed of the dog, where the dogs come from, and then you put your money on it. And that same thing applies to all these AI machines. You need to look at what videos were fed to the AI. AI will be only as good as what was fed to it, because it will not recognize things that were not fed to it. And that's very difficult. For a normal endoscopist, we cannot find out what was fed into that software. So there will be differences between these softwares for sure. But our experience is when it comes to detection of polyp, more or less all the available softwares are 90% plus. So I don't see much difference between in CADI aspect of most of the commercially available softwares. But when it comes to characterization, I think it's a very different game. And we did some work which shows that everybody is focusing a lot on sensitivity. So sensitivity of these CADX systems is high, but specificity is all over the place between the different softwares. So if you're going to implement resect and discard strategy based on the current CADX, I think there will be a lot of issues, and we need to understand the implications of this before we put it into practice. So yes, there's definitely a difference when it comes to CADX.
Great point, and actually on that point, we're going to go very nicely into a CADX case. So we'll just present the next case, if we can get the slides up. It's a combined detection and characterization case using Medtronic's GI Genius. And I think what we'll demonstrate in this is the importance of the human-AI interaction. So we've got a 50-year-old male, had an index colonoscopy 6 months ago, and the endoscopist found 2 large and 1 small sessile serrated lesions, which they removed. They asked for a subsequent endoscopy just to check the site of the large piecemeal cold EMR that was done for the sessile serrated lesion in the ascending colon. The kit that we're going to use today is the Olympus EVIS X1 processor and the 1500 colonoscope. We've got a distal attachment cap, as we mentioned, Medtronic's GI Genius and the Boston Scientific Captivator Cold. So really what we're really looking to focus at here is, first off, is using image enhancement to characterize polyps, using obviously the virtual chromo, but also dye-based chromo sometimes to improve optical diagnosis, and again, getting familiar with how we best interact with the AI software. So let's go into the case. Using the latest GI Genius AI detection system, along with the Olympus EVIS X1 processor and the 1500 colonoscope. And today, hopefully, we'll demonstrate both its detection functionality, the CAD-E functionality, and CADX, its ability to optically characterize the histopathology of the polyps.
We're just now in the ascending colon, and as you'll see up at 12 o'clock, we can see the scar very nicely from the polypectomy performed by the previous endoscopist. What's reassuring actually is that the GI Genius is not flagging up any alerts that suggest that there is residual polyp. We can go close and have a look in near focus, but here's a very useful function of the AI system, particularly in inspecting previous resection sites. We know that sessile serrated lesions, particularly from evidence from the CARE study, have quite a high incomplete resection rate. And so it's really important that we inspect these scars very carefully. And we'll switch over to narrowband imaging. I'm quite happy here using narrowband imaging to say that there is no obvious recurrence of this scar. Now, the question is, are there any additional lesions that possibly have not been identified at the first procedure? And as you can see there, GI Genius is giving us a very brief flicker there on the right-hand side at 3 o'clock. And actually, you can see that this probably is a sessile serrated lesion that was not seen at the first colonoscopy. And quite nicely, you can see with the characterization function, it is demonstrating that this is a non-adenoma, I would agree. So let's switch over to narrowband imaging. So what we can say for this polyp is that firstly, if we consider the NICE criteria, first feature is the color. Color is probably the same or perhaps even lighter than the background. There are isolated few lacy vessels, and essentially this would make us consider that this is a NICE type 1 polyp. But then if we also apply the WASP criteria, which are the criteria to optically characterize a sessile serrated lesion, we can see that it has a cloud-like surface in irregular shape. I think you'd agree with me that there are quite indistinct margins. And probably you can see some dark dots within the crypts. Now, ideally, I'd probably like to see the NICE type 2 2O pit patterns to confirm this, but I think on the basis of the NICE type 1 and the WASP criteria, there's enough to say here that this is very likely to be a sessile serrated lesion. Now, what we will do next is we will apply some acetic acid what the acetic acid does. We're very used to using this in the upper GI tract, particularly in Barrett's esophagus. Concept is quite similar in the colon. There's some evidence, in particular some randomized controlled trial evidence, supporting its use to increase detection of sessile serrated lesions in the right colon. It is a mucolytic, but it also reacts with the glycoproteins, which are particularly rich, in particular the goblet cells, in the sessile serrated lesions to give you a beautiful aceto-whitening effect. And the benefit of that is not only it may aid with detection, but also it helps us delineate the boundaries very nicely. So Suzanne, if you can just spray that for me there. Keep spraying. Keep spraying, keep spraying, keep spraying, spraying. Stop. Like if you see that beautiful aceto-whitening effect of this sessile serrated lesion, it's been nicely delineated, yeah. And I think with the aceto-whitening effect, what's quite nice is you can probably appreciate these type 2O open pits a bit better, right in the center. By lifting the sessile serrated lesion, we'll get a very nice contrast with the indigo versus the acetic acid and the aceto-whitening effect. So we're just continuing our withdrawal here in the transverse colon. And there we've just seen a brief flicker suggesting there may be a polyp under that puddle. It does appear that there is a diminutive polyp here, making an optical diagnosis slightly challenging as we've got some slight instability from the pulsation of the abdominal aorta. But if we persist, this system has predicted in white light this is an adenoma. If we switch over into narrowband imaging and get a still freeze, I would agree that based on the NICE classification, this is a NICE type 2 polyp. We see overall that it has a slightly darker background due to the brown vessels, which are surrounded by white branch structures. So agree, this is diminutive adenoma. So we're just continuing our withdrawal here. We know the patient is now one polyp short of serrated polyposis syndrome. And actually there we can see a persistent flicker on a small, subtle, flat elevated region. Remember, the characterization process is dynamic, and as the GI Genius is building up its confidence over successive video frames in white light, we do see a prediction there of non-adenoma. If we swap over to narrowband imaging now, you can see the nice advanced optics in action here from Olympus's near focus function, and indeed this does look like a nice type 1 lesion with no clear vessels. It appears to be the same color of the background, and there's an absence of any uniform surface pattern. There are potentially some additional WASP criteria there as well, an indistinctive border, clouded shape, and slightly irregular margins. So this does appear to be a serrated type lesion and could be a sessile serrated lesion. Sometimes actually it's easier to characterize these lesions in the normal focus mode, especially with Olympus's extended depth of field technology. And you can see here both in white light and narrowband imaging that the GI Genius confirms a prediction of non-adenoma. So this is proximal to the rectosigmoid, and indeed if this is a serrated polyp, this would be very significant for this patient. Start injecting there for me then. Now you could argue that we could just cold snare this. Yeah, stop, kneel back. Yeah, then we'll go to cold snare. I do find that the submucosal injection just gives us a additional benefit of making sure that we've got a complete sigmoid colon. And open snare. Start closing that. Yeah, cut. Nice. And what we can do is after suctioning the polyp out, we can just use the water jet to check the margins, and you can see actually GI Genius agrees with me that this polyp has been entirely resected. It's not showing up any bounding boxes. So we can be quite confident about a complete resection there.
Okay, so I promised you we're going to talk about clinical value at the end of every case. So I think we saw the detection there added clinical value because you had that extra subtle serrated lesion at the end that meant this patient qualified for serrated polyposis syndrome. But I want to talk about the value of CADX and characterization now. And a lot of people will say, who cares? You were going to remove all those polyps anyway. So I'm going to go to Raf actually for this one. Raf, where is CADX really going to add value? Is it going to be in diminutive polyps? Are we ever going to implement an optical diagnosis strategy for diminutive polyps? Is AI the answer?
Well, I definitely think it is. I mean, if you look at the performance of optical diagnosis outside of study settings and outside of experienced endoscopists, it's really poor. And as you said, many people don't even care about it because they're going to send everything to pathology. But that actually raises significant costs. So that comes with a lot of costs for the society, also environmental. So you could argue that why take out all these smaller polyps? I don't think it should be limited to 5 millimeters. I think we should do better and even go up to 10 millimeters, for instance, because also there the chance of having cancer is also quite low. And I think there's a huge potential benefit. And the advantage is that after the procedure, you can immediately give the report to your patient and say, okay, we found so many adenomas. I think people who do optical characterization already do that in their reports, but I think that's still a minority. So I think that's just a modern way, I think, in the future to do colonoscopy, to make the diagnosis and to be helped by AI there. And I think there's the clinical benefits for most of the endoscopists to be assisted by artificial intelligence.
Yeah, I like this comment about sustainability. People keep throwing that fact at me. Is it 3 histology pots is equivalent to 2 miles in the car with your CO2 emissions? So we're doing endless diminutive polyps every day. I think we do need to stop this, really. So Pradeep, next question then is, you know, I have a lot of trainees, you have a lot of trainees joining your list, and you spent a lot of your career introducing all these classification systems for optical diagnosis. You know, should we still be teaching these to our trainees, or is the AI going to do it in white light?
That's interesting because my gut instinct tells me that there's too many classifications and everybody comes up with their own named classification. Every technology comes up. But the basic principle behind all these classification is the same. So I think we should get rid of all the named classification, but still continue to teach the principles of optical diagnosis of how to assess the vessels and surface pattern. Although in the near future, AI and CADX will take over and will become very good, but machines make error. Will always be a possibility. So if you don't have the background knowledge, then that becomes a serious error. So I don't think we can get rid of that training. I think that training has to continue, but we simplify all these name classifications, bin all the names away, and go to some training that this is how you assess the vessel, this is how you assess the pits. That's it.
That's the basic classification.
That's a basic classification. I'm not here to promote basic, but I'm saying we should be focusing on very basic facts.
Yeah. It's like the pilot, you know, even though the plane does the landing for you, you still have to be trained how to do the landing every so often because, you know, the automatic system can go wrong. Yeah. So Cesare, I want to go across to you because we talk a lot about diminutive polyps. But what about the other end of the spectrum? You know, we've got more and more advanced imaging. We're getting more and more early neoplasia we're detecting. And our meetings are full of these cases where you're challenged and you say, what do I do for this lesion? Am I going to do an endoscopic resection? Does this need surgery? Do you think CADX will ever play a role in this use case? And how close are we to that?
Yes, Omer, I feel that we started from diminutive because they are much more prevalent and it's easier to train the machine, but there is a limited value here. On the other hand, in advanced lesion, as the one we saw in the case before, and for Barrett, for instance, there is a lot of clinical value in deciding whether it is a T1 or not, or whether it should be removed and blocked or not. So I feel that the clinical value of AI is still ahead to come, but eventually it will come. Unfortunately, the limited prevalence make to create a training database very, very challenging.
Yeah, I agree, Cesare. I think we really need some nice global collaborations on this topic. So I'm going to go next to what I think is the elephant in the room, which is everyone does this every day in endoscopy. We don't talk about it, which is sizing. It's built in and cooked into all the surveillance guidelines. It's built into our resection strategies. And we know from the studies we get this wrong as humans. So we're just going to play a video to try and look at some solutions to this problem. And I think definitely we're looking at technological solutions. The question is whether AI will solve this, but I'd like to show this nice video next of Fujifilm's Scale Eye in action. This is a laser-based hardware technology that also uses some computer vision software. It's not strictly standalone AI, but what it should allow us to do really is use push-button technology during endoscopy to make an instant diagnosis. So this again was a serrated polyposis case I had a couple of weeks ago. And interesting, the trainee was with me and thinking everything was 10 millimeters, but actually when you use the Scale Eye, you can see you can use either this circular shape or a linear shape. It's quite a dynamic process and it can be very helpful. So Pradeep, I know you've done a lot of work on sizing. Do you think this is an important issue and do you think AI is going to come in and maybe solve this or help us at least?
Oh, I think sizing is a big problem. It's a big problem for men than women, but the focus on the polyp sizing, I agree. Humans are prone to error. It's a big, big possibility. And you're so right. We have so many strategies based on size, and we have no means of measuring the size. Yeah. So when we've done work with endoscopists, experts, experienced trainees, everyone gets it wrong. It is not that you are less experienced, so you get it wrong. Even experienced endoscopists get it wrong. So if you're going to introduce resect and discard and develop very good CADX and leave this behind, then we cannot implement. So definitely, this is a very good technology. I'm really impressed. This shows the power of technology, how it can measure. But I think maybe we are complicating a very simple problem with a very big solution. So we need to simplify this. We've used this as a fantastic, the measurement is accurate. I think this will be very good for big polyp, where we're trying to make a decision about en bloc or not en bloc. There, this will be a very useful technology. But for making it diminutive, I think we need to simplify the technology a bit more.
Maria, I'm going to give you a tricky question now, which is, if we've been getting this sizing wrong for a long time, we bring in AI or software that makes this easier. Do we have to rethink our surveillance guidelines? You know, if actually all these polyps are the wrong size, are we going to change all our guidelines? What do you think is going to happen?
I mean, for sure, but we won't be able to do it like very fast because the problem right now is that we don't really have a gold standard for sizing because there is a good work done by Daniel von Rotten and other people. And you see that we really don't have it because there are many moments where we do something that changes the size, no? From the moment that you cut, for example, with cold snaring, we take a very long rim of normal mucosa, so then everything that we will count from now on will also change the surveillance guidelines, because probably when we were removing the polyps with hot snare, we were just taking the polyp just in the rim, while now we are taking a larger side of it. So, I mean, this will be impossible to look because all the studies that were looking to metachronic neoplasia in large cohorts, they were based on the size, and the size that was in those studies sometimes was the histological size, and other times it was the endoscopic size. So we really don't know what was going on there. So maybe it will change, but at least it will be more precise than what we were based on right now.
Raf, what's your practice? You know, what do you think of this?
Yeah, I think it's a really important point because actually there's a little bit of a pervert effect of using AI. If you improve quality, you're going to do a better job. Mm-hmm. The number of adenomas per colonoscopy goes up. And by consequence, if you follow the guidelines, you're going to do a shorter surveillance interval, although you did a very good job, removed everything that's there. So I think definitely in the future, provided we have some certainty about the high quality of the endoscopy that's been performed, we need to re-look at that because presumably I think you would have done a better job finding 10 polyps than instead of finding 2 adenomas or 5 adenomas and then saying come back in 10 years. And if you do a very good job, you have to say come back in 3 years. So that doesn't make sense, I think. So we really have to think that along with the size, maybe that it will not be so important after all. So I think a lot of the guidelines that are out there now take into consideration the known miss rate. And if this is solved with a high-quality AI-assisted endoscopy, well, I don't think that holds anymore, and then we need to revise that.
I think it's a really important point because everyone keeps talking about cost and the additional cost of AI, but we've got to think about some of the savings there. And I think that's a major place where AI could have impact and readily be adopted into departments. I think we're going to move on now because I think we've done a lot of work in the lower GI tract and we mustn't neglect the upper GI tract. And I think, look, there's been a lot of development in the East for understandable reasons because of prevalence, but we mustn't forget this is a huge problem in the West. We're getting increasing awareness, especially with the post-endoscopy upper GI cancer audits and showing actually this is a massive problem. And we're going to go now to a Barrett's surveillance case. We've got a 70-year-old male. He's had previous treatment for Barrett's. He actually had an EMR back in 2021 for an intramucosal cancer with no high-risk features and followed by endoscopic eradication therapy with RFA, which was confirmed on histology to be successful. He returns now for a routine surveillance procedure. And the kit we're going to be using for this case, we're going to be using the Olympus EVIS X1 processor with a 1500 gastroscope, distal attachment cap, which can be very helpful in these cases, and Odin Vision's CADU cloud-based AI system, and also demonstrate an EMR with Cook's Duet multiband mucosectomy device. And the learning objectives really of this, of course, the principles are always important, no matter what AI system you have, that you must perform a high-quality Barrett surveillance. We'll demonstrate the benefit of both virtual and dye-based chromoendoscopy with acetic acid, which I know Pradeep's really pioneered. And then really we need to get familiar again with our relationship with the AI technology and how we get the best out of it. So let's go straight to the case. So today we're using Odin Vision's CADU AI system to assist with the detection of Barrett's dysplasia. This is cloud-based technology, and we're using this alongside Olympus's EVIS X1 processor and the 1500 gastroscope with a short distal attachment cap.
So we've just performed a retroflexion, and you can see I haven't even cleaned the cardia properly yet. The CADU system is flagging up an area, a suspicious area, and the longer you look at this does look like a slightly elevated Paris 2A lesion. We'll switch over to narrowband imaging now. The CADU system isn't necessarily designed or intended to be used with narrowband imaging, but we'll just have a bit of a closer look at those mucosal surface and vascular architectures in this region. If we could just clean and get a bit more of a stable view. And interestingly, the CADU system is continually flagging up this area even in narrowband imaging. And I think you'll agree with me, there's definitely some irregular vasculature just at the bottom there at 6 o'clock, this Paris 2A lesion. And this is slightly concerning for a recurrent lesion. We'll just switch over to forward view now. We're having a look at the irregular neo-GOJ. It's important to get in there to the hiatus hernia and suck some air out so we can have a look at this cardio region where we know this is the danger zone for occurrence. And just as we have a closer look here, we see again the CADU system in white light is flagging up this same region that we saw in retroflexion. It's a very slightly elevated Paris 2A region. Again, in narrowband imaging, we see some irregular vascular architecture just in the center there of that nodule. And we see another really important feature of the CADU system here, which is really incredibly helpful. We can see on the still freeze now of the image that the CADU is providing an overlay or delineation of the area of dysplasia. And actually on the left-hand side in the smaller image, frozen, you can see that there is a green dot which represents the geometric center of the delineation, but importantly the blue dot which represents the area that has the highest likelihood of dysplasia. We can always use some acetic acid easily sprayed with a catheter just to help confirm our suspicions, and if we just go closer into the lesion, what you can see, first of all, very nicely here is that the CADU is continuing to flag this up with acetic acid, and actually looking at the mucosal surface patterns in narrowband imaging, we see some disorganized pits. And if we swap over into conventional white light, what you see very nicely is there is some loss of acetowhitening in the center there of that Paris 2A lesion. Okay, so we'll plan to perform an EMR of this lesion, initially marking it with snare tip soft coagulation, followed by the use of Cook's Duet multiband mucosectomy device. It's my own personal preference to turn off the CADU system, which is very simple, just so that it doesn't interfere with the therapeutic phase.
Okay, so I'm sounding like a broken record here, but we're talking about clinical value again, and you saw there a very subtle lesion, very nicely detected with the assistance of this AI technology, very few false positives, and in a very, very high-risk case, actually. So I want to go across, actually, to Pradeep, because I know, Pradeep, you've done a lot of work in Barrett's dysplasia, but also especially with AI. And the question, you know, this is, I'm going to make a controversial comment. I like to be controversial sometimes. I think if we're honest, we've maybe picked the low-hanging fruit with colonic polyps, and the neoplasia in the upper GI tract is a lot more subtle. And I think this is where AI probably can make a big difference. What do you think? What can we expect for AI technology in Barrett's? How's it going to make a difference?
I agree. I mean, I was going to answer, you know, you asked somebody, what will it take for the community to start using AI more? It is this kind of pathology. If we start picking up subtle pathology like Barrett's neoplasia, early gastric cancer, squamous cell cancer, which we genuinely struggle in finding them, that's when adoption of AI will become more widespread. You saw the power of AI. Barrett's neoplasia looks very different from colonic polyps. Developing AI for colonic polyps is a lot easier than developing for Barrett's, early gastric cancer, or squamous. They're very, very challenging. Numbers are less. The pathology is very subtle, and the certainty about the margins of all those pathologies also very uncertain. So the whole game is very challenging, but we are seeing the power of technology, and I think it is happening. It just needs to get a lot more mature for people to replace the biopsy. But we already seen the proof of concept that this can be done, and that's what's happening right now, that the concept has been proven. This concept now just needs to go to the next step to become a lot more solid in evidence, and I think that will change our practice.
So Raf, building on that comment, you know, I'm going to ask you the question, who is this software for? I know we asked for it in colonic polyps. I think it's a very important question here. Is the future going to be that, you know, diagnostic Barrett's cases are going to be done by someone anywhere with the software, and then they say, oh, look, I took a biopsy, there's a high-risk lesion, I'll refer it to Raf Bishop's. What is the future? Or is this for experts as well?
No, I think it's definitely the first scenario that you described, absolutely. But again, like you pointed out for the colon, even more importantly here is the quality, right? I've seen a very nice example from Jack Berkman, where just a wee bit of mucus on a lesion just misses the lesion with the same system that detects it when the mucus is removed. So, well, this is also because we're just starting with this, right? So, and even as experts, we need to clean everything to see those subtle lesions. So why would we expect that a system, if you do a quick whiplash through the esophagus, we cannot expect the system to pick it up. So we need to have like that speed meter we have for the colon, right? and also something that assesses the cleanness of the surface in order to make that work. That's going to be even more important. But I agree totally. I mean, this is something that is very challenging and that has really the potential to change practice and pick up lesions early that are now missed. Because the problem is, even if we have false positives here, it's not so bad, because now we are supposed to take many biopsies, which many people don't do. But that would give more certainty about the fact that it's in fact a negative endoscopy, right? So the sensitivity is obviously crucial. And I'm not really sure what the trade-off for the specificity is. I think around 60% will be good enough, right? Because that would already decrease significantly this redundant number of biopsies that we're always taking in these Barrett's cases. So that's the major advantage there.
I'm going to pick you up on that point, though. I'll go to Pradeep, because it's this Seattle protocol. You know, every time someone comes in the room, I get people with big brains, you know, engineers, computer scientists, they come in and they watch us do a high-quality Barrett's assessment, use image enhancement, use everything, acetic acid, and at the end you say, I'm going to do this Seattle protocol and randomly sample less than 5% of the mucosa. Pradeep, are we finally going to be able to get rid of this with AI?
I agree. One of my big missions in my life for a long time is to eradicate the word non-targeted and random from endoscopy. I think the business of non-targeted biopsies, random biopsies, doesn't matter, Barrett, stomach, colon, from everywhere, it should be out. And AI is the way forward. So whatever AI does, it will definitely improve, change our practice from non-targeted, stupid protocol-driven biopsies to targeted, more meaningful biopsies. Yes, there will be false positive, as you said, we cannot get rid of that, but the yield from these biopsies will be a lot more. So I think the future is AI-targeted biopsies or AI-targeted therapies.
Yeah,
in combination with biomarkers.
Well, yes.
We've got to work hard on that one. A quick question for Cesare, although it's never a quick question because it's a slightly tricky one. But I think in the East, we're seeing some beautiful new AI systems coming for early gastric cancer, early squamous neoplasia, ones that make you quality assure, so you do the systematic screening protocol. Now, these are in high prevalence settings. Do you think we can bring these across to the West, or do you think the endoscopist is going to say, well, there's just too many false positives, you know, we don't see enough gastric cancer here? What do you think?
Let's see, because the advantage of this East software is that they are trained on a lot of cases, because they have thousands of early gastric cancer, thousands of squamous neoplasia. So I'm not necessarily expecting a worse trade-off between sensitivity and specificity. And if we agree with Rafa on a 60% specificity threshold for upper GI, I guess that most of this East software will match this cutoff. So, Omer, I'm very optimistic about this East software for upper GI, because the prevalence of lesion and the magnitude in East allow a better training for the software.
So maybe it brings us back to this issue about quality assurance. I think it comes back to that. If we can do a high quality upper GI endoscopy, then actually the software will be able to do a lot of the image recognition for us and detection. But I'm just going to take the debate forward a bit now, because I think it's important to sort of wrap up this session and think about bigger picture. Because I think in reality, AI is at its infancy. We have picked the low-hanging fruit, and I think the exciting developments are going to come in the next few years. And I think what a lot of us are talking about is maybe quality assurance and moving on the debate from detection and characterization, and instead having these sort of comprehensive softwares that do everything for you. So, Maria, what do you think? I mean, do you think we're going to get more benefit with having these sort of quality assurance software? So, giving you feedback about your mucosal exposure technique or blind spots, and will that make a bigger impact in practice? What can we expect?
I think that AI, and I hope AI will help us in other issues as well in endoscopy, like all this burden that we have of administrative work and this multitasking that we have to remember so many things while we are doing a very specific thing. So there are many ways that it can help us and outside this diagnostic and characterization field. So I think we need to work on that, because probably we have been thinking that it was impossible to have that, so we haven't been asking for it. But if we have the possibility of having that now, we will probably all want to have that kind of help in our daily practice as endoscopists.
So maybe with the reporting software, we'll get more time. Pradeep, what are you going to do with that time? Another 10 endoscopies? What are you going to get your fellows to do?
Well, that will make business case very easy to make. That will improve the adoption of AI for sure, because you can justify that your efficiency of the department will go up. So I completely agree. For adoption of AI, that's essential.
And do you genuinely think if we get quality assurance systems in, let's say the KPIs that we have, the very robust KPIs like ADR, could we potentially see a future where we have AI-driven mucosal inspection scores? Is that going to be a game changer? Could we actually, even as Raf was alluding to, maybe even increase the surveillance intervals? You have an AI rubber stamp procedure, we're saving resource. What do you think? Is this coming?
Oh, definitely, 100%. I think the KPIs that we think right now will be redundant in the future.
Totally.
We will not be measuring ADR and polyp detection rate. These are surrogate markers of mucosal exposure. If you have AI telling you that you'd seen 100% or 90% of the mucosa, we don't need to know your ADR, because my ADR in my unit is 100%. I only endoscope patients with polyps. So what value does that ADR carry? It has no value. So I think AI-driven KPIs will be different, and mucosal quality of inspection of mucosa and the quantity of inspection, once that is sorted out, we're done.
And Raf, what about therapeutic endoscopy? I've always felt therapeutic endoscopy has been left out of the quality movement, and now when we're realizing a lot of these lesions, maybe they were incompletely resected, etc. Do you think we saw a little bit of a demonstration there about AI in third space? What about resection and quality parameters there?
I think for me, in the future, but it's not going to be for next year, really determining what kind of treatment would be optimal based on the endoscopic image would be very helpful. Delineation, I don't think that's going to work very well, not with the way we work nowadays. And anyway, if you're going to do ESD, you're going to take a 1 centimeter margin anyway, like we saw in the case from Rosa this morning. So I think mainly to help, and also bringing it back like to the daily endoscopy, now what we have a scenario usually is they see a big polyp, they take a redundant biopsy, which is not going to drive the decision making for that patient. They don't take the time to take proper photo documentation or a video that would help us to know what to do. So I think if AI could step in there to help to get good photo documentation, give again quality feedback on that, and then also drive the decision, say the most suited therapy for this patient is a surgery, or it's very suspicious for deep cancer, make sure you do full staging before you do anything, something like that in that direction, that can be very helpful also to make things more sufficient. And that's more futuristic. But again, I think the first step is to assist again with good photo documentation, which already can render everything more efficient, because now what happens very often is that you don't get any photo documentation. They say, I found a big polyp and it transfers, and then you say, okay, you have to come back for an next colonoscopy, have another bowel prep. We need to assess. If it's a small lesion, which sometimes is the case, you can take it out. If not, we have to reschedule it for a longer procedure. So this is kind of this redundant number of colonoscopies and procedures and burden for the patient that we could avoid if we were to have a system like that.
Pretty. A very quick point to add. I feel I want to be more ambitious than that. So look at the AI-driven automatic car systems. They drive the car, they know where the pillar is, the post is, the next car, and they automatically stop. So there's no reason why we can't put an AI sensor in my ESD knife. It will recognize where my muscle is, it will automatically abort the current.
You get an electroshock.
Yeah, it's about business case, who will pay for that. Once that is sorted out, that will be there.
Okay.
And I'm wishing for that.
Anything is possible.
We're going to have to close the session now, but listen, I really want to say thank you to our expert panel today. And the question at the beginning of this was, is AI mainstream? Yes, I think it is. It's here to stay. We've got to work out as an endoscopic community how we work best with this technology to really get the best out of it. And I think next year, George Webster's going to have to give us a whole afternoon for this session, because there's going to be so much to talk about. But thank you all for joining.
Thank you.
Thank you.
See you.
Okay. Fantastic session, Omar and colleagues. We're now going to change tack a little bit, and instead of all this clever science and future gazing, we're getting back to those scenarios that all of us in our endoscopic practices get presented with, whether in an on-call, middle of the night scenario, or as part of our routine lists. And this is the issue around stents or other foreign bodies that are stuck, and how do we get them out? So we're going to start with a focus on proximally migrated biliary stents. We've got 3 cases to show and then discuss. The first is a 65-year-old lady who had a fully covered self-expandable metal stent inserted as part of tamponading a sphincterotomy bleed, and maybe we'll chat about how we should manage sphincterotomy bleeds. The second is a 37-year-old man who had an ERCP at the time of investigation of a PET avid lesion in the bile duct. And the third is a 62-year-old woman with complex stone disease and a previous choledoduodenostomy with a rendezvous for biliary access, again, who actually had a sphincterotomy-related bleed and a fully covered SEMS inserted. So we're now going to show all 3 cases back to back and then start discussing.
Okay, so here we are, doing this procedure with Charlotte Knox, one of our excellent Aussie fellows. And this was supposed to be a straightforward stent removal and then maybe a stone clearance. This patient previously had ELCP for the removal of stones, had a sphincterotomy bleed that was managed with tamponade with a fully covered stent, and she's now returning to just take the stent out, and it's migrated upwards into the sphincterotomy with a slight complication that papilla is sitting within a diverticulum. I think these stents are almost always successfully removed with stent grabbers. I would keep the wire in, and I think the reason for keeping the wire in here is that it just can help you direct the stent grabbers. Now, these are very stiff, so Charlotte's showing very nicely here, very stiff instruments like stent grabbers. The bridge will not fully elevate. That's nice. So you might be all right there, but you may want to get below it. You may want to try and push your scope a little bit down to get, that's nice. That's very nice. That's it. And a bit of jiggling, and you might find that it get nice. Okay. And then a bit of forward pressure on that. So push up against it. Nice. And now close your snare. You might have it. And then slowly come back. Slowly, slowly. You've certainly got some bit of it. Try and keep the line, a bit like if you're removing the stone. You can do the same maneuver, actually. Push in, a little bit of rotation. I mean, this is, if we're going to win, this is how we'll win. So I think I just keep confidence with that. And you're securing the shaft of the stent grabber with your left hand. That's good. Let's have a little wiggle. Thank you, thank you. I think actually here, having the wire in also, it sort of lines the bile duct up as well, doesn't it? Right, so what I'm doing here is trying to get right below it and tip right up. Now, let's just open there. Got to get that. Close there. No, maybe got something. Let's just see. Okay, so slow and steady, slow and steady. Screen, please. Let's just see, let's see. Slow and steady. Okay, let's get up close and personal again. Tip right up, a bit like you're removing a stone. Secure it, secure the shaft of the stent grabber to my left hand, and then tip down, clockwise torque, push in just to keep the line of traction. Nearly there. Come on. Slow, steady. There we go. There we go, there we go. Screen, please. Yeah, I'm off there. So I'll actually come out with the scope and then we'll go back down. That's great. So I think actually a very interesting case. Thought it was going to be entirely straightforward. And a few teaching points about removing proximally migrated stents, whether they're metal.
56-year-old lady who presented to us actually back in November 2022, complex stone disease and very difficult cannulation. Ended up having a cholecystoduodenostomy via hot axios with a rendezvous procedure, and then biliary access subsequently gained, sphincterotomy, subsequent ERCP, followed by a big sphincterotomy bleed that required placement of a fully covered metal stent. Then referred on for cholecystectomy and sadly lost to follow-up. She's now had her cholecystectomy, but has re-presented for a stent pull somewhat later than we would have liked. And interestingly, the stent, so you can see a double pigtail plastic stent here, but we think she's got a metal stent that has proximally migrated. Sungjae's just approaching and not unreasonably is going to cannulate alongside the stent retrieval options. There are a few here, but we may end up requiring spyglass as one of the retrieval options if the stent doesn't come by other means. So Sungjae's done a great job, and he's managed, it looks like, to fly up through the stent. So you're going to catch the mucosa there on the right. Yeah, try that. Yeah, well done. We're using the Pentax DEC duodenoscope here. It's got 4.2 working channels, so should be able to get that 7 French double pigtail out through nice and easily alongside the 035 wire. Can you do a bit of right wheel? Just try and bring the papilla into view. Stop screening. I think let's go with a snare because we don't want to push that through and cause mischief. You can see the snare going up the duct now. So yeah, come down a bit more. So just close the snare a little. Yeah, keep screening. No, that's fine. Keep screening. Okay, all right. And then try and push up the snare there. Just be careful of your snare is kind of partially out. So you're going to have to go back into the duct. Close a touch. Yeah, close about halfway. Okay. And again, the difficulty is here because we're so far away, we can't get enough of the stent open below the stent to try and grasp around it. Inject. So we are getting some stent moving, coming down. So at least it's not embedded. Store that, please, and keep screening. All right, now let's try balloon up there, please. Yeah. So now we're going to inflate the balloon within the stent and see if there's any joy in trying to pull that down. It is coming, but I'm not sure it's going to come enough to get us through the papilla. We'll try our stone removal technique. Keep screening, please. Balloon down. Okay, so balloon up, 15. Okay, stop screening. Balloon down. Aha, so remarkably, having poo-pooed the idea of the balloon, it's done exactly what it was meant to do. So you can tell Dr. Webster that does work from time to time. Yeah, and picture there, thank you.
Yeah, well, good. As Taz alluded to, I've spent about the last 15 years telling all our fellows that a balloon, as a means to try and extract a proximally migrated stent never works, and he's shown very nicely how it may. But different techniques we've seen in those two cases. We did actually have a a case of using the cholangioscope and visually grabbing the stent, but that seems to have fallen off the deck. But Reem, your algorithm, don't say straight with a balloon, please. You are going to, aren't you?
No, I'm not. But I do like the way you described what to do, because I think that's often a lot harder to do. I think I either try blindly with a rat tooth forceps to grab it, or put a wire and then grab it, because as you said, it just helps see where you're going, under fluoroscopy, but then the line of sight, it straightens everything out.
Can I just ask you, do you worry about passing freehand forceps or stent grabbers up the bile duct?
I only use that if I can see the opening well, and it's sort of, the stent is there within reach, but you can't really grab it. Yeah. Otherwise it would have to be, you don't want to mangle the papilla too much.
Yeah.
But then if that doesn't work, I do the balloon.
Yeah. Well, listen, it was a great example there, and it worked. And Simon, the other technique that Taj, attempted there was the technique of a snare over the wire.
Yeah.
Is that something you've tried and used, and do you think it's
often difficult to get the snare to engage over the metal stent to actually grasp onto it to pull it out? As you said, it works well for plastic stents.
Yeah.
Easy to grab hold of the pigtails on it. But I think you just got to have all techniques available to you, like Taz demonstrated. The stent grabbers weren't going to work in that case, and he went through the algorithm of the other options.
CRE might work, and in very rare cases, what I've done, like after I've tried so many things and nothing has worked, I sometimes put another stent through it and then bring them back in a couple of weeks, just so that it.
You mean to sort of particularly to open the sphincter, just to sort of
and help you.
And two of those three cases were proximally migrated stents after a SEMS was put in to manage a sphincterotomy bleed. Do you use SEMS in that setting? And of course, one's putting in a metal stent, a covered metal stent there, when there's nothing really to keep it in place, because there's no stricture. Any techniques you use to see that it doesn't migrate, and do they work?
Loaded question. I think because there's no stricture, you want to make sure it at least is sort of 2 centimeters, or, usually they say you have to have 4 or 5 diamonds showing, maybe a little.
Never heard that.
Well,
a teaching point.
Boston
Very good.
Reps in America. What happened here?
No,
just to have it, because they do foreshorten a little bit. And so especially when there's no stent, you don't want it to foreshorten upwards. And so in someone like a GI bleed from a sphincterotomy, it doesn't matter if they down migrate, because it's okay. So I usually let them sort of deploy them intentionally more distally. I do use a double pigtail stent often, and I know there's not much data on that with preventing of migration, but it makes me feel better.
Sure, yeah, no, and we do too. So just to clarify, that is using a double pigtail stent with the idea that the proximal pigtail and the distal pigtail will sort of keep it in place. Just a little technical point with regards to that. Do you try to do anything particular with the proximal pigtail? In other words, do you like to just curl it conventionally in the common hepatic duct? Because sometimes I've tried to deliberately
put it into the intrahepatic.
Hook it into the intrahepatics.
Yeah, I think into the intrahepatics it works better. I feel like if it's just in the common bile duct or common hepatic duct, it'll probably fall down. At least it just isn't hooking up on anything, and there's more of a chance for migration. But I haven't looked at that data, but it just makes more sense, I guess.
Okay, and occasionally, Simon, we have, always a disaster, but we have referred in patients who have had either a fully covered stent that's been in for 18 months or an uncovered stent that's been in a shorter time and shouldn't be in there. Stent in stent approaches. Just tell us about them.
Yeah, so we've done a few of them now where you overlap a fully covered stent over the existing metal stent that's either embedded or migrated up to try and push the tissue out of whatever side holes have developed in a fully covered or the actual holes of an uncovered, with the hope that then when you come back a few weeks later, you free the stent up from the tissue that's growing into it and take both out in one go. And it sometimes works, and they don't really have many other options other than surgery,
Yeah.
which is big.
And I think we tend to say, you don't leave that second stent in for more than 2 or 3 weeks.
3 weeks, yeah, exactly.
And then have another go.
Yeah.
Okay, great. Excellent discussion. Well, let's go to the next case. No, I think we're not. Let's go to the next case.
There's a 400 retriever, stent retriever, also for plastic stents as well. But it's harder to...
So you mean the one that you screw into the end. I've never had a lot of
success with that. I usually use it to get through strictures sometimes.
Yeah, really,
but
what's
like,
to sort of drive your way
Is that like
through?
an Archimedes type engine?
Yeah.
Interesting.
Yeah.
That'd be a good thing to have.
Yeah, no, it's
you literally
like
have
our
to...
next case that we're watching, because it was actually quite difficult to get that out without putting it to pieces.
Yeah. So this case, 44-year-old lady had a very effective cystgastrostomy for a pancreatic pseudocyst. She had a double pigtail put through the hot axios, which, as you'll see, may have actually been a very good thing. On interval CT, the collection had resolved, but on going back in after about 6 to 8 weeks to remove the lambs, you can see in the bottom right image that the lambs wasn't seen, but the pigtail was still in place. So, Simon, we'll show your procedure now. We're using the Pentax therapeutic gastroscope, and you'll see the different techniques we used, including a Jaguar and a CRE dilating balloon, as well as the Steris grasping forceps. Let's show the case.
We're going to have a second attempt at trying to remove this stent in one go. So you can see that she's got a pigtail stent that goes through the hot axios into the collapsed collection, which is maintaining that tract. Okay, so we're starting off with just a balloon and a wire, so we're going to try and cannulate through the tract alongside the pigtail and hopefully through the axios. This has gone through the axios or alongside. There's a lot of pus coming out here. And what if you go up to 8.5 there and try and pull it out, and does it get stuck on the stent or... Yeah, so you've probably gone through a side hole of the stent and it's not through the middle of it. So I think it wouldn't be good to dilate it like that, because you might just break the stent up even more. If you're getting the scope right up against the fistula, you can see alongside this pigtail stent, you can see the hot axios inside the cavity. So we're trying to direct a wire through the lumen of this stent so we can dilate the tract. But because the stent's broken down a little bit, it's quite difficult to direct the wire through it without it going through a side hole. Stop screening. Balloon down. Okay, so we've got the wire within the tract, so we're just going to exchange that balloon over the wire so that we can do a 12 to 15 CRE dilatation of the tract, the hope being that we can then engage the scope into the fistula to pass stent grabbers and grab one part of the metal stent. Okay, let's put the contrast in. Stop screening. 12 to 15. Okay, contrast in and stop screening. Let's go up to 3. Yeah. 3 atmospheres. Screen. Currently at 12 millimeters. I'm going to go all the way up to 15 millimeters. Okay, so we've dilated the tract now, and we've got the scope engaged within it, and we're getting reasonable views now of the meshwork of the lambs alongside this pigtail. We're going to keep that in, maintain the tract, while we try and grab it with this stent grabber. Open. Close. We know that the portal vein isn't far away from this stent, so we need to make sure that the grabbers are going straight onto the metalwork, not something else. Close. Screen. Stop screening. Let's see what we can do with this. No. Open. Close. Part of the stent's now come out through the track, so we're going to try and grab that. Close. And part of the problem is that when we're pulling it out, we're pulling it in the wrong direction. So rather than just pulling back, I'm trying to now torque the stent out in the right direction. Screen. Screen. Stop screening. Screen. There we go. So the exos is now out of the gastric wall. We just need to retrieve that pigtail as well. So we're just going to get a really good fluoroscopy to make sure we haven't left any wires back inside the track before we take the pigtail out. So it looks to me like it's just the pigtail left there with no metal strands. So we're good to just take that out now. Close. Screen. That's now out of the collection. Thank you. There we go, we can see into collection. Doesn't look like there's too much bleeding, bearing in mind the portal vein was right next to it.
Okay, so, you know, I think it's very useful to have the chance to focus on, you know, problems related to otherwise perfect procedures. This lady did very well with her procedure. But potential long-term implications if we hadn't been able to remove that. Reem, have you seen problems with, well, general complications, but in this case, sort of impaction or migration with regards to lambs?
Yes, actually both. We spoke a little bit about this sort of offline, but I've had a patient that I put it in for a gastric outlet obstruction, and it's sort of similar to this, but I hadn't put a pigtail through. She came back with recurrent symptoms, and I was completely mystified why that would be. And when I went back in, I couldn't see where the lambs had been. It had just been pushed down, or pulled down, rather. And I sort of tried to probe. Like, I knew there should be some sort of connection, and tried to probe with a tome until we found a tiny, tiny hole.
Yeah, and Vinay, you have a lot of experience of getting us out of trouble, including with the sort of buried bumper cases, you know, post peg insertion, not anatomically, not completely dissimilar to this. If Simon's attempts hadn't worked here, and clearly surgery really needs to be off the table here, what other lessons from buried bumpers might you bring to the discussion for a case like this?
Yeah, so it's a really relevant question, because at UCH we've been seeing another little mini pandemic of buried bumper syndromes from PEG tubes. And the first point is education around managing these PEG tubes. I think if you get the first step wrong, you're setting yourself up to fail. So it's really important that patients, and often their carers, are told to rotate the internal bumper twice a day, to be honest with you. And if you don't do that, you do run the risk of the bumper getting buried below the gastric mucosa. So what we've been doing here is really using a modified ESD technique. So we use the Olympus dual J knife to really begin tunneling towards where the bumper is. And once we begin to see the white of the bumper, we then pass a snare through the bumper tract and basically remove it, but pulling back from the endoscope side, really. I have the backup, knowing that if there is a full thickness perforation, we can switch to the overstitch device and close it there and then. That's my get out of jail card, and that's perhaps why I may be kind of more courageous than others in terms of removing the bumper, but I think it's a nice backup, and maybe having surgical support as well in case. we found really good results with it, actually. And I think there was a similar device, the Flamingo device, that was once kind of touted around for a while. I think it was a bit of a glorified needle knife, I think, from in terms of an ERCP perspective. But I think we've had some really encouraging results with these patients. So really just using an ESD knife to really find your tunnel through and pull. Have you had any of these, Reem?
Not with an ESD knife, but I like the technique, and it sort of goes to show that you can use other devices from other techniques to help you out. And the sort of foreign body removals, for whatever reason, you just need to think outside the box and see what other tools that you have available.
And I think the quite nice, for me, the quite nice thing about this session is that, you know, it is a bit of an evidence-free zone. You know, it's a case of bringing our interventional skills to the patient in front of us, and that applies to the next patient. So let's go to the next case, if we could. So I think we're going straight to a case of a patient with a food bolus. Now we don't have audio for this, but this is a patient presents with, you know, acute dysphagia, comes in as an emergency. Here is the lump of food, and you know, not a complex video, but the decision by the endoscopist here was to push. So do we push? Do we pull? You know, I'm not quite sure whether there is any particular underlying pathology here. There often isn't, is there? I mean, there may be a Schatzky ring. There certainly wasn't a high grade. There certainly wasn't a high grade stricture here. And Vinay, back to you again. Push or pull?
I think taking the history from the patient is important. If it's a young gentleman, I would have a very kind of low threshold for thinking he's probably got undiagnosed EOE.
Yeah.
And when you speak to these patients, they often say that they're always the last at the dinner table. They've had lots of food bolus impactions that have cleared spontaneously, and eventually they culminate one day with a food bolus. I think I would always try to push, assuming there's not too much resistance, and have a low threshold to then stop. But usually what Matt's demonstrated quite elegantly there is just by pushing alone, it's usually effective in most cases, and that's what the ESGE sort of recommends in their most recent guidelines on this.
And this is in patients specifically without a clear diagnosis of a distal stricture of any sort. Is that fair to say?
It's fair to say. And I think the other thing I should have said earlier is have a low threshold to abort, because if you are particularly doing this in endoscopy, you don't have airway protection and you are struggling a bit, I would have a very low threshold to remove your gastroscope and get them tubed and do them in theatres, really, because this can go south very, very quickly, actually, and you need to be prepared for it to go wrong, I think. So that was a very straightforward demonstration. It looked like it was getting a one-to-one as he was pushing the bolus down, but that's not always the case.
And it was clearly a bit of food of some description. Reem, do you think what the bolus is important in this, or what the foreign body is?
I think so, and especially depending on what the patient's doing. If they're walking, talking, it happened last night and they're seeing you at 2 p.m. and they're okay and they're not salivating, SATs are okay, then it's okay, I guess, to start with moderate or conscious sedation. But if there's any concern that it's a solid body, or let's say magnets or something like a little bit more extravagant than that you may need to go back in a few times, then I would usually err on the side of intubating.
Okay, let's look at the next case where we do not want the endoscopist to be a pen pusher. I think the case will. Yeah. And so here we go. So 25-year-old has swallowed a pen. As many of these patients are, you know, a lot of psychological problems, numerous presentations, and the CT scan, you can see that black cylindrical structure is a pen in the duodenum. So we'll be using the Pentax gastroscope and duodenoscope, actually, snares, grasping forceps, baskets, a capuchin hood, and a cap. So let's go through to the case.
So this is a lady who's a regular attendant at the hospital, having swallowed foreign bodies. This is her 18th endoscopy for removal of horror body. Going to open the snare. He's going to pull back in the duodenum, because as we come back through the second part of the duodenum, it drops, the scope drops back, and we lose the proximal end of the pen, and so we've not really had a good view of the proximal end of the pen at any point, as you can just see demonstrated there. So before starting recording, we've been in and out of here a few times and struggled to get a stable position onto this. The CT scan's interesting and straightened up the wall a little bit, and I think because of the bend and the long straight pen, that's why it's gone through the wall and not round the corner. If we can't get hold of this with the snare, then we may try and dislodge it with a grasping forceps. What you might have to do is see if you even can just drop it down a bit and pull it away, but let's see if you can grab the proximal end first. Come back and get the other end of it. I'm not sure the grasping forceps will hold on to this. No. Could use a basket. Open. You can see that's not going to grab it. I mean, just try as a matter of interest. I think it's just going to, no, it's not going to, that's not going to grab. Open the snare. So we're going with the Pentax duodenoscope. See if it gives us a different lie in the duodenum. Oh no, can you believe that? Oh, is this one of those endoscopic times of, I wish I'd done this earlier? Open. It's just a bit sticky around my cap. Okay, close. Really tight. Got that tight? Got all my locks off. I'm aware that there's a bit of a drag from the top of the scope. It is not coming very easily. So if we're in the stomach, then I think we'll get a gastroscope back in. But okay, so we're going to probably go with this again. Close. Slowly. Oh, that's it. That's good. That's good. I think that's great. Yeah. Right, now let's see if the hood flicks. Yeah. Let's see if this comes out now. I can feel it coming.
There it is. Yeah, there it is. Got it. Right.
Oh, right. Open. It's a felt pen. Okay, so I'm going to clip this. Open. Close. Fire. That'll do. Right, we're done.
Yeah, so nice case by our colleague Monk Chapman there, and having the awareness of going back down and closing that defect. Reem, The previous case, we were pushing down and letting things pass through. Here, we're taking the foreign body back out through the esophagus. Talk us through anxieties about taking foreign bodies back up through the esophagus. When might you? There was a Capuchin cap. We're going to see the next case that being used again. But when do you use a cap? When might you use an overtube? And what are the foreign bodies that you really would be anxious about pulling back through the esophagus?
Good question. So we don't always have the cap available, but usually I would reserve that to anything sharp that you're just removing once, meaning there's just one of them, like one pen, one safety pin or whatnot, because that comes out this way and then as you're going in, and then it inverts the other way around as you're pulling up. For an overtube, it generally requires, an extra skill set. So you need to know how to place it, because I've seen perforations or esophageal injuries when they're not placed properly, and also there are different lengths that you would also use. And so I would reserve that for something where you're going back in and out multiple times and you don't want to injure anything. I can't think of maybe a group of pens. Or a group of pins, maybe.
And Vinay, any tricks and tips for a case like this? I mean, this unfortunate woman, repeatedly comes in, and sometimes it is more than one foreign body. And are there particular, foreign bodies that worry you absolutely specifically?
Yeah, I think whether it's blunt or whether it's sharp, I think is the first thing.
That's the word I was looking for.
Yeah, I think if there's any concern that this is a sharp object, then I think you need to be careful to protect the esophagus when you're withdrawing it. I think also if there's evidence of esophageal injury when you intubate, you may want to have a lower threshold to potentially have some degree of protection as you withdraw the foreign body. I think Reem made a really important point. Overtubes are very easy to talk about. To actually place one is not relatively straightforward. I think most trainees wouldn't know how to do it because it's not a commonly performed procedure.
And the patient needs to be fully intubated to pass.
There is risk of doing more harm than good, actually, if they're not placed correctly.
Yeah.
So a Capuchin hood is another option that you could use, much simpler to place over the scope.
Well, I'm going to stop you there because that may link with this next case and also links with the issue of sharp objects. So let's talk about the next case. So this is not the case. Let's describe we'll describe the case. This is a patient who again has come in with having ingested and a history of having ingested a razor blade. Hi,
I'm Rami Swayze. I'm one of the gastro consultants at University College Hospital, and I've got with me Will Blad, who's one of our senior registrars in gastroenterology. We're doing a joint procedure today. We've got an unfortunate young lady who has swallowed razor blades. She's tends to attend frequently. This is her second this year. Last month she had swallowed a single-edged razor blade, and clearly she has done the same today. Last year she also swallowed the screw from her wheelchair on several occasions, and so now she has moved on to swallowing razor blades. She swallowed this morning, and clearly the razor blade remains in place, so we're going to try to extract it. Clearly it's important for us to do this safely. She has been intubated and general anesthetic, of course, and we are now just gathering our image so we can be clear how many razor blades she has swallowed. It appears that she has just swallowed one on this occasion. The last time I think she swallowed 2 or 3. So Will is expertly looking around to make sure there's nothing else that was swallowed alongside the razor blade. He's entering the duodenum now. The esophagus looks clear. She has previously had an esophageal perforation, which required repair from previous objects she swallowed. So there are various ways of trying to remove objects from the stomach. We could use an overtube to protect the esophagus, or we could use a capuchin hood, which I think we're going to be using today, and I'll show you what it looks like in a moment. And basically, oh, there seems to be a second razor blade. Do you want to grab it and put it down next to the other one? Maybe if we can get stent grabber. These are single-edged razor blades, so they're at risk of causing some mucosal damage or harm. So it'll be wise to remove them rather than let them pass through the small intestine. So we're trying to capture the razor blade on fast rather than in the middle, because it's much easier to pull back. Well done, Will. Yeah, excellent. Great. So now he's going to face forward in order to try and place it in a position that's near the other one in the antrum. It's much easier to remove them from the antrum than from the fundus. Here's the capuchin hood. Do you want to show what it looks like? Okay, it's a rubber device. It looks like a skirt with a narrow end and a wide end. So the idea here is to place the narrow end over the scope and then flick the open end over so it's like a skirt. Okay, so here is the capuchin hood, and once you're retracting, it should flick over and protect the device that's within from causing harm to the mucosa. So I'm going to just flip it back over again. So now if the object that you're trying to grasp through the hood is lost after the hood flips over, you're going to have to come back out and flip the hood back over the scope, because there's no other way to adjust the hood without coming back out. Yeah. Okay, let's try that.
Hold tight, please.
Slowly coming back. The hood has now covered the razor blades to protect the esophagus. We're slowly coming back. And well done. You've done it. You've taken both out at the same time. So that's the hood flipped over. This is what it would have looked like beforehand. And once it passes through the GOJ, it flips right over, which is a very nice contraption, very simple, very easy to use. You don't need a overtube or anything. And we can go back down to take a look, make sure there's no mucosal trauma. Here's the razor blade. See? So there's a little mucosal trauma here, but that's okay. There's nothing else that we can see that's untoward. Very well done, Will.
A nice couple of cases, I think. And we were just talking between ourselves that I'm not sure that the availability and the use of capuchin hoods is as universal, certainly in the UK, as it perhaps should be. But a nice example. And we're just looking, in fact, I'm glad that Reem has actually learnt something while she's been with us for the last couple of days, because she was taking photographs of this this summary, which is the ESGE summary of removal of foreign bodies. Vinay, do you want to just, highlight some of these issues and how they define management, and most particularly whether we need to be getting up in the middle of the night for this?
It's an increasing problem, as we've been talking about offline, and I think you need to be aware of what objects are going to get you up in the middle of the night. So batteries, particularly button batteries, are particularly dangerous because of the current that you could be transducing via the saliva and the esophagus. Magnets are another problem as well. So if you've got a clear history of ingestion, whether it's intentional or untoward, then actually you need to get up and get these out, basically. Most other objects, particularly if they're blunt and not sharp, can probably wait within 24 hours, is what the recommendations usually would say. So just anything sharp or anything electrical or with magnets are the ones that you're going to need to act sooner.
What about location? the balance of the foreign body is in the esophagus or it's in the stomach or it looks like it's about to pass through the pylorus. How does that influence decisions?
I think symptoms are also important. If they're symptomatic, particularly if it's in the esophagus, that's probably going to want to make you intervene slightly sooner. It's probably causing some degree of obstruction. If it's in the stomach or the proximal duodenum, that for me is enough evidence to go through and try to remove it. But clearly, if you can't see it on an X-ray, I think a quick CT probably will be very helpful, because if you're seeing it in the mid-small bowel, it will save you a wasted endoscopy, really, and either a phone call to the surgeons or a watch and wait policy. So I think symptoms, and as long as it's proximal to the ligament of Treitz, I'd probably give it a go.
Okay. So I'm just briefly getting back to the case of the pen in the duodenum. Both a duodenoscope and a gastroscope were used. Do you want to more generally comment on visualization within the duodenum and whether a gastroscope or a duodenoscope should be used?
Yeah, I think most people are more familiar with a gastroscope, and if we're going to be removing these out of hours or in an emergency, then certainly that's what people are more familiar with. And I think in the end, Mike was most successful with a gastroscope, and he was having difficulty with the duodenoscope. Of course, you're going to see the side of the duodenum much better with a duodenoscope. So if the foreign body's perhaps gone through, like it did in Mike's case, and it was going through the medial wall of the duodenum, a duodenoscope would be useful. But I think I would always start with a gastroscope, and I think most people can't use a duodenoscope out of hours.
I think it's a fair comment.
Yeah.
And the provision of fluoroscopy, do you think it's something that is needed for these cases, or is it just a luxury that probably is not necessary?
I'd like to say it's probably a luxury. I mean, in this case with the pen, it may have been nice to have in the room because you could demonstrate complete closure after the pen removal if there was a contained perforation or a full-on perforation. But it's not necessarily needed if the patient's doing well. I say that because I don't want to be called to do these cases rather than general GI. But
yeah. But as you say, that there is that, let's be honest, it's somewhat of a heart sink, when one's on call and one gets a call at 10 o'clock at night to say that patients come in having ingested perhaps again a foreign body. And what about the overall team, the overall infrastructure? And it's a more general question actually about doing technically demanding procedures, whether it's GI bleeding, whether it's foreign body removal, whether it's an out of hours emergency ERCP. Reem, do you have good support in New York? Because the risk, certainly that is true in the UK and probably elsewhere, is that the risk is that the most high risk, technically challenging endoscopies are done at times with the least experienced team and the least equipped environment.
Yeah, completely agree with you. So for ERCPs or anything advanced related, we tend not to do them after hours because really anything can be treated with antibiotics and wait for the light of day. And so usually I'd like to do them sort of between the morning hours, which is 7:30 to 6 p.m. Unfortunately, with foreign bodies or GI bleeds, you're not always, you can't necessarily wait. And often those are done with the fellow on-call and the on-call physician. So it's usually very, especially at night, it's usually just two people helping. One of them is teching the other. On the weekends, you do have a nurse or a tech that can help you out. But generally, the nighttime is when you have skeleton staff.
Yeah. Okay. Great. Well, I think a fascinating discussion. Thanks everybody for really diving down into a very clinically relevant area. We're now going to change tack, and I would probably be doing a disservice to the other amazing faculty who have been with us over the last couple of days to say that we're saving the best for last. But it is certainly an enormous pleasure and privilege to finish our 2 days of London Live Endoscopy, to focus again on innovations and to introduce one of the absolute global stars of endoscopy innovation over the last 20 years, Professor Ken Binmuller from San Francisco. He is going to cover the history, the present, and a little bit about the future of therapeutic endoscopic ultrasound. And the reason why he is doing that is that he has been at the center of introducing the technologies that are dramatically changing patient care, and specifically the development of lumen-opposing metal stents. So, Ken, it is an enormous privilege. I know it's still probably pretty early in the morning in San Francisco. I would imagine that nevertheless it's a bit drier than it is in London today. But it's a great pleasure to have you with us and to introduce our final session on therapeutic EUS and to hear get your oversight.
Thank you, George. A great pleasure to be with you this morning. Good morning from San Francisco. And it is, in fact, raining outside, but I've opened my window and it looks like we have some sunshine here in my office. So I'm going to very quickly, over the next 15 minutes, take you on a quick journey through the evolution of EUS. It's been a remarkable evolution over half a century, but really it's been the past 3 decades that we have seen just an incredible advance of our therapeutic capabilities, where it's truly changed the landscape of what we could do as endoscopists. I don't have any financial conflict of interest, but I am the proud parent of the Axios LAMS and delivery system. And of course, I'm going to talk a little bit about that in this talk. So if we think back 30 years ago, Peter Villman, he reported in the New Methods, New Materials section of GIE 1992, this method of going beyond the GI tract under EUS guidance using a needle and accessing various structures, be it organs, lymph nodes, periintestinal masses, and fluid collections. This was the birth of notes. And if you think about it, up until this time, we were confined to the gastrointestinal tract. Now, for the first time, we could journey beyond the gastrointestinal tract using our new eyes, not just the endoscopic eyes, but our ultrasound eyes that have really become part of our diagnostic and therapeutic procedures in our units. So it started really with diagnosis with FNA. The A stands for aspiration, but it then quickly evolved to therapy when we switched out this A for an I, our ability to inject. So we're reversing the direction. So now we're injecting a solution, a therapeutic solution, into our target. And that could be a steroid solution. So we could perform nerve blocks, celiac nerve blocks. Could be a sclerosant. We could perform neurolysis, celiac ganglion neurolysis, and tumor ablation. It could be glue, cyanoacrylate glue, and we could perform hemostasis for gastric varices, for example, or really for any bleeding vessel. And then it could be chemotherapeutics, enabling us to ablate tumors. And that I could also stand for implant. So again, through the same needle, we can introduce fiducials and we could guide radiotherapy for our radiation oncology colleagues. We could implant even radiation seeds for tumor ablation, and we could implant coils. So now we're looking across our disciplines here to our interventional radiologists, and we are borrowing or adapting technologies from them. This is true translational medicine, where we're adapting procedures that are commonplace in other disciplines and applying it to interventional endoscopy. So vessel embolization for hemostasis, something that I've been doing for many years now, and I think is becoming increasingly mainstream. So here you see fiducials, radiation seeds, and coils, again, all delivered through an FNA needle. And that eye implant could also be a guide wire, right? We can advance a guide wire through this FNA needle. And that led to the rendezvous procedure. Now think about this. This is the marriage of EUS and ERCP. It becomes a true hybrid procedure now because we're assisting the completion of a difficult or a failed ERCP with this procedure. It was described in Brussels in 2002, and then in Minnesota in 2004, consisting of these three steps. Anterograde duct puncture, you can see here how we're passing the guide wire under EOS guidance into the bile duct or the pancreatic duct, anterograde. And then we pass the guide wire across the ampulla or in anastomosis if the patient had prior surgery. And then we exchange now the echoendoscope for the duodenoscope to complete our ERCP. So this is an anterograde, retrograde, hybrid marriage. And we can use that guide wire also as a guide rail for interventions. And this is the Seldinger technique, what Sven Seldinger, radiologist, first described back in the 1960s, I believe. And it become, of course, mainstream with our interventional radiologists. But we applied that in 1992 in Hamburg when I was working with Nib Sahendra to perform the first EOS-guided pseudocyst drainage, consisting of these four steps. We access the cyst with our FNA needle, we insert a wire, we then exchange the needle for a bougie or a balloon catheter to dilate the tract. We're priming the tract for stent placement to drain the cyst. The Seldinger technique. Now, as elegant as this technique is for our interventional radiology colleagues, it's a bit more technically challenging for us because we're working so far away from our target through an angulated endoscope. This is a multi-step and therefore multi-risk procedure. As soon as we remove that needle, we have our guide wire in place, but there's a gap between the guide wire and our tract, and that's where the leak can start. And then when we insert a dilator over the wire, we can displace our target cavity. When we dilate over the wire, we can perforate. And when we remove our dilator, now we have an even bigger gap between our guide wire and the tract, and again, leak. And even when we insert our stent, everything's been primed, we're ready to go, and here we can again displace our target if it is not adherent to the wall from the gastrointestinal tract. And here is a historic video. This is one of my perforations. I had a few that draining a pseudocyst. I thought I was in the pseudocyst, and then when I look more closely, I see all this fat. So I was in the retroperitoneum, and I went alongside the cyst trying to drain the cyst. So the challenge of transluminal therapy is avoiding leakage. Because remember, we are performing an intentional perforation of two walls, right? The gastrointestinal wall and our target wall. We have two walls that we are creating holes in. So it's no wonder that there is a significant risk of leak. So when you drain the gallbladder into the duodenal bulb, for example, it's not adherent to the bulb. And there is this echogenic plane that we can see with EUS between the gallbladder and the bulb. It may look like it's adherent, but it's not adherent. And in this case, This patient ended up going to surgery. Now, this is already some 15 years ago, but this is what inspired me to think about how can we address this problem of leakage that can be life-threatening, sometimes fatal. So we needed really two tools to prevent leak and perforation. We need a transluminal stent delivery system whereby we can access the target lumen with a stent-loaded catheter. In other words, we want to eliminate Seldinger. This is the anti-Seldinger technique. Seldinger is wonderful for our interventional radiology colleagues. It's not great for us. We want to eliminate over-the-wire exchange. We want to seal off that tract the entire time and not give any opportunity for leakage. And we need a transluminal stent, what we call LAMS today, that is covered and self-expanding to seal off the tract. And it should be lumen opposing. It should keep the two lumens in apposition. But most importantly, it should also serve as a port for transluminal intervention. Because now this enables us to truly extend the reach of the endoscope into extraintestinal spaces. So we have focused on two targets. Firstly, WANS, walled-off necroses, to perform necrosectomy under direct endoscopic guidance, something that's become very mainstream today because we can use that LAMS as a port to safely enter into the cavity. But also the gallbladder, we can create a cholecystoduodenostomy or enterostomy, gastrostomy, and then we can enter into our gallbladder and we can perform stone clearance. And there are different ways we can do that. We can do it this way, where we can grab the stone with the Dormia basket under direct endoscopic guidance. You don't need any fluoroscopy. You see the stone, and you can now tease it out very slowly through the opening of your LAMS, as you can see here. So we can just directly remove these stones. They're multiple one by one because we have that port. We can also perform mechanical lithotripsy. You can see here a stone, and we can capture that with a lithotripter basket, and we can crush that stone and remove the fragments. And we could even pass an electrohydraulic lithotripsy probe directly through even a pediatric gastroscope, right? Because it will go through that channel. It's 1.5 or 3 French. And we can perform lithotripsy under direct endoscopic guidance here, just as we're used to doing it maybe under cholangioscopy guidance retrograde, but we can do it so much more easily anterograde. And while we're in the gallbladder, why not take a biopsy of this polyp here if there's anything concerning or suspicious, so we can get biopsies. That's something I do all the time now. And there have been some reports of polypectomy, and I think you could probably do EMR and ESD. I mean, we're just extending the reach of the endoscope. All the tools that we use in the gastrointestinal tract, we can use outside the gastrointestinal tract. But remember, the LAMS is more than just a stent. In fact, I didn't want to call it a LAMS. I called it a LAD. It's a lumen opposing device, because the word stent already implies a different purpose. It's for drainage. This is an anastomotic device. And so when this first proof of concept of creating a gastroenterostomy, that's where we are creating an os, a stoma. It is axios, an abbreviation for axial ostomy. It's an anastomotic device. So we can do a hot puncture, deploy our distal flange here, our proximal flange. Now we've created a gastroenterostomy. You see the afferent and efferent limbs, and this is on the necropsy studies showing this anastomosis that we have created. And one wonders then, is this really not the ideal anastomosis? Because it is truly organ and tissue preserving. That's what our work is all about, right? It's about organ and tissue preservation, and we preserve the blood supply. There's no ischemia, and we create a tension-free apposition of healthy bowel. So it's a whole different approach. We don't have sutures and staples. That is usually the origin of dehiscence and leaks. So that's why we don't see this after we create an anastomosis with the lambs. But the limitation is that lambs is temporary. We know of complications. We've heard about these when they are left in long term. It's not yet a permanent device, unlike a cardiac stent. So there could be tissue injury that can lead to ulceration and bleeding. Like this case, you can see blood flowing out of the lambs here. There can be tissue in and overgrowth. We were talking about the buried lambs, buried bumper, buried lambs, and we see that. And you can see this lambs is completely occluded. This is one of my cases. I had to remove it and replace it. And these lambs can migrate here. This one's migrated into the gallbladder. So what we need are tissue friendlier. It's pretty tissue friendly, but it needs to be tissue friendlier for permanent anastomosis. And I'm really excited about this. You know, we've seen a revival of notes, right? We thought notes is dead. Well, we're reviving notes. It could be a port for EOS guided notes. So my idea is that we perform FNA, we infuse saline to create an extraintestinal landing target for our lambs, right? So that we can safely place our lambs outside of the gastrointestinal wall. And now this serves as a port for notes. So we do whatever it is that we want to do with notes. I mean, you could even remove the gallbladder, I suppose. And after you remove your lambs, you close the hole. So we're talking about the ability to explore, stage cancers, get biopsies under direct endoscopic vision, resect, ablate, maybe we can place implants, sensors, therapeutic devices. It's a candy store for us, right? And this could be in organs, tumors, lymph nodes, et cetera. And adhesiolysis, we could do that directly from the stomach, for example. So this is, I think, the big question. What is the future of bilial pancreatic endoscopy? It's an important question because this is going to impact how we train in the future. You know, ERCP training really needs to change. It needs to be a marriage of EUS and ERCP. Will EUS-guided intervention replace ERCP? Certainly conceptually, it's very attractive. It eliminates difficult cannulation. You don't have that difficult ampulla that you have to deal with. No more pre-cutting, none of that. Eliminates risk of pancreatitis. That's been the holy grail. We just bypass the pancreas entirely because we're coming from above. We're working above the obstruction, so we're not even going through the stricture. And this is dear to my heart here, minimizing, even eliminating entirely ionizing radiation, something we get way too much of in our work and our patients get too much of. But the limitation is shown here. We are limited by the size of the ducts. So you can't ram this catheter into a small duct like this. So I would say, will EOS guided replace ERCP? Probably yes, for strictures in surgically unfit patients. We're doing this. And patients with failed or high-risk ERCP, right? I think this is basically, and our guidelines are reflecting this. Likely for malignant strictures in surgically fit patients. We're putting together the evidence now showing that we are not adversely impacting the outcomes of surgery. We need to, of course, more robustly prove that, but it's looking like that is indeed the case. And no, what would be leaks? We still need to do an ERCP for that. And stones, although maybe difficult stones, refractory, these large impacted, maybe it's easier just to go from above and do your lithotripsy just like we do in the gallbladder, maybe. So to be answered, well, we need studies on better durability, on long-term adverse effects of these lambs, because our recommendation is you need to take it out after a few weeks. Don't leave it in long-term. And what's the impact on future surgery? I just want to say one word to this area that I think is going to explode. You see, under EUS guidance, we have direct access to the portal vein. That's unlike our radiology colleagues. When they do this percutaneous, they don't have direct access. So we can go directly right there in the portal vein. We see it from the duodenum, we see it from the stomach. We can perform thrombolysis. We can embolize in those patients pre-surgery, liver surgery for contralateral to induce contralateral liver lobe hypertrophy. And we can perform a TIPS. And I had a chance to dabble a little bit with that as I was using lambs and placing it, lambs here, lambs there, lambs everywhere. We are putting it everywhere in our animal studies as we develop this technology. But I also performed a number of TIPS procedures with lambs, and you can see here the puncture of the portal vein through the IVC, the distal flange here in the portal vein, proximal flange and the IVC. This is in the swine, of course. And then you see the axios right here. And here you can see our TIPS, right? So very nicely placed between the two vessels. But you have to be careful what you wish for, because we may be getting that calls. We're talking about that being called with emergencies during the night. And we may get called to do a TIPS if we really show that this is better than radiology guided. So what does the future hold? Well, I love this quote from Abraham Lincoln. The best way to predict the future is to create it. Creation. That is something that AI will never do. So let's support creation in endoscopy. There's so much creativity to look forward to. Thank you very much.
Overview, and it's great for our younger endoscopists, I have to say, to see the passion, to see the enthusiasm, and I would say to them that if several decades into one's career one can maintain that passion, then you're in the right job. You may have the day job to run off to, in which case we completely understand. We're going to focus over the next 45 minutes on a number of cases. We would love it if you could stay for a little bit and give your insights and your expertise. We're actually going to go to my colleague Gavin Johnson, who is just going to demonstrate the technology of hot axios, and then we'll be looking at a couple of cases.
Excellent. I'm here and available.
Great.
Good afternoon, everybody. Thanks for staying with us till the end of London Live. What I'm going to do is demonstrate the deployment of a hot axios. I've got Simon here. So if you could just focus in on my hands, team. That's perfect. Good angle. So obviously, linear EUS. Identify your lesion. You hold that for me, Simon. And this is where you do your diagnostic EUS, look at your vascular structures, have a good look at the gut wall at this point to check that you're not near a major vessel. We then, can you hold that for us, Simon? Yeah. This is the Axios from Boston Scientific. So a hydrophilic coating. You take off your bung from the top of the scope. Give the white sheath a wipe with a wet bit of gauze because it's hydrophilic and it will slip down the working channel of the scope a lot easier. So down it comes. You'll see that I have preloaded this Axios with a long 450 Jaguar 035. The reason I do that is, with the exception of an EUS gastrojejunostomy, in just about every case, we are going to be placing a coaxial double pigtail stent. Furthermore, if you've got a guide wire in place, if you do mal-deploy your Axios, you've got a guide wire across to the target and you can sort of rescue the situation with a guide wire. So if you look at my hands here, we've got the Boston Scientific logo pointing towards us. There's a little screw here that goes down. You really want to make sure this is nice and tight on the top of the scope. This works with all EUS scopes. So twist that around and really give that a really tight twist. You do not want that falling off in the heat of battle. Fine. So that's me with the scope like this. At this point, the Axios is not coming out of the tip of the scope. We go to step one, which is to slide the lock, and with this grip, bit like an FNA needle. We're pushing down. And if you go to the tip of the scope down here, yeah, you can see the device coming out. So you would now start to see that on your EUS view. You would see the little white probe, very akin to a biopsy needle coming out. It's at this point where I might take the catheter back a little bit, back into the port, and do my final Doppler check, and just rock ever so slightly with a bit of torque, left and right of my target to make sure that there isn't a vessel that's just off view within the realm of the expansion zone of the axios. When we're ready to go, we're going to put a lead up to the top. So back to my hands, guys. We're going to put the lead there to your Irby machine. The settings are coag off, effect 5, and 100 watts. That's the settings. A good idea to take a picture of those settings so you've got them on the phone for reference. And when we're ready to go, we're going to be on the yellow pedal, not the blue pedal, on your Irby. So you're going to push out. You're going to start to see, back to sort of both here, yeah. I'm going to crouch down a little bit. So step 1, foot on the yellow pedal. You want to spin that round, Simon? That's probably better, yeah. You got it? Great. Okay, so now step 1, foot on the pedal and push, and that's going to go into my target lesion. That's already deployed distally. We may have a malfunctioning axios here. So that goes as far as you can, at least a thumb width of the bung, but if you've got a nice big target, as you often do with a pancreatic collection, I'm going to put that step 1 as far as I possibly can to be sure that the distal flange is going to be deployed well away from the lumen of the gut. We then can lock this, so that's in place. And when you've got a nice EUS vision on the distal flange, you're going to pull up the step 2, which has already gone off here because it wasn't locked. So step 2 has already been deployed, and you can see on EUS that you're going to have the white opening of the distal flange on EUS. At this point, you need to bring the stent back to get apposition before you deploy the proximal flange. So it's at this, I still am not going to place the wire. I'm going to take the lead off my axios, so there's no accidents with the cauterization. I'm then going to unlock and go back to step 3. And what I'm looking for on step 3 on EUS is 2 things. The shape of the distal flange changes. It goes from a rugby ball to a football. You can see that happening there. And another thing that you can see that's hard to explain on here, but the white olive, the tip of the delivery sheath, bends towards you on your EUS image. It moves to touch the distal flange. And that tells you you've got a nice bit of tension in the stent and decent apposition. At that point, step 2 has been delivered. I'm once again going to lock step 3. Okay, so I've locked that. I'm now going to deliver the proximal flange within the channel of the scope. So nothing will happen on EUS because I'm delivering the proximal flange within the working channel of my EUS scope. You're often very close to the target. Often you've got a red luminal view. You're not seeing anything on EUS. You're not seeing anything on your luminal view either. At this point, we've got the distal flange deployed. We've got the proximal flange deployed, albeit in the working channel of the scope. So then it's a triple maneuver, if you will, to push the stent out of the working channel of the scope. So I'm going to make sure my scope's got a little bit of looseness in it. I'm going to get my finger on the big wheel of the scope so that we're going to extend the head of the scope. I'm going to torque slightly clockwise because remember the working channel of a linear echo endoscope is to the right, coming at about 2 or 3 o'clock. So we want to torque clockwise to bring that stent into view as you go. And as I do that, I'm pushing down back to step 1 to push the sheath onto that stent and release the stent. So with my shoulders, 1, 2, 3, looking away and torquing clockwise. And then you'll see a gush of pus, bile, depending on what you're draining. Now, what I forgot to say is before delivering the channel, is that out? I think we've got a bit of an old working version of a axios here. Just pull it off. I forgot to mention, after deploying the stent and coming back to step 3, at that point, I would advance my guide wire through the working channel of the scope so that you've got that to go with. I then exchange on that guide wire with my assistant, put the bung back over the wire, and then you've got a wire going through your axios, and it saves that step of having to recannulate the stent after deployment if you have a coaxial wire. So that's it. So a slightly faulty axios, but you get the idea. And I think we're going to go to a few cases of axios placement. Thank you very much. So the first case is a 78-year-old gentleman, a head of pancreas lesion causing double duct sign. He's jaundiced. We've failed to cannulate at the first ERCP attempt, but we do know he has adenocarcinoma on a US fine needle biopsy. So this case uses the Pentax J10 echo endoscope, an 8mm hot axios stent, an 035 Jaguar, and a 7 French 4cm double pigtail stent by Cook.
This is a 79-year-old gentleman with an unsuccessful ERCP last week due to an infiltrated papilla from presumed metastatic pancreatic cancer. So we've got the EUS scope, which is the J10 Pentax scope in the duodenal bulb. And what we're looking at here is the liver hilum here, and then a big dilated bile duct coming all the way down. We'll get our Doppler on to show this is the bile duct, and then you see the insertion of cystic duct at the back here. So we could follow that off to gallbladder, which is going to be yonder. There's the gallbladder. Follow the cystic duct back to bile duct, and then as we follow the bile duct down into the head of the pancreas, there's some debris within, and then we hit the mass here at the bottom. So we're in a nice position. The course of the portal vein's a bit curious because it's quite closely opposed, and there's one of the hepatic arteries, so we need to avoid that. So just superior to insertion of cystic duct seems to be a good position, just here. So again, we're going to mag up. I would ordinarily go with a 6mm hot axios, but we don't have any available today, so this is an 8mm hot axios stent. And I think this duct is big enough to go freehand, so rather than do a 19-gauge duct puncture and a cholangiogram and pass a wire and put my hot axios over the wire, I think we can proceed with a freehand puncture here. So there's my hot axios coming in at that angle. And now Doppler can be quite misleading. When your axios is out, you get artifacts. So I'm going to bring that right back just to make sure I'm sufficiently distant from that artery that we saw, which is here. So I need to go push in a little bit more, thumb down, mag up a little bit more. So I'm well out the way of that. There's no vessels. And then I can bring in my axios here, and that looks like a good position. Doppler off. We've got the axios settings ready to go. And we're just going to put the little lead on. Yep. I've preloaded a long Jaguar so that I don't have to try and cannulate the stent to then pass a coaxial pigtail. So it just sort of saves as a cannulation step. So onto the yellow pedal, bit of inward pressure. And we're in. We need to get as much clearance at the back as we can. Lead off, guys. We don't want to do any trauma to the back end of the bile duct, so the thing's off. I'm going to lock step 1, and it's whether we can deploy this in one go. Step 2 is whether I have to push out again. So very, very slowly. Where's that going to flare? Is it going to flare in the duct? Yes, it's going to flare in the duct, so I don't need to manipulate with the first step again. Then I'm going to come back. And let's hope this Jaguar now goes north in a retrograde angle rather than south in a antegrade angle. Screen. Can't quite see it looping there. Yeah, and that's gone up. So we've got a balloon ready because we'll just do a cholangiogram with that wire. And now we're ready to deploy the proximal end of the flange. So we're in the channel of the scope. So you don't see anything on a US at this point. That's the proximal flange deployed, and then a little maneuver to look away and put the stent out there, and hopefully see a nice gush of black bile usually. Screen please, so let's inject. So I'm expecting to be in the right ducts with this wire. Yeah, and see, you get a really good aerogram with a choledochoduodenostomy. So we see the aerogram of the right duct there against the background liver parenchyma. Stop injecting. And there's now good evidence on the patency of a hot axios choledochoduodenostomy versus a transpapillary fully covered stent at the 1 year mark, which was Tio's paper in gastroenterology this year. So this is something I think in a patient who has locally advanced or metastatic pancreatic cancer, particularly if there's issues around an ERCP, as there is in this case, to go straight to a choledochoduodenostomy. You just need to be mindful, we're just exchanging here, you do need to be mindful of coexisting gastric outlet obstruction, because I think we've got some good data emerging now from Belgium that if you have coexisting gastric outlet obstruction, then a choledochoduodenostomy is probably not the best way of achieving biliary drainage. And if you do that, you should probably combine it with an EUS-guided gastrojejunectomy or possibly a duodenal stent. But there tends to be some argument that a transgastric drainage from left side might do better in the context of gastric outlet obstruction. Now we need a short pigtail, please. So the trajectory of this bile is a bit tortuous. So you see the anatomy on my cholangiogram, it's a bit odd in that I'm almost lateral to the liver, but we know from the CT that's this chap's anatomy. He's had a previous pull-up. And you often see with the therapeutic scopes, with the stent coming out at 2 o'clock, it often just catches at the top here, which is exactly what's happened. There we are. Just need to bring that off. It's looking good. Deploy the top of the pigtail. And then get the back at the stop screening. Start withdrawing the scope a little bit. There we are. And then wire out. There we go.
Lovely case, Gavin. And Ken, if you're still with us, you suggested at the end of your talk that this technique may, in the future, replace transpapillary retrograde ERCP. In 2024, does it replace the role of the interventional radiologist doing percutaneous transhepatic drains?
Yes, I think definitely. It is nearly making percutaneous drainage obsolete. Our interventional radiologists get very little business for biliary percutaneous drainage. The rendezvous is something we used to do with the help of our radiologists. They would pass a wire percutaneously. Now we can do that under EUS guidance. But for the drainage, as you just saw so masterfully performed, we can definitely do this now from above the stricture. I just might make a few comments. Firstly, it's very important to identify where the proximal flange will deploy in the bowel lumen. So in the case of a colodochoduodenostomy, you don't want that too close to the pylorus. And in the event that the patient might go for a Whipple operation, you definitely want to have some distance, ideally about at least 2 centimeters from the pylorus. So you're targeting more the apex. So you need to also confirm on endoscopy where your puncture site will be. The second comment I wanted to make is it's important to measure the runway. And obviously this was a very generously dilated bile duct, so it looked from Gestalt safe. This was an 8 millimeter. With an 8 millimeter, you need a runway of 24 millimeters. If you use a 6 millimeter, you need a runway of 20 millimeters, 2 centimeters dilated, right? And when you're doing like gastroenterostomies and when you place a 20 millimeter lambs, you need a runway of 4 centimeters, right? So you need to measure that out to know, because it can be deceiving depending on the level of magnification that you use with EUS. But very nicely done. The only difference in the way I do this is that I will push out the proximal flange under endoscopic guidance. You can do it under ultrasound guidance. It's no problem. I do keep sort of one eye on the ultrasound just to be sure that that distal flange is not advancing. But I want to really watch with my right eye, the main eye here, the deployment of the proximal flange.
Great, thank you. And Reem, Gavin there inserted a double pigtail stent. What's the logic around that? You've got a nice fistula there. Why should that, is that what you do, and why should that be necessary in a case like this?
I think that's a good question, and I think practice is changing. I do it, and I'm curious to hear what Ken says. I do them for choledochoduodenostomies. I don't do them as much for like a gastrojejunostomy. We used to, but stopped doing that. And I do them for gallbladder drainage. And the thought being is that it may prevent some sort of sump syndrome or help with more adequate drainage from the bile duct. But
okay, great discussions. We're going on to next case. This is a patient with chronic pancreatitis with duodenal stricturing, fibrotic duodenal stricturing. Not a great candidate for a surgical bypass. This is benign disease. We had discussed all of the issues, which we can discuss again, about duodenal stenting versus EUS gastrojejunostomy, but we're going to show here a EUS gastrojej.
Okay, so this is a 59-year-old woman with known metastatic breast cancer who's said to have a very good oncological prognosis in terms of oncological options. On CT, it's unclear exactly where her duodenal obstruction is, but she presented with gastric outlet obstruction, very distended stomach, lots of vomiting. But on CT, it's quite difficult to determine exactly the nature of duodenal obstruction. In breast cancer, one gets malignant plaque-like disease throughout not just the duodenum but also the lower small bowel as well. So we've got two objectives before we even think about how to best palliate the gastric outlet obstruction. One is to document the level of obstruction, and what we can see here with a gastroscope is that we are not even able to get into the first part of the duodenum. Can you just see if you can follow that, Dan? So it could be that with a balloon tethering the tip of the scope, you may find a little bit more joy getting your scope through, and that's quite useful here because this could just be a discrete short stricture of the first part of the duodenum, or the entire duodenum may be stuck down and plaque-like with plaque-like disease. We just don't know. The second objective, as well as documenting the anatomy of the duodenal obstruction, is whether there is also further small bowel obstruction in a runoff type way down the small bowel, because of course a duodenal stent in that context would be futile, and an EUS gastrojejunostomy with a lumen opposing metal stent would not only be futile but may actually be impossible if we're unable to distend up the jejunal loops with solution. So now, Dan, just use your balloon, lock your wire, use your balloon just to see what that stricture's looking like. So it looks quite short and discreet there, doesn't it? So this is a 15mm balloon, I think. It's the Olympus balloon, so the biggest balloon in here is the 15. That looks a very inviting loop of bowel for an EUS GJ there, doesn't it? So given that she's got a very good prognosis for 4 or 5 years, according to our oncological colleagues, she will do better long term with an EUS-directed gastrojejunostomy into that limb there, rather than a duodenal stent across the pylorus, which is a better palliation. And then we do a CT in a couple of weeks. They take a while to open up. And the stomach, when it's been obstructed, is quite atonic. So for the stomach to get its tone back and rhythm back takes a couple of weeks as well with prokinetic meds, so metoclopramide, domperidone. Then, so once we think it's fully open and the stomach ought to be back into gear, we would give her an oral contrast radio opaque contrast liquid to drink, then do a CT scan, and the CT scan would show contrast going through today's stent, and it will tell us if there's a problem downstream. And our job is to find the distended jejunal limb that we've got, that we've filled. So we've got some methylene blue with dilute contrast. And what's quite useful here, screen, we've already got quite a bit of contrast in the is it gives you a little clue as to exactly where in the stomach to look for the distended limb there now. We just have to be pretty sure this is that loop that we think it is. There's the white tube. Okay, so let's photo document that. And that's what I mean by a longitudinal limb of jejunum rather than a cross section like this, a longitudinal like this. Ready? In the past I have punctured limbs before just to be sure. That's filling. That's filling dynamically, isn't it? So can we get the 20? And there's the tube. See that? So there's no doubt about it. That's jejunum, or DJ flexure even. So we unlock step 1, get our axios out before we fine-tune the precise puncture point. That looks good. Hold it there. So we're nice and close. Now we just need to ensure there's no nearby vessels. We've got smoke. I've lost my view. Screen, please. Yeah, we're in there. Save that. That looks good. Is it blue? A boy. So there we have nice and straightforward dilute contrast and methylene blue coming from what we presume to be the small bowel. Just going to engage the balloon just at the other side of the axios and inject. Just check where we think we are before you inflate. Inject there, screen. Yeah, it's good. And balloon up. And inject there. Yeah, and we've got runoff and there's no leakage. So just because it was a little bit of a challenging initial puncture for reasons I'm not certain of, we needed a second stent. I'm keen to document that there's not an injury on the contralateral jejunal wall. Keep injecting. So just interrogating the jejunum with contrast is probably the right thing to do here. Screen. It was not plain sailing, and there does not look to be any extravasation beyond the lumen there of contrast. And actually, if you mag off a couple, we may be optimistic in that, no, the other way out. We may be seeing lots of contrast going downstream, which would be encouraging for her palliative outcome here. Screen. So just to discuss the end of that case, a difficult decision between a duodenal stent and EOS gastrojejunostomy, but on account of her excellent oncological prognosis, I think it was right to give her the benefit of the doubt and go for an EOS gastrojejunostomy. We still have concerns about, in the context of metastatic breast cancer, whether there's small bowel obstruction further down, but not obviously on that plain fluoro X-ray. So she's got a 20mm hot axios. She'll be on nil by mouth overnight, water tomorrow, then on to free fluids.
Okay, lovely case again. Ken, before we come to you, I gave slightly the wrong history of a different case, but this patient had a short duodenal stricture. As you mentioned, Gav, so that this was likely to be a malignant plaque-like breast cancer-related stricture. Just explore the decision-making that we go to through our MDM, because all of these cases are discussed within an MDM setting, about why one might still use a duodenal stent and why one might go for an EOS gastrojejunostomy.
So we're lucky enough to get our oncology colleagues to join our MDM if it's this sort of case, because I think what they have in mind for the patient's crucial. So we've got a little bit of a sort of, if you like, UCLH sort of modality as to how we approach these things. If the patient is really approaching the end of life, you're probably not trying to get them onto burger and chips, frankly, because they're not going to feel like it, but you're wanting to palliate vomiting. And I think in that case, a duodenal stent is quick, easy, safe. Some of the data that shows the complication rates of duodenal stents are quite high, something we would not recognise. I can't remember the last time we had a significant problem with a duodenal stent, touch wood. Whereas if that patient's got a reasonable prognosis, a good quality of life, we don't really put a number on it, but more than 2 or 3 months, they're probably much better palliated. And I think the evidence now supports this to go with an EUS gastrojejunostomy. And for a patient like this with breast cancer with fantastic oncological options, it is a bit of a no-brainer. And if you then speak to the patient a couple of weeks later, it is remarkable the quality of the diet they're on. They're pretty much on a normal diet in the advent of the 20mm hot axios.
Yeah, and I think the point you make about certainly our experience is that duodenal stents are very safe in terms of major complications, but the physics of duodenal stents is unfavourable, isn't it? You know, you at times have a 12 centimetre stent which is narrowed to, you know, 4 or 5 millimetres along 6 centimetres of that stent, and with an already atonic stomach, it's unsurprising that these patients often, we might get a good technical result, but a clinical result is much harder.
They probably stop vomiting, but they are not thriving. If you actually go back to them.
And Ken, would that be your conclusion as well? And I also wanted to ask you about the necessity of delineating and defining the small bowel loop with contrast.
Yes. So firstly, in our practice, EUS-guided gastroenterostomy has virtually replaced duodenal stenting, but we do 2 to 3 of these every week, where we have a lot of expertise, and one should not underestimate the skill and experience needed to safely perform a gastroenterostomy. Remember that it's the high surgical risk patient that is end of life, that is sent to us, who can benefit the most from this procedure, but also will fare the worst if there is a complication. And we know there is a complication rate or adverse event rate that approaches some 25%. So it requires a high level of skill and experience. So this is really something that should be at the very end of the learning curve. Having said that, though, there's no question that there are physiologic advantages to a gastroenterostomy. I think it's the fact that we're performing the drainage from the proximal stomach versus waiting for everything to go through the more distal part of the bowel. So the patients have much better palliation and quality of life. I think you mentioned one other question about defining the small bowel anatomy. So there are usually I don't need to use X-ray, but this is one instance where you absolutely need to have X-ray available and use it. So you do want, through your oral enteric catheter that you've placed, to basically create your volume distended target. You want to also define the anatomy. You really want to place this at the ligament of Treitz because that's where you have a natural ligament that brings the small bowel in apposition with the stomach. So take advantage of that. So identify where the ligament of Treitz is, and clearly in a patient like this, you need to be confident that you don't have blockage further downstream. So yes, this is where radiology plays a very important role. The other areas where I use X-ray would be the colodocal duodenostomy that you saw earlier, because we want to make sure that we are oriented towards the hilum. And then I do place a pigtail stent, but it's the only time I do that. And that is to prevent a sump syndrome. So I want to keep the opposite wall away from the distal flange. And then the other would be the edge procedure, because you want to make sure that you're oriented towards the pylorus and not the fundus. when you go through with your endoscope.
Fantastic. Okay, well, another case to show and further discussions to come up. I think we might have some slides for this patient. So this is a 78-year-old man. His third admission with acute cholecystitis. He does have important comorbidity, and I think our surgeons were particularly unkeen on the history of severe aortic stenosis and a significant abdominal aortic aneurysm. They turned to us not wishing to do a cholecystectomy, and so after imaging and review within our specialist multidisciplinary meeting, we proceeded to an EUS-guided gallbladder drainage.
So here I am with a 77-year-old gentleman with acute cholecystitis who's been deemed not surgically fit from the surgical team. We're going to do an EUS-guided gallbladder drainage. So I'm here in the bulb, just having a look, and my arrow at the moment is on the pancreatic duct and bile duct at the ampulla, and I'm going to follow the bile duct proximally, portal vein behind, cystic duct coming off, and then as we follow this more proximally again, up to liver there and the bifurcation of right-left. So I'm going to ask the team to start preparing the Axios kit, and there's a stone within the cystic duct or the neck of the gallbladder as documented on his axial imaging. So I'm going to follow the cystic duct on this occasion, follow it round. So this is thumb up on the big wheel and lots of anti-clockwise torque, and then the gallbladder is coming to view here. My pointer within the lumen of the gallbladder, and that's a nice distended, slightly thick wall gallbladder for us to place an Axios. I'm going to measure here and now just the width of the gallbladder wall to see if we need a 15mm or a 10mm saddle on the Axios. So I'm just going to pause and check with Doppler. Looks clear, no vessels interposed, and on measurement that is less than 5mm, which means a 10mm saddle is fine. And given that this chap has stones in his gallbladder, albeit small ones, I'm going to go with a 15mm rather than a 10mm here. We can discuss the merits of going back in to remove the gallbladder stent down the track towards the end. So here's my Axios down, I'm checking my settings. Step 1 on cauterization is just advancing the cauterizing tip. Before, I've already got a guide wire loaded in here, guys. So just hold it with the wire for the moment. And I like to deploy the distal flange first before manipulating my guide wire within the Axios, just to prevent a bile leak. So if you flare the stent prior to manipulating guide wire, it may just block the tract and prevent a bile leak a bit sooner. So there's the distal flange, step 2, and then I'm just going to pull that back to oppose the gallbladder wall as so, lock that in position, and at this stage I'm going to start advancing my guide wire. So just get ready with screening, folks. Yeah, just screen there. We'll keep it on EUS view for now rather than fluoro, and we'll start to see the wire coming through here. You can see that on EUS. Okay. And screening. Excellent. Okay, so that's plenty of wire, I think, and this will facilitate the placement of a coaxial pigtail, which is my practice. I'm just going to deploy the proximal ed flange now. So step 4, and then push out right torque. You see on this Fujifilm scope with the 3.8 channel that we're getting the stent out of the channel of the scope, and now we just need to please exchange. So I'm going to pull back on the Axios, just exchange over this Jaguar, guys. Okay, lock that into position. And now we're just pasting a 4cm 7 French pigtail. Just advance there, staying close, pushing with a 7 French pusher. Screen, please. Deploy the distal flange
That's a good position. And then the proximal flange. All done. And just take that picture. So the next consideration is whether we leave this stent alone. But it's my practice. He's not somebody with malignancy. He's frail, but reasonable prognosis in life. I would be my practice now to take this out in 6 weeks and use a gastroscope to clear the gallbladder of residual stones. Okay, so locks off and bridge off. Take that picture for me and scope out. Thank you very much.
Okay, we're whizzing through these interventional EUS cases, and I think we've still got one more to go. So, Bev, I'll just ask you for this. Again, a point that Ken Binmuller made is, be careful what we wish for in terms of taking on the work of others. The option for a patient like this who comes in acutely through casualty would be for, the interventional endoscopist to dive in and do EUS gallbladder drainage. Where do you think in real life clinical practice the role of the percutaneous cholecystostomy sits, which at present would be our usual way to go?
I mean, I think EUS, let alone interventional EUS, is not a commodity, at least in the UK, and I think it would be difficult in other sites across the UK to be able to find an interventional EUS practitioner who would be able to just attend and put in a percutaneous, a EUS guided cholecystostomy for us. But I think if this is the future, especially in someone who's presenting with recurrent cholecystitis, and if they're not deemed to be a surgical candidate, then I think it's a good option to just go in straight away with EUS gallbladder drainage.
Okay, and we certainly know that, the patients that we see walking around with a gallbladder drain for the next 6 weeks is a hell of an undertaking.
Exactly. There's a lot of data now to suggest that the morbidity associated with percutaneous cholecystostomy is much higher than with EUS guided drainage. I mean, the bile leakage, the pain that they get. There's also evidence to suggest that hospital admission rates are longer with percutaneous drains. So I think, there's a lot to go for going with EUS guided drainage for these patients.
Okay, and just briefly, Reem, we were talking offline. We've seen wonderful cases. We've seen wonderful advocacy for lumen opposing metal stents. But like anything, there are complications. Any comments you would broadly make about things that They say that an expert is somebody who's seen every complication in a narrow field. It's one of my favourite definitions. And
I agree with you. And Ken said it really well as well, that for each one of these, you have to have a certain skill set to do it, because you really need to know what might happen and how to get out of trouble. We saw with Gavin's EUSGJ, which is always like the most sort of harrowing of cases from all the aluminum opposing metal stents, is you want to see blue at the end, and you said blue, it's a boy. But you kind of need to know how to deal with those, the different types, either a perforation or a misdeployment, either towards you or away from you, how you can deal with a bleed that could happen if you hit a vessel or not. How to deal with the two main things would be, I think, the bleed and the perforation.
And I think both of you, or Gav, I think you particularly made the point about not losing access. So the advantage of having a wire in, because almost all problems are going to be that little bit easier to deal with if you've still got a wire across. I think we need to go to what I think is probably our last case, and then we'll have a little bit of time for discussion. So this is a very unusual patient, but I hope there's a lot to learn from it. 55-year-old lady who, back in 2016, had a cholecystectomy at which adenocarcinoma of the gallbladder was diagnosed. She had imaging that suggested at that time that there was metastatic disease. She did have a stricture, and so an uncovered mesh metal stent was inserted locally at that time, and then go forward 7 years, and she's had lots of problems with recurrent cholangitis, complex intrahepatic stones, an embedded uncovered mesh metal stent, and no retrograde access to the intrahepatic biliary tree via ERCP. So she had an EUS hepatogastrostomy into the left lobe performed by Gavin, but still has stones and still has obstruction. And the aim of the procedure we're going to see was to see if there was any way of us improving drainage antegrade down the biliary tree, and seeing if we could perform some stone management.
Doing this with Daniel Snyder, and he's the wheels.
Yeah, nice. Got a wire.
Well, look. So we're filling the right posterior, probably with stones in it. Okay, and again. Okay, so I think we go with spine next. Yeah. So let's do a nice balloon trawl and a balloon cholangiogram. So keep your wire. Screen, please. Can you come up the patient now? This is interesting, isn't it? Yeah, leave the wire in, come out with the cholangioscope. I think we dilate up the mesh. If nothing else. Oh, that's interesting. We're through there. Right, let's have some contrast in. Can you mag up, please? And let's inflate to 11 atmospheres. Oh, no, we're okay. So we've got a wire through the mesh of the stent on the right. Yeah, you can see the cholangiogram shows significant stone burden on the right down to that stent. Okay, using a 6mm Titan balloon here to try and open up the mesh. This is so frustrating. I just can't get this mesh metal wall flex stent through the mesh of the previous stent. So we're seeing if we can use here the 7 French plastic 10cm stent. See if this will go through. Yeah, okay. Well, that's as good as we can do, I think. So trying here to see if we can get a mesh metal stent through on the left through the dilated mesh. It just will not go. That is very frustrating. So we need to think again. So we've got a wire that we've passed retrograde back up the metal stent, through the mesh of the metal stent, into the left duct system, and then out through the HGS. So the next thing we're going to do, we're going to take this pigtail out. Close. Okay, all right, that's fine. So what I want to do now is I want to grab the end of this wire. Yeah. So we're right down the HGS. We're almost through the mesh here of the previous uncovered. There's no doubt that if we could get a stent of any description through this, we may, that would be a great result. The wire's nicely down in the duodenum. Right, okay. Okay, let's have the stent now. Try and put the antegrade fully covered stent in across the obstruction at the metal stent. Yeah. Screen, please. Okay. Moment of truth. Probably 2 millimeters, isn't it? That's all we're talking about here. Look at that for annoying. I mean, we could leave the wire way down in the duodenum, come come out with the duodenoscope, bring the wire through the HGS out through the mouth, put a white tube over it to protect the wire, go back down with the duodenoscope into the duodenum. You've then got a much stiffer...
because you're pushing straight. Right?
So rather than pushing the stent, you've anchored it. Come out with that. Can you feed the white tube over that? Just want that to protect the mouth, rather than doing any cheese wiring. Yeah, that's fine. Good, stop there. Right, excellent. Okay, let's just go back down with the duodenoscope. Right, okay, good. Yeah. Come back with the wire. That's good. Open the snare. Come back a bit more with the wire. Bit more. Stop. Okay, close the snare. Okay, now you'll hold the white tube and feed the wire. You hold the white tube and you feed the wire, yeah? To summarize. So what we have done is we've now got a wire passing up the metal biliary stent, through the mesh of the stent, into the left ducts, and then through the HGS, into the stomach, and back out through the mouth. We've protected the wires so that we don't get any cheese wiring with this 5 French white tube. But from experience, if we can stabilize this wire, it provides much more pushability. Stop. Okay, we'll get into position and then we'll put a bit of tension on. Right, now I need you to put tension on your wire. Screen, we're through. Right, let's not try and get too cute. So that's below the HGS. Okay, let's start deploying now. Keep deploying, keep deploying. Screen, please. That's fine. That's fine. Perfect. Good. Okay. Screen, please. And let's inject. See, good runoff down here. Yeah. That's good, isn't it? And then we can, that's fine. Take some crap back out through that. Leave that wire in. Down with the balloon. Let's have stent grabbers. Open. Close. Screen. Here we go. Keep screening. There we go. That'll be fine. So extraordinary case, really. We have, I think, achieved some major gains. We've managed for the first time to get access to the left-sided ducts from the extrahepatic biliary tree through the mesh of the long-standing uncovered mesh metal stent. By doing so, we've managed to get a nice fully covered stent into the left. That can be removed at a later date, but that means there's nice patency of the left liver. And we've taken out the HGS. I'm half tempted not to put anything back in, but I think we will for now. And the question is what stent we put back in, and I don't quite honestly know what the best thing would be. Should we put a nice long stent that goes right from the stomach down the extrahepatic bile duct? Or do we do what I'm going to do, which is just to see if I can curl this pigtail stent above that new left-sided stent? There we go. Well done. Very, very long, difficult procedure, but a great result in the end, actually. Hopefully, as a next step, if she needs more procedures, we can do so endoscopically into the left lobe. We've still got a problem in the right with respect to those stones, but, we'll see how we go. Great, thank you.
Okay, so a very unusual and slightly crazy case. I think it makes the point that we made yesterday as well of never putting an uncovered mesh metal biliary stent in without absolute certainty. This lady does not have malignancy. It was understandable why it was thought that this was metastatic malignancy, but it wasn't. But I think that the reason we could finally get a stent into the left lobe here was because of the previous HGS. And we're just in our last couple of minutes, Ken, but give us your views on where HGS may additionally be providing benefit. I know you've made some comments during your excellent talk.
Yeah. Well, my first comment would be there was reference to the management of patients with gastric outlet obstruction. For example, a pancreatic cancer that's obstructing the duodenum as well as the bile duct. And here it's very important to recognize that in these patients, the risk of aspiration is very high. And therefore, it is important to actually address the outlet obstruction first. And the best way to address that would be with a HGS. So in our practice, we are performing HGS first, and then we'll do the bile duct drainage afterwards. So that would be our first step. The other thing just to recognize is, and I think you've had this available for some time now, but you need cautery usually to dilate up the tract. And we now have, since a few months now, the 6 French cystotome available. So that has been hugely helpful. We still don't have all of the stents that you have available for HGS. And it's like any of these areas, we're always pulling something off the shelf and then using it off label. And we need dedicated devices. So I think we're going to see a lot of innovation in this area to facilitate the creation of HGSs. Just remember, the liver is not adherent to the bowel wall. These two organs are moving against each other. And so it's catastrophic if you have migration of the HGS. So here again, experience plays such an important role. You have to be sure that you have enough stent in the stomach so that when you get some migration of the stent, you still have enough anchorage in the stomach. So we need to think about stents that have better anchoring capabilities. Now, there are lots of ideas out there, but that's where I see this field evolving.
Okay, well, that is a fantastic moment to both finish our innovation session. Huge thanks from all of us, Ken, for joining us and giving your time. It's been an absolute inspiration. We've had a great couple of days here in London, and I hope that those attending from around the world have also enjoyed really covering both the diagnostic endoscopy that remains so crucial to the care that we give, the importance of intervention, but also a great way to finish with looking at what the future may be. We've pretty much run out of time now. I would just say to those who have an interest in HPB endoscopy, therapeutic ERCP and EUS, that if you wish to join us in person, May 9th and 10th, we have our first London Live HPB Masterclass, in which we will have the opportunity to do hands-on training with experts to discuss all aspects of HPB endoscopy, to watch again truly live endoscopy and really immerse ourselves in ERCP and EUS. So you just need to go onto the Gastro Learning site and find out more about that. I hope that you can join us in London. But with, as I say, we've run out of road. Huge thanks again to all the faculty, Ken in San Francisco. It's been a great honor, and to everybody who's been with us the last couple of days. Hope you've enjoyed it. It's been a great pleasure to be with you. Thanks very much.
Thank you.